Vamos dar início.
Good morning, everyone, ladies and gentlemen. So we're going to start out our CONASS debate. CONASS is the National Council of State Health Secretaries. I would like to thank everyone's presence, those who are here on site and those more than 900 subscribers that are watching us from afar. So following us on YouTube, I would like then to thank each one of you. So my name is Henrique Mansan, and with Philippe Ferrer, my colleague, we work with the Technical Chamber on Health Information Technology, and we are very happy to be able to start out on this debate. So having here on the table with me, Dr. Tânia Maria Coelhos, State Department from Ceará State, Deborah Milek, representative of the National Council of Health, and Dr. Eva Patterson, representative of the Embassy of Denmark, who I would like to thank for all the support given by the government of Denmark and all the support given to the digital health initiative here in Brazil. So for the initial remarks to start off the event, I would like to turn it over to the representative of the National Council of Health, Deborah Milek. Hello, good morning, everyone. President Tânia, on whose behalf, Fernanda Magano, we would like to thank everyone, CONASS agenda, and by greeting you, I would like to greet all the managers, workers, everyone that is in the front line that follow up on this important agenda we are dealing with today. I would like to share with all of you the understanding that being here today, having this dialogue on digital health, is talking about the future. A future that is based on public policies with a important influence over Brazil and Brazilian health. The national and the social control of the unified health system, the SUS, the Brazilian healthcare system, made up a digital health committee and health communication as well. And in this space created by the Technical Chamber, we hold debates on digital health, and we have some understandings. First, we understand that digital health is not a neutral stance, and it's not only technical, but also political, and we cannot debate digital health without democracy on the table. Along these lines, we understand the National Health Council that we should champion digital health as a state-run project where right to healthcare is beyond profits, a project where democracy trumps market interests. So that's our underlying understanding that today's activity will join forces, political and social forces, so that we can really have the digital health the Brazilian population, Brazilian state deserves, thus reinforcing our SUS. Great day for all of us. Thank you. Thank you, Dr. Deborah. I would like to turn it over to her initial remarks to the ambassador of Denmark, Ms. Peterson. Thank you very much. I would also like to congratulate Jurandi and President Dr. Tânia for the invitation and all the table, Dr. Deborah as well. So thank you very much for being able to be here. So Denmark is really has this long-standing collaboration with Brazil. It's marking 10 years now in 2026, and this is an important decade of this cooperation. And around this cooperation, this is data driven. We use data to make strategic decisions, thus our cooperation in this area. And along these lines, I would like to say that next week we're going to count on the presence of our health minister, Sophia Lud. She is going to come, she's going to land on São Paulo and going to come here. So we're going to offer her a reception March 3rd in the ambassador's residence. You are invited to be there and follow up on this discussion that we're going to have today. And know something that is important also in this government to government effort, it is important to consider research and development. That's why I see the importance of the professor Christian Noor of the University of Auburn, Denmark, that will also take part. And it is a pleasure to be here with you. And in this cooperation with Denmark, it's also important to consider digital health. So thank you very much. Thank you, Dr. Eva. I would like to turn it over to Tânia Maria Coelho, our president, for her initial remarks. Thank you, Dr. Tânia. Thank you, Nereu. Good morning, everyone. Good morning to everyone who's here, those who are following us from afar. I would like to greet all of you here on the table. And on behalf of Nereu and Zonadio, I would like to thank the organization, the technicians, everyone who's making this possible. So, Deborah, please convey my greetings to Fernanda. I am admirer of her work, and her words were very important. We're going to deal with digital health, but we can't lose sight of our focus is the patient, and it includes what you mentioned about respect and democracy. I would like to greet our representative of the Denmark embassy, 10 years of partnership with Brazil, so we hope 10 decades over. And then, so we would like to thank not only you, Ambassador, but all people who could support the partnership established with CONASS. So I'd like to greet some people who have been very important, who are always here with us, our Secretary of Rio de Janeiro, Cláudia, our Deputy Secretary of Mato Grosso do Sul, Cristine Nayara, our Secretary of Health in the state of Amazonas, Silvani, representative of São Paulo. Silvani, you are down there. You should get closer. Yeah, one more woman in the group, right? And I would like to say that we are very happy with this gathering in the state of Ceará. We have gained grounds a lot with digital health, but we know that challenges are very difficult to surmount because you're talking not only about the data centers, softwares, programs, and technical stuff, but we have to take into account equity, sustainability, as well as efficiency. Oh, when we talk about efficiency, we must take into account that there's no point in having all technology available if we don't have engaged people, a team that is really dedicated to make it happen. Otherwise, we won't be able to progress. So during the pandemic, we can say that there has been a leap, a 6-year leap forward in terms of telemedicine, something that had been uh, put on the margins. Even the Medicine Council wasn't accepting telemedicine, but COVID showed its efficiency. And nowadays, we know we had a very clear example in the state of Amazon's telemedicine made medicine reach the furthest points in the nation and the state of Ceará. We have our telemedicine system, which was inaugurated in 2024. We had 22 specialties available, and we have 27%. It means that 87% of those who have access to telemedicine, they have been able to solve their problems without having to go to major cities. And it is very important for us to organize our healthcare network and for regionalization matters. So we have this partnership with the state of Bahia, Diego, right? I always make mistakes, Diego, but anyways, Diego, in partnership with the departments, but there were some setbacks. Anyways, we already had a system Integra S8. So we integrate all data from the Secretariats of Health. In December last year, we had our system here to launch the system that is all in all states. We want to reach all states in Brazil. It's already present in 11. And we have been able to connect all systems. We created Click Saúde, this app, so that we must say the importance of the Ministry of Health that have been working a lot. So, Anastela Haddad, for example, the secretary, I must thank her because she has given support in terms of technological advancement in states and municipalities. So, through the healthcare network, we've been able to download all the primary care data on patients because we must have interoperability among the different various manifold systems, and we must make them available for work. Of course, many things evolved with telepep, for example. We showed that here in the past assembly, and we have been trying to evolve with some previsibility with epidemiological data so we can have more control over the outbreaks and epidemics, over patient records, what to do with patients so that we can speed things up without losing sight of quality. And what I would like to put forward to you here is that we cannot miss humanization, right? So today we talk about customizing, personalizing, individualizing treatment of patients, integrating our data, but we should have control of that because they're important to warn us, but we must be able to make all ends meet so that the healthcare is available for population as a whole. And we must also have clear that not always will we have the technical capability to reach all of our population with digital health. So it has to do with leadership, governance, and make everything that we think and create reach the front lines because we see the potential we have in order to transform people's lives, but we must make that happen. And today, particularly, I would like to say that we are in a very difficult period, which is the electoral year. And what we create in this seminar is perennial. It shouldn't be interrupted so that we can evolve more and more because the main problem during the electoral period, elections and so on, every 2 years we either change governor or mayor. So every 2 years we have elections, even if in different branches. And it entails lack of continuity. So we must work with state policies at a higher level, overarching level, so that we can make strides in the benefit of our population without losing sight of the human-centered approach. So I hope you all have a great seminar. I would like to thank the opportunity of being here with the president of CONASS, our National Council of State Health Secretaries, because this event is very important. So thank you very much, and I wish you all a great seminar. Thank you very much, Dr. Tanya. Thank you very much for all the support that you've been giving to our CONASS team in conducting here our work in the presidency that made also available the organization of this event. I would like to mention the presence of Michael Diana, our colleague from the National Council of State Health Department secretaries. And thank you for our presence and partnership in all the spaces for this kind of discussion. Michael is a person that gives us great support. So I think that this exchange of knowledge that we end up having CONASE CONASEMS with the CONASEMS contribution, this is crucial for the discussion where we have these tripodically discussions. So I would like to thank all of the components of the table, and now we go over to our data-driven healthcare panel. So this is an international panel, and I would like to call upon our colleague, Philippe Ferrer, who follows the digital health division here in CONASS. He was the idealizer and also the made huge efforts for these events to take place. So Felipe, great to have you here, and thank you for the partnership and for making this event happen. So Felipe, the floor is yours.
Good morning to all. To our technical team, we'll put our online. They are here through a specific link. I would like to that there's a link for the presenters, and there's a link in the CONASS page for those who are registered. We, while we put our speakers online, I will present myself and I will present our panel and Mr. Agostinho, who will conduct the debate. I'd also like to inform that the idea is that we have some time to take in some questions from those who are present. And if there is some question that comes virtually to me, I will try to do it. And I will try to do this moderation with Professor D'Agostinho. So I am Felipe Ferrez. I am Technical Director here at Ferraz. I will speak in the afternoon in a tripartite panel. I'm a pharmacist and I have a graduation in health, and I've been working for 25 years in IT in health. We have a technical chamber, one of 14 that is present here, one of our technical chambers. We had the technical chamber specifically, and now we have CONASS debate specifically of the technical chamber. That is why we feel very represented here. So I would like to ask to put on the screen, and I will, the debaters, and then I will present them. You can put it in the screen, please. So we have here a very heavyweight panel in health oriented by data. I like to inform that we have interpreters and they're translating into English and vice versa. We will hear the translation, and the idea of this panel, and it was formatted to bring a challenging theme for all countries, which is the value-based. We have operation means that very much oriented in payment for services, and the use sometimes above the necessary for the service. So we're trying to promoting radiography, tomography, and others, but we still haven't found a way to see how much it is solving, what is the result, what is the value added to that patient. Of course, we measured in currency and financially, but the value to the user. So when we talk about data based on value, we want to know the results. Of course, our speakers will put it in a more instrumental way, but it's the result. It's not only the glycemia that was controlled, but also the perception of the user. Can now I hold the glass? My vision improved. So it's very subjective as well. And CONASS has promoted about the health of the elderly. So we go there and measure how much the life of that person improved. It's not a laboratory exam, it's something very subtle. And how are we going to allocate resources to this? So how have they have promoted digital health? That is why it's the CONASS debate digital health. So we have that the data, the patient's data, and the clinical data, it becomes administrative, and we can put a budget on that based on rationality in therapy and resolution. So I can ask the speakers to open their cameras, but I will present them, and Agostinho will do our introduction. There is an order, but feel free to change it. I'm not going to speak in the specific order, but you can conduct it. So first, I will first Max Juppe. Apologize for my pronunciation. He's a professor of health economics and director of the Center for Health Economics of the University of York. He did economic of health, and um, Christian Noor is from Denmark, professor of health informatics from the Aalborg University, and in digital coordinates, interoperability, and national networks of digital health and research. And I'm very thankful of having taken CONASS in October, last October. And it was a fantastic experience. Ana Paula Edges, she's a production engineer from the South Brazil, from the PUC Rio Grande do Sul, master and PhD also, and with a postdoctoral in studies in epidemiology. And she's from the Institute of Evaluation of Health Policies, and also a guide she orients in the university that she graduated from. I also have Mauricio Barreto, a great friend. I said he doesn't need to be presented, but yes, I will have to. He's a doctor by the University of Bahia, a community doctor, epidemiologist in tropical medicine from the University of London, and founder and coordinator of the Data Integration Center from the Oswaldo Cruz in Bahia. And finally, our moderator and presenter, Mr. Marcelo D'Agostinho from Barro. He is a reference in digital health, and I'm very, very grateful for him accepting this challenge. And he accepted immediately in the contact here, and he was very attentive. He's the head of information systems and digital health unit from Barro and from the World Health Organization. So I would like to hand over the floor and the moderation to Marcelo D'Agostinho. Thank you very much, Felipe. Can you hear me?
Sim, dá para ouvir.
Tá bom. Então, não sei se na sala, se Felipe, você podia falar, confirmar que na sala
Could you
está tudo
confirm
certo
that everybody hears me?
para
If the
começar.
audio is okay? Yep. Mark Fisher. If he's not here, we can go to Christian Noor.
Perfeito. Muito obrigado. Uma
Okay.
honra para mim
So thank you very much. It's an honor to be here participating,
com todos
even if
vocês.
virtually, with all of you.
Uma honra sempre para mim poder
It is an honor for me
física ou virtualmente
to be physically or virtually
com colegas, amigos,
together
amigas do
with our
Brasil.
colleagues
E
from
esse é um
Brazil.
país que
Brazil is a
gosto muito,
country
eu morei lá
of which I like
há
very
muito tempo
much,
atrás e tenho grande respeito,
and I lived a
respeito e
long time
carinho
ago, and I
por
have a lot of
todos no Brasil.
respect
Então, hoje,
and
a
care for
primeira coisa
them.
que queria
So the first thing
agradecer
I would
e
like to thank
parabenizar a
is to
CONASS e a
congratulate
todos os
CONAS
organizadores deste
and all
evento,
of the organizers of this event,
principalmente pelo conceito que colocaram
especially for
de
the concept they put,
cuidados da saúde orientada por dados, não? Isso é uma
and
poucas
in
vezes eu participei em algum
healthcare
debate
via data.
com este
And very
foco,
few times
com
have I
este
debated with
ângulo que
this
dá
focus or
para
angle
entender melhor de que estamos falando quando
and
falamos
to
de
understand better
cuidados na saúde orientada
when we're
por
talking
dados,
about
não? Não
care,
estamos falando só de
healthcare
tecnologia,
through data.
que
We're
todo mundo
talking about
coincide com relação.
technology,
Estamos falando finalmente na capacidade
but we're
para
talking
melhorar
about the
os sistemas de
capability
saúde
to
nessa América, não?
improve
Todos os
the health systems in Latin America, as well as other countries. It seems obvious that data by itself doesn't transform anything. It has to be used to improve decision making and also fundamental to improve the use of artificial intelligence to issues with algorithms and inequalities. I'm not going to go into depth in these. They are great speakers here, so I don't want to take their time. But I would like to go a little bit deeper. And at the end, we're going to talk a little bit about what we're talking or what we're doing in OPAS, in PAHO, but to reinforce that there are many, many discussions within artificial intelligence. And this morning, I was talking with a vice minister that is coming back from the AI summit in India. And everything is around the use of data for many things, but especially for artificial intelligence. So we're here, we're talking about added value and also how it is necessary the digital public infrastructure and also digital sovereignty. There are many concepts that many years ago we wouldn't even put into discussion at the strategic and political level. It's always our director, Mr. Jarbas Barbosa da Silva. Every time he says, every time he's traveling, and each meeting he has with ministers of health or presidents, there is one theme that he always wants to put forth, and his theme is digital health, data in health systems, innovation. So congratulations, Felipe and other colleagues from CONASS, and I will start with a first question. The first question is to Mark. I'm going in the order they gave me, and I will start with a question. Mark, so a focus in the economy of health. How can you do the economic evaluation, or how should it develop with these systems that are so overloaded with artificial intelligence, that are improving and learning with the technology and with machine learning and continuously updating? So how do you see this concept of economic evaluation and how it should evolve in this digital transformation? So Mark, if you could answer us, I thank you very much. Go ahead, Mark.
Mark, can you hear me?
Mark, did you hear me?
Hello,
Okay.
are you talking to me?
Yes, I raised a
Yes.
question for you. I don't know you got the question. If not, I can repeat it in English.
If you wouldn't mind, I don't think unless I'm not sure how to get translation. So if you could repeat it in English, that would be great.
Yes, for sure, no problem. What I was saying is that how you see this concept of economic evaluation in this, let's say, digitalized world with a lot of actions and priorities related to artificial intelligence, but also with a lot of concerns about cybersecurity. So this concept of the digital transformation of the health sector, how do you see there the economic value of the data? So in that context.
Yeah, well, I certainly think that the digital sector offers opportunities to economic evaluation, and I've got a presentation I can share with you later on that detail. Ultimately, though, what I will be arguing is that data is not a sufficient basis for better decision making. We're trying to make better decision making, better decisions about how resources are used in health systems. Then we also need strong, robust methods to analyze those data and to link them to decisions. Now, in the context of cybersecurity, clearly an ongoing challenge to ensure that we have both high quality data, but also data that are safe, secure, and meet basic minimum requirements for our population in terms of having trust in those data. So huge potential, but we have to do an awful lot more than generate data to make sure we're exploiting those opportunities.
So thank you very much. And I have tengo una pregunta para los organizadores. Felipe,
I have
la
a
idea
question
es
for the
hacer
organizer,
una
Felipe. The
presentación
idea is to
con
make a
participantes,
presentation by the speakers,
moderar algunas preguntas abiertas. Mark, do
or
you
just to
have a
moderate some open
presentation
question.
also that you want to share?
I do. Do you
Okay.
want me to present now, or
Yeah,
do
go
you-
ahead, because I didn't know that there were also, we can make a mix of questions and presentations. So you have your presentation, feel free to share the screen and start with your presentation, and then I will continue with the rest of the panelists with one question plus the presentation if they have.
So I have scheduled these for about 15 to 20 minutes, which is what I was told. But if you would,
Yeah, it's okay.
if
It's okay.
you-
15, 20, between 15 and 20 minutes is okay.
Okay, let me see if I can share this then. Bear with me. Uh-oh, screen sharing has failed to start. Please try again later. That's a desperate, that's not a good thing to see. Let me try again.
Maybe you need.
Okay, what I'm going to suggest, if you don't mind, is that I'm going to reboot so I'm a co-host. Let's see if that changes anything.
Yeah, no,
No, still got the same code.
so you
When
don't
I've
have
had this,
permission to share the screen?
no, I do. I think it's a software error with Zoom. I think. When I've had this before, what I've done is I've rebooted my computer and tried again. So can I ask your forgiveness to log out of the meeting just for a couple of minutes, and then I'll come back in if you wouldn't mind.
No, it's okay. It's okay. We can start with. It's okay, Christian, if we continue with you once we wait for Mark.
Sure, just go ahead.
Okay, I will continue with you in English. I have one question, and then feel free to share your screen and your presentation. But the context of the question that I was curious about this, and thank you very much for your participation. Every time that I am with Dr. Ana Estela Haddad in Brazil, she refers to the experience that you have in your country. So very happy to be here and learn with you. So it's a very quick question. Is which one was the most difficult decision, not technical, related to governance that you took in Denmark to go towards interoperability in the health sector? If you want, you can answer that in the middle of your presentation, so feel free to answer and share your screen and start with your presentation as well.
But I think the short question is that it's the interoperability that is still the big problem, I think. And different things are done in that area, and I think we're making a lot of progress. But every time you turn one page, you find out that there are new problems that pop up. But maybe I'll get back to some of them during my presentation. So should I do that now, or
Yeah, please go ahead.
let's see if my screen can share?
Not yet.
Uh-huh.
No, and we lost. Oh. Are you there, Christian? No sé. I don't know, Christian, if you can hear me, or if you are trying to share your screen.
I can actually hear you, but it's because I have two computers on. But I'll just log into the meeting again.
Okay. Si no, pasamos a Ana Paula mientras esperamos a Christian y a Mark.
Yeah.
Yeah, you are in two screens right now in this in the Zoom.
Yeah, it's because I have two computers on, because otherwise I won't get to see what you can see.
If you can close the mic of one of the computer, because if not, it's coming with a little bit of echo.
Yeah.
Now we can see your screen.
Yeah, okay.
Yeah, if you can put in projection mode, will be better. Okay, perfect.
That's it.
If you see a virtual clapping, is that you are on the
Oh,
15 minutes.
Yeah, thank you for the introduction. As you can see, I'm a professor in health informatics at the Department of Sustainability and Planning at Aalborg University. Just to
She needed to close the sound in the other.
Population of 6 million people, very
Christian,
small. Sorry?
If you can mute one of the two computers, because it's coming with a lot of echo, the audio.
He closed it now. He's closing now. No.
No, you need to open one mic.
Is this better?
Yeah, much better.
Okay, so you are able to hear me now?
Yes, loud and clear.
Good. And just saying that we are a very small and organized country, only 6 million people here. We have the healthcare expenditures about 9.8% of the GNP, and it's fully funded by taxes. We have GPs, they are private enterprises in a way, but they're all on a contract with the public system. They work as gatekeepers to the healthcare system, and they are paid fee for service. We have about 27 hospitals in 72 different locations, 15,000 beds, and it's almost all public. Private hospitals don't have a very important role to play in Denmark. The hospitals, they are owned and run by 4 different regions, and the long-term and home care, they're run by 98 municipalities. And on the map, you can see you can see the country here, Denmark. It's attached to Germany in the south, and there's water up to Norway and Sweden. And on the other map, you can see the white spot there is Greenland. The healthcare system in Greenland is also run by the Danish healthcare system, and it's, as you know, it's not for sale though. If we look at the central trends and challenges right now, you see that 20% of the population, they have one or more chronic condition, and that's a rising number. And in 10 years, there will be 50% more elderly people over the age of 80% or 80 years. And also you can note that the citizens' expectations of the health services, they are growing as we become richer as a society. And then also you can see that that there may be a shortage of healthcare staff in the future. That's very likely. Another issue is the geographic balance in healthcare. I haven't translated all these numbers, but the figures just says that the doctors live where the people are less sick, and there are not many doctors in the areas of Denmark where people are most sick. So that's a geographical imbalance that is becoming a problem. And all these issues, they have been trying to be dealt with the new health reform that we're working on now. And it's a broad political agreement. If we go further into it, the aim of the health reform is to make the healthcare system deliver more equal, more local, and more coherent healthcare. So the more equal is including a better distribution of doctors and resources so that everybody has access to high quality health services, and also to work with the closer proximity where the less specialized and digital health services are becoming more dominant outside the hospitals. And also the context, which is one of the more difficult one, is to have coherent responsibility for patient care. So to sum it up, we want to reduce inequalities. We want closer proximity of health services and coherent responsibility. And all these three issues, the main issues, they require the use of digital technologies. So we talk about digital transformation of the health system, or more recently, that we work on a digital health transformation, because it has to be both issues that are worked with. And of course, there are a lot of optimism attached to that when you talk about digitalization and the use of data. And I think there is still some way to go. And I just put in this drawing that we made one day, and it came out very funny. That it's an AI-generated drawing. We asked them for a nurse taking a note in the medical record, and that's what the AI machines could come up with. And it's quite funny to see that the context of healthcare delivery is not there yet within the use of AI. But we have had national strategies for health informatics in Denmark since 1995. And what is characterizing those, they come every 4 or 5 years in a new version. And they haven't been very political documents. They have been very technical and focused on those who are actually working with it, but not the political side. And the last one has been stretched because it was planned to end in 2022, but now it's prolonged to 2025 and 6. And some of the examples of how the new reform will focus on solutions with these advanced digital technologies is that we want to have easy access to the healthcare system. And that means that we focus on digital first, or what is in many countries are called digital front door. It's something they work on and have been working on for many years in the NHS in the UK, but all the Nordic and Scandinavian and Nordic countries are also using this metaphor for how to approach the healthcare sector. And patients who can stay at home, they should stay at home, they will stay at home and not in the hospitals. And that requires further initiatives on telemedicine, telecare, and telehealth, but also something we need if we want to take care of people on the distance is advanced sensors. And it's a really big technical development area at the moment. And then the use of AI is also entering the healthcare in radiology to interpret X-rays, to find guidelines and handbook information in the hospitals, but also clinical documentation to generate discharge letters and summaries of what has happened to patients while they have been admitted to hospitals. And the recent examples that we have been confronted with is that the AI systems is very good in summarizing clinical events and put them up to a documentation. But so far they have only been looked at from the center point of view. Though the clinicians in the hospitals who write discharge letters, they are very fond of this technology because it gives them a lot of freedom to do other things. But when the discharge letters, they arrive at the GP, they get 2.5 pages of text instead of half a page, and they have to read through all this text that is very, it takes a lot of time and a lot of energy. So we really miss studies that are directed at how does the clinical work, or how do clinicians actually work with this technology. And of course, also data-driven healthcare is a big issue. But I think what is missing a lot is that there is a choice of what data is going to drive. We have so many data available, more than we can use, and it's very critical on what kind of data we are choosing to drive the healthcare. And then we have been struggling a bit with the terminology here, because if we not agree on what we're talking about, then it makes discussion and debate very difficult. So at least in English, we can distinguish between digitization, which is something that focuses on converting, recording data, and then digitalization. That's about developing processes and changing the workflow to improve the manual systems. And then digital transformation is something that where you enhance engagement and redefines value in all areas where you actually use it. So there are 3 different things we're talking about: digitization, digitalization, and digital transformation. And so just to make it clear what it's all about, we could look at this. It's a lion cub, and as time goes by, it will grow, and it will become a bigger lion, a faster lion, and a stronger lion. But the point is, it's still a lion. In contrast to the caterpillar, where when time goes, it will transform into something completely different, a butterfly. So the lion example is an example of IT-enabled organizational transformation, where the caterpillar and the butterfly is digital transformation. And the main difference is illustrated in this drawing, where you have the value proposition that is added to the flow of work here. And then one of my colleagues, he has been studying IT projects. In this case, about 6,000 different IT projects, many of them in the healthcare sector. So if this is 100%, then he looked at how many projects are actually on budget or better. How many keep the budget or project? And it's about 60% of them. But then if you look at who are actually keeping the budget and the time frame, it's only about 7.4% of all the projects that are on budget and on time or better. And then he looked also at which of these systems are actually delivering the benefit that we are looking for. And it's only 0.5% of all these projects that are delivering on budget, on time, and on benefits. And that's a bit sad because the budget and the time is something that we hear very often, and it's the main issue of management. It's those two parameters. But I think we should have a lot more focus on the benefits. Will they actually deliver on benefits? And just to show some studies that Ben Schneiderman he did in 2006, that the time lost to solve a problem by using computers in a healthcare environment was about 42.7% to 43.7%. And if we look forward into to fast forward into 2023, some of our colleagues from Copenhagen University did the same kind of study, and they showed that the time lost to solve problems were between 11 and 20%. It's a lot lower than in 2006, but I think it's still very high. 20% is almost 1 day a week that you just spend your time trying to solve the problem instead of just working with the problem in the healthcare IT system. And it's this overspending thing is a pattern. In many cases, it's actually a business model to do that, as it's easier to get forgiveness than permission. But it's very often based on optimism and say, well, we didn't make it quite right this time, but next time we will be doing it right. So there is a lot of what we call availability bias in running these projects. But there is also a uniqueness bias. If you listen to many of these projects and descriptions, they say this is unique, this is completely new, it has never been done before, and therefore it's more difficult and so on. But actually, if you study it, it's not very unique. I mean, most of the things that are being built today has been in to some extent been built before. And what is the most dangerous by this uniqueness bias, if you think you are unique, then you also inhibit the use of experience. And I think that's a very critical point in time. I'll just do this very quick. It's a normal way of illustrating communication. You have a channel and a source and a destination, and then you transmit the data into something that can be transferred. But it's also it's a model that have existed for many, many years. But if what we're actually striving to do is to move toward a data communication model where you have the source and the user, but the source is just putting the data into some kind of repository where the user can pick it from and make use of it. So this has been used in one example. I'll just go briefly through a shared medication record that we have in Denmark. It was because we had problem with many medication errors. We have medicine reconciliation was difficult, and the patients, they have no overview of their medication. So the implementation started in 2010, where we earlier just had paper-based communication between GPs, citizens, and the pharmacy. And then we switched to an EDI, a message-based drugs prescription system. And then later, as it is now, we have one central database for all medication in the whole country, and all the different partners can actually communicate with each other through this shared medication record, where central database is containing all the data, all the information. Yeah, I'll just go through. I think short in time, but we are building similar national systems in other areas as well. We have a referral hotel where it's a national database containing all referrals from GP to specialized diagnostics and treatments. We have a national database on test results, all the lab test results. and images, description of all the scannings and so on. We don't have the whole picture available, but the description of the pictures are available. And all this is actually built into a national system that are connected via the most important thing is the NSP you can see in the lower part, the National Service Platform, and it is very comes very close to the RNDS in Brazil. It's the same kind of functionalities, the same kind of ideas, and to have that platform and make all the systems talking to this channel is a key point in having the whole system running. Yeah, the main conclusion would be that implementation of new technology takes a long time. It takes a very long time to get all the users included, and we should strive to build better and more modern and also more sustainable systems. And then I think one of my key points is always that we should involve the users in the fundamental design process, because that would really help the usability of the systems. Yeah, I think I will stop here, so we can go on as well.
Thank you very much, Christian. Sharp 20 minutes. So thank you so much, and thank you for sharing an amazing concept. We are having this conversation also in Pajo about digital transformation, digitalization, digital health, and all around terminologies and concepts. So thank you very much, and I took note also the uniqueness bias. This is the first time I hear that, and I love it. So thank you so much. Let's see if we can come back to Mark, and then we will open for questions to all the panelists. So Mark, you want to try to share your screen? If not, I already your PowerPoint here.
Yeah, thank you. I'll give it another go. Let's just have a go here. Hold on. Bear with me. Right, can you see that?
Yeah, perfect.
Excellent. Okay. So what I am going to talk about is the use of economic evaluation that's driven by data to inform resource allocation decisions. So really the context here is that healthcare systems, particularly in high middle income countries, have in principle an abundance of data. In principle, that allows health systems to make better decisions about how they allocate resources. And economic evaluation is a broad set of tools to use those data to make better decisions. So to inform decision makers about which treatments, services, interventions are going to generate the greatest health benefit for the resources available. So I'm going to talk about what economic evaluation is. I'm going to talk about policy decisions and the types of policy decisions that are used, for which economic evaluation is used, types of evidence we need for economic evaluation. We'll talk about the importance of statistical modeling of data and the use of decision analytic methods. So what do we mean by economic evaluation? Well, the context of this is all healthcare systems in the world, in Brazil, in the UK, in every other country, are constrained in terms of their resources, their budgets. For every collectively funded system, whether that be funded through taxation, social insurance, the same applies. And all systems have already committed resources to a whole range of different activities, different services and interventions, each of which develop generate some sort of benefit for patients, but they do so at a cost. The way economic evaluation tends to be used generally is to look at investment opportunities against the background of those funding commitments. So typically in the world of health technology assessment, we're asking whether a new intervention, a drug, a medical device, a diagnostic, it generates benefit over and above what we currently do. That's the first hurdle. We must demonstrate that. Typically, though, for proprietary technologies, that intervention will cost us more. And because it costs us more, it displaces other activities. We can't spend a dollar twice. And so anything that's costing the system more needs other services to be displaced or funding not delivered to make financial room for the new intervention. So put simply, economic evaluation asks the questions about whether the benefits of new interventions outweigh these foregone benefits, which we call opportunity costs. And that sort of approach, what we might call incremental economic evaluation, is fundamental to health technology assessment, which is used in Brazil, many other countries in the world. This map is probably a bit out of date now, but it's used routinely, particularly in the context of medicines evaluation and medicines pricing, proprietary branded medicines. But if we look across a broader range of services and interventions that health systems offer, we see that so this diagram is trying to show that we do an awful lot of economic evaluation for branded drugs, quite a lot for medical devices and surgical procedures. But as we move from left to right on this diagram, you can see that some of the really important resource allocation decisions around, for example, service development, infrastructure investment, like system strengthening, system reform, staffing, decisions about staffing numbers and staffing mixes, very rarely is economic evaluation used to support those types of resource allocation decisions. But how can data be used, and how can data drive the use of economic evaluation to make better decisions? Well, we think about economic evaluation in terms of a range of different types of parameter, or different types of information. The foundation, if you like, is around clinical effectiveness. So is a new intervention or a new way of doing things better than the alternatives? So this is a comparative evaluation. And in clinical interventions, drugs, devices, procedures, we tend to measure that using clinical endpoints, clinically derived endpoints, and typically from clinical trials. But increasingly, as regulators are willing to accept less in terms of the rigor of clinical studies to make regulatory decisions, real-world data, routine data generated by health systems is being used to generate this clinical effectiveness estimates. But knowing something about clinical effectiveness doesn't tell us very much generally about the impact on longer-term health outcomes. We need to know that because we're committing resources for the long term. So survival duration is key to that. And clinical studies sometimes give us that information, but real-world data and national data on mortality rates, for example, are increasingly used to try and give us some idea about how new interventions can impact on survival duration. Costs, obviously, very important consideration in doing economic evaluation. And we need to understand the cost of the interventions, but also the cost of clinical events that the intervention may reduce or increase. So a new drug for cardiovascular disease, for example, in principle reduces the rate of non-fatal myocardial infarction and stroke, and understanding the cost of those types of non-fatal events are important in understanding the value of those interventions. And those data can be generated in clinical studies, but again, increasingly, we estimate those things from data routinely collected in health systems. And survival is not the only type of health benefit. Health-related quality of life is key to many types of services and interventions. And this is a challenge. Clinical studies do measure these types of endpoints, but are typically too small to estimate them with great precision. They're not collected in routine data. And so we rely on clinical studies, and often these data simply are collected very poorly. Now, I mentioned opportunity costs earlier, fundamental to any economics, but in economic evaluation in our field of health, we are we have very little evidence, but routinely available data now, so in a data-rich environment, allows us to estimate opportunity cost. So to be clear what we mean, as new interventions come into the system, we need to understand what that means in terms of foregone health to other people. If we're the most obvious example, a new cancer product, new cancer drug, costing a system 10 million, in a system with constrained resources, which is true of all systems, that 10 million has to be found by doing less of other things. If we do less of other things, then on average, we will reduce health outcomes for other types of patients. It's that exchange between the benefits of the new and the cost of the new and the foregone of benefits for other patients that we call opportunity costs. And there is research now available in a number of countries around the world, actually ongoing research in Brazil, I understand, as well, which estimates essentially how much additional spend imposed on a healthcare system reduces health by 1 unit. So we use the quality adjusted life year typically in this context. The work undertaken in the UK indicated that if additional expenditure is imposed on health budgets of 15,000 UK pounds, that will result in 1 QALY's loss of health for other types of patients. So we have this rate of marginal productivity, which we can interpret as an opportunity cost. Similar estimates in Australia there, every $28,000 additional spend in Australia will result in a QALY loss in overall health in the population. And the mechanisms through which these opportunity costs incurred vary by the system. In the UK, as we spend more on new interventions, the impact tends to be on things like waiting lists, staffing levels. In other systems like Australia, which is more insurance-based, it tends to have an effect through co-payments and premiums in insurance. But let's be absolutely clear, opportunity costs exist in all healthcare systems. But the types of parameters that we use in economic evaluation need us to be incredibly careful in how we analyze data. There is a temptation, I think, sometimes by having an abundance of data that we use it without care and attention. This is an example of a piece of work that's estimating essentially the risk of hip replacement failure. So patients have had new prostheses inserted, and there's a risk of failure over time, which we can express here between 2 different types of prosthesis, the spectrum compared to a Charnley prosthesis. The spectrum, the hazard ratio of 0.669 here indicates that it appears to reduce the risk of failure by about 30%. That's estimated from routine data collected in Sweden, registry data, and we can use that type of analysis as part of our economic evaluation. The challenge is that the Swedish registry, by definition, is not a randomized trial. There's every chance that there is a selection of patients, a differential selection to these 2 different types of prosthesis, and therefore there is a chance that we have biased estimates of the effect of the spectrum compared to the Charnley. So methods of causal inference are challenging to use securely with these sorts of routine observational data, But increasingly, we have methods and study designs that can allow us to be more secure in making causal estimates of effects from these types of data sets. And machine learning is increasingly used in that type of context. Here's another example of where statistical modeling is used on routine data sets. This is data taken from the UK NHS, our primary care data and hospital data, to look at the costs and mortality associated with ischemic stroke and bleeding events in patients with atrial fibrillation, and using statistical models to control for all available covariables that describe the mix of patients in the data set. So 50,000 patients in total here. It was possible to estimate the mean cost over time per patient for different types of event and different types of treatment. So these types of estimates are crucial when we're looking, for example, at the cost effectiveness of new interventions to manage atrial fibrillation. But we need more than statistical models as well. Estimating these types of parameters is not sufficient to support decisions. We need the type of analysis we call decision analysis as a way of linking treatment decisions or intervention decisions to the types of decisions we're making, the types of decisions I introduced earlier, which is essentially, do we introduce an investment that generates benefits but also incurs opportunity costs? So the use of decision analysis allows us to be explicit about the decision problem. What are our alternative courses of action that we're comparing? It allows us to be clear also about our objectives. Primarily, we're interested in improving population health, but clearly from a more policy perspective, there may be other things that decision makers are interested in. For example, not just aggregate health, but the distribution of health across different types of individual, perhaps defined by their socioeconomic disadvantage. Decision analysis allows us to link different types of data, different types of evidence from multiple data sources. So particularly where we have clinical studies, often undertaken by the sponsors of these technologies, that we're using alongside routine so-called real-world data sets. And these models allow us to be explicit about the uncertainty that decision makers face. We never have precise estimates of any of these types of parameters, however big the data sets are, and therefore we need to make decisions appropriately in the context of uncertainty. So key messages from the talk really are resource allocation decisions right across healthcare systems. They're taken every minute of every day, need evidence on benefits and opportunity costs. We know we can't apply those sorts of scientific techniques to every single decision, but to major investment decisions, particularly about new technologies, but also about things like about redesigning health systems in different ways, need those methods. Currently, these sorts of methods are only used routinely in medicines evaluation and some other medical technology. We should ideally be using them much more routinely for the large decisions outside of those sort of medical technology areas. These methods involve the use of different types of evidence, but we need appropriate statistical analysis and decision analysis to use the increasing amount of data we have available appropriately. I think the bottom line is that having more data is simply not sufficient. We need analytical methods, appropriate analytical methods to deal with those data appropriately. I'll stop there and stop sharing my slides. Thank you.
No, thank you. Thank you very much, Mark. This was really, for me, a masterclass, a lot of things to thought. So then I will make some questions around that, but I also love it that you frame at the end key messages related to this important topic. So thank you so much, Mark. Agora vamos passar para Ana Paula. Então, acho que vamos mudar para português.
Now
Então,
let's
muito
go
obrigado,
to
Ana
Ana
Paula.
Paula.
Dá para compartilhar a tela? Você tem uma apresentação também?
Sim, sim. Então,
Can you share your screen? Okay.
tá funcionando?
Sim, está perfeito.
Está bem, então. Bom
Is
dia
it
a
working?
todos.
Okay.
Muito
Good
obrigada,
morning
doutor
to
Marcelo,
all.
pela introdução,
Thank you much to Dr. Marcelo
pelo
for the
convite.
introduction
Thank you so
and
much,
Marcelo
Professor
for the
Mark,
invitation.
Professor Christian, for
And
introducing
thank
the
you,
topic
Max
with a
and Christian, for introducing the
very
topic.
insightful and powerful class. And I hope we can bring here a few perspectives from Brazil and what we are really doing locally. So I will speak in Portuguese, respecting the audience. Most of audience is a Portuguese speaker today. And later we can chat about the topic. So, voltando ao português.
So now
A
back
minha
to
intenção,
Portuguese.
ao longo da fala,
My
realmente trazer,
intention during this speech
perspectivas do
is
Brasil,
to
da
bring the
perspectiva brasileira
perspectives
e
of
o que temos
Brazil,
feito nesse
of what we've
tópico,
been
de uso de
doing in
dados
this
em vida real,
topic, and
explorando as
using
bases nacionais também,
real
e o que
world
outros
data,
países, têm
and what
nos
other
inspirado, na
countries have
perspectiva mais de
inspired us
estrutura de sistemas
in
de
perspective
saúde baseados
in
em
terms
dados.
of
Então, eu fui
systems based on
apresentada,
data.
acho que
I've been
essa
presented,
preparação
but
de ter
let
essa
me
aula
show
foi
me
preparada exclusivamente para
that
esse
this
evento
class
e
was
não tem
presented
conflitos
just
de
for this
interesses
event,
diretos,
and
com
that
o
there are no
conteúdo que
direct
será
conflicts of
apresentado.
interest on the content
Bom,
that will
a
be
agenda
presented.
que eu
The
pretendo
agenda
passar,
here, which I
ao longo
intend
desses
to
15 minutos
over
que
these
estaremos aqui,
15 minutes that
começa
we
então,
will be here,
com os atuais desafios,
starts
e
with
como os
the
sistemas de
current
saúde podem se
challenges and
beneficiar
how the
das
health
bases de
systems
dados existentes,
can
o
benefit from the
impacto,
great
de se
databases
estabelecer
available,
estratégias de
and the
saúde baseadas em
impact
dados e o que
on
tem já sido
database
feito em termos de
and what
políticas de
has been
saúde
done
nacionais e
in terms
internacionais
of
que possamos
policies, national and
mais implementar,
international,
ao
that
longo
we can
do nosso
implement
país.
around our
Eu trago
country.
três pontos que eu acho que
And I bring
têm
3
sido
points.
bastante externalizados, e ano passado, em alguns fóruns da Organização Mundial da Saúde, eles vieram também com uma
And these
força,
points were
onde a
also
digitalização
shared
pode
at
também
the
trazer
WHO
alguns
meeting. So
benefícios.
here,
Então,
digitization, some data for some
pós-pandemia
benefits.
e
Post
nos últimos anos, a
pandemics
gente tem
and
visto
over the
diversos
last
sistemas,
years, we
inclusive o
have seen
próprio sistema
many
inglês, se
systems and also
repetindo,
the English system that
que
has
viram uma
been
falha
rebuilding
acontecer ao longo
itself
do
because they
período
were
de
able to
crise
see this
internacional.
failure over a
Também
period of
outra
international
melhoria, a
crisis.
confiança
Also,
nos
over
sistemas
the
colocou
pandemics,
em
the
dúvida,
trust
e a
in the system
recuperação da
has been
confiança
shaken,
sobre as
and the
tecnologias, sobre o
recovery
sistema de
of
saúde, eu acho que é uma
confidence
busca
over
diária de
the
todos nós.
healthcare
O mundo hoje é
IT
digital,
systems
e a
is
saúde
a
também
challenge for all of
se
us.
está
Nowadays, the
digitalizada
world
cada vez
is
mais,
digitized,
concordo
and
com a fala
health
do professor Christian
follows the
anteriormente,
trend,
que nem
as
sempre tem sido
Professor
usado da forma
Christians
mais
says.
eficiente, e eu acho
Not
que
always
nós
will
temos
it be used in
papel
an efficient
realmente
way.
usado
So for
a
us, it
capacidade
is
de
a
análise e
role of being
digitalização
able
de uma
to
forma
analyze
bastante
the
eficaz e direcionada
digitization
que é valor ao
in
sistema de
order
saúde.
to channel it in
Frente a
order
isso, eu
to
acho que
create
a
value to
Organização Mundial da
healthcare
Saúde, a
systems. So
FAO,
based on
também
that, I
diversas
believe that
entidades têm
WHO
feito
and
realmente a
PAHO,
força-tarefa
several
internacional,
entities
e aí
have been
coloco aqui o Ministério também
joining
da Saúde, o
forces, and also the
WHO
Ministry
seja
of Health
envolvido,
of
no olhar,
Brazil.
para a gente
Just by
repensar
holding
os
an
sistemas
event
e
like
trazer
this, it will
soluções
help us to
realmente
rethink the
fortes,
system
que
and bring
explorem a
new
tecnologia
solutions
que
that
hoje
will
temos
explore
capacidade de usar.
technology that
Acho que
nowadays
uma
we are
frase
able
que ano
to
passado
put into
circulou em
motion.
alguns
A
fóruns, que
sentence
eu
that
trago aqui
circulated
para
in
refletir
some
algumas horas
fora
na
last
sequência, é a
year
segunda que está no slide,
is the
que
second on
coloca
this
como uma
slide,
contribuição
saying
de
that
dados
the
secundários
non-use
priorizados
of
do sistema de
secondary data
saúde
to
atualmente
innovate
pode ser
the
compreendido
healthcare
como
system
ético e não o
can be
contrário.
understood
Eu
as
acho que esse tipo de pensar o mundo
anti-ethics
de
and not
hoje
the
sem usar,
opposite. It's
quando
like
usar
thinking
dados
the
devidos.
world
Então,
today without using
realmente a
big
gente
data.
saber usar,
So it
com
is
sabedoria,
knowing
ética
how to use data
e
with
conformidade, os
wisdom
dados que
and
existem
in
hoje disponíveis nos
conformity
sistemas
with the
a
data that
nível
is nowadays
nacional,
available
regional e nas
at the
empresas
regional,
que compõem
national,
o
and
sistema de saúde.
international level, and
E
in
aí abro,
companies
então,
that are
a aula
engaged in healthcare
especificamente, com uma
systems. And
pergunta
now I would
sobre
like to
como a
open with a
criação de uma
question
estratégia de saúde
like this: how the
baseada em dados
creation of a
colaborar
strategy for
na
health
solução
based
desses
on data
desafios que
can
estamos vivendo.
collaborate in solving the
E
challenges that we've
brincando um
been
pouco com a capacidade
living
de
through.
dados, eu acho que
And
o
now,
dado
thinking
adicional
of
às
data
vezes
and
não se dá
additional
conta de quanto
data,
ele pode tornar uma
sometimes
decisão
we
muito
don't
mais assertiva,
understand how it can
uma
help us
brincadeira comum que a
make
gente
more
faz
assertive
com o
decisions.
avião, né?
A
Você pode
common
entrar hoje num
joke we do
avião
is like
e
boarding a
ficar com
plane. If
certeza
we
de
board a
que
plane nowadays and
o único convidado de
I tell you, the only data that I can give you is that we're going to travel 12 hours leaving Brasilia. It will be very difficult to have a good likelihood of estimating temperature and time of arrival. But when I add, for example, that we're going to travel for 12 hours going northeasternwards, we will probably go to some European city and we have a good estimate of temperature and arrival. And this shows how we can predict things with more data. It grows exponentially and has been used more and more for making decisions in healthcare systems. So when we consider the history, the clinical trials that were our only source of generating new evidence in the 80s and 90s, it has helped us nowadays when we put technology and systems into use in healthcare systems, and we can prove in real life of population that it can really work. And that's what our current studies of real life data will complement the common clinical trials that will be an essential source of evidence to make decisions based on data also. So what we must have here, and there is the positioning of eSport that was published 2-3 years ago. eSport taking its stance, for example, with real life data in a scale to make decisions in healthcare systems. I believe there are two important pillars here: transparency and reliability. When we start to advertise scientifically and post the scientifically validation among society as a whole, and it will generate impact, a new technology, a new way of structuring a system, what it has generated in terms of impact over the health of population. We can create a new way to communicate society, and it does work, and it generates that. So there is a relationship of transparency and confidence that permeates the use of available data so that we can make decisions in a better way and drive also population-oriented public policy. So as it is diffuse, I would like to focus on three pillars here, and also respecting the health managers that are present herein, so that they can maybe take advantage of some insights and how can they can use data available at data source and use that to make better decisions. So the first look will be over the process of technological assessment in health. So I would like to thank Dr. Mark that brought his perspective. So I'll take a deep dive into what that means to inform better decision making. The second point would be the proactive management centered on the individuals and resources, and take a look at the world. I would like to highlight that I'm going to talk about the US and England, what they have been doing in that regard, and also positioning their public health policies reform. So now, taking a look, I would like to trigger this question with some examples. We know the costs of not having technology embedded in decision making, and when we submit a new technology, most of the economic models, as Professor Mark has already brought up in his class, most of the models will incorporate costs data and efficacy data, costs data, take data from the Brazilian models. They use literature data, secondary data, and they don't reflect the real costs in the system, the cost of not having this technology. And an example that is quite recently was the incorporation of HeartMate in the Unified Health System, SUS, where we assessed the current costs in SUS of patients of heart insufficiency. So this was the submission criteria to the health department, and the cost of patients. They were using here data of an ambulatorial follow-up of insufficiency patients. So what we wanted to know in the research here was to assess in a cohort of 20 patients, for example, most of them a male, that were under remark under care with heart insufficiency, and they were candidates to the use of technology. So when we assess the real use, we assess here that the patients were costing on average per year $96,000. So we're talking about 250,000 reais per year. The cost of these patients, we had here patients with over half a year hospitalized, and this piece of information, when it is not made available, not accessed, well, it can really inform our decision making, right? So with this study embedded with the submission, Harper was incorporated, and now the technology is made available. So it marks an example of how to generate more accurate data, and the resources are very important to subsidize a decision that is sustainable. So the $120,000 or $96,000 are paid somehow by the unified health system. So the second approach here has to do with the management routine as secretaries. You know where the most efficient services are, the best results, and with the least resources consumed. So maybe here we have some benchmarks that could reflect the best management models with the data that we have nowadays. The answer I have here is yes, it is possible to be done. So here again, this is a non-scheduled program, but very happy coincidences. So here is ischemic a heart failure, as it was shown in the previous class, and here there is this paper that was published in New England with Brazilian data of public hospitals from Brazil, and we automated the collect of the endpoint of the patients in terms of cost. So we were able to create this management dashboard, real-time dashboard that could be constantly updated, helping to check the outcome of patients treated against thrombolysis, most severe, less severe, according to their clinical stratification, what were the results, how much they costed, and it allows us to see therapy benchmark hospitals. And the message here is, yes, it is possible to be done, and it can be implemented in hospitals all over Brazil with data we have available here. This study was expanded into Latin America, and then we start working with a cohort of almost 3,000 patients in most of Latin America, comparing variability of technology access and stroke treatment costs and possible variabilities of best therapeutical strategies. And here it was a little bit more handmade, artisanal, the data collection, but the message is, yes, it's doable, and it brings us a result that here maybe we have the most efficient ways to allocate resources hidden here in this study. See, these studies, they have a very good source, wealth of source, and this is a just a range here that will help us assess public hospitals, excellent, top-notch public hospitals, lots of teaching hospitals, trying to understand if there is an opportunity to reduce costs, reducing efficiency. In this case here, so we had 5 clinical hospitals. It has been a while ago we measured variability of costs in elective cholecystectomies, and this is a low complexity procedure. The expectation is that we wouldn't have much variability, but in practice, we found an expressive variability in terms of the procedure carried out in each institution. And when we analyze this, we estimate how much I could save per procedure. The hospital A worked in a similar way to hospital B, for example. So this kind of assessment is doable, but here $126 per procedure is not a significant amount. But when we take account the amount of daily procedures in Brazil, of course, that it amounts to a lot, and it's important to save. In the US, it has been done in an automated way. The example I brought, for example, we did a manual collection, but with data from the database of public hospitals, no data is not available. So in this case here in the US, we can automate these data extraction. In Brazil, in some institutions, it's already possible, so it's not something that is very far from us. But the message that I would like to bring here is that by doing this, we can scale up this kind of analysis. So this study was published in the past. We had data from 4 institutions that are referenced in the US. And then we compared procedures here of these Manguito surgery, and we studied the cost of prosthesis acquisition and the efficiency gains in terms of how surgeries are being done with 2 or 3 more surgeons, more residents in terms of teams, how long it takes, and so on and so forth. So this kind of technology has been saving a lot of millions of dollars in the US, given the easiness to identify the best practices and the best news is that nowadays we can see all hospitals in Brazil with data SUS data. So this project was led by Yatscare. So it was terminated last year, this project, but it allowed us with data source data to create a panel like this one, so we can see all over Brazil where it is available, the Weblin. The thing is that it has data up to 2021. I don't have data from 2021 onwards because it's a concept proof just to show it was possible. But nowadays, in terms of hospitals, so all of you who are here from each municipality, each hospital, you can also see your institution and volumetrics, consumption data, hospitalization time, cardiovascular procedures that are being carried out. So here we can have an outlook and compare variability all over Brazil. So these are data that are made available in our country, and we can work like that. And the last message that was shared in Professor Mark's class is that not only having available data, but also and mainly using it efficiently. And that last, I think that the most important topic I would like to bring up is look into other countries' situations. And there are several possibilities, but I wanted to link to the theme in point here of best practice. So I chose here the current one in the US. Then I will talk about the English one. But from January onwards, the program team is operational in the US, and I would like to highlight that this program was launched with all the metrics and functionalities in 2024, indicating that the American institutions would have to prepare themselves in terms of technological facilities to meet the requirements of this program. The major principle here is to change the remuneration model so that procedures that they are in a stepwise manner, but they take into account the 5 main surgeries, and all the logics of functionality includes a measurement of the consumption of resources, individuals per individuals, just in the case of the study of the rotator cuff, as I showed here. And in terms of efficiency, we keep the clinical results reaching the expected results for each of the outcomes, and bonus is shared in all teams. It's not concentrated to surgeons and hospitals only, but the gains are shared in scales with the multi-professional team engaged in the case. So it's one of the principles that's behind team. And another one that is indirect is that we start observing in the US as a whole, at the federal level, where we see the centers that are delivering more value, they are delivering best health outcomes with the least consumption of resources. Now, NHS in England, for example, it is the result of one of the major efforts. So this program, PLAKES, started out in 2016, patient level information and costing system. So offering to institutions how to implement this kind of technology and allowing a knowledge into the financial details, even if it's been out for 10 years. I think that the challenge here, and people here from the US, we can also discuss this, but the tricky here is to use this information for better decision making. For example, resources allocation within England. I would even like to listen from Professor Mark a little bit how it works, but it is kind of old, 10 years already, but it helps an accurate perception of costs for the best decision making. And of course, that I have to mention here the English reform that was advertised halfway last year, so it shows the migration of analogical to digitization. It's the first pillar of the reform, expansion of the service, the from hospital to the neighborhood, so being closer to population as a whole, closer to community, with an expectation that it will reach excellent centers, so the patients that have to go there, so it corroborates in the reduction of queues, of lines, and it improves the English national health system as a whole that has been suffering a bit. And I use this system as an example when I started the class. We know that we could use other countries, but these are benchmarks of what to do best with the resources at hand. So I believe that if we don't use in the best way the data that we have in terms of clinical outcomes or patient outcomes and economic data, if we don't take them into account, we can discuss contemporary remuneration models, sharing risks, contributing to the sustainability of the healthcare system. So it's at the base of the system. So it's being used by us here, managers, health managers, so that we can have a more efficient healthcare system.
Muito obrigado, Ana Paula.
So thank you, Ana Paula.
Excelente, mil cosas interesantes
So
para
excellent,
comentar.
many interesting
Y
things
con una cosa que usted
to
falou, que es
take.
el
And
costo de no ter incorporado
so
tecnología,
what's the
¿no?
cost of
Entonces,
not having technology
¿qué
embedded?
acontecería
So I
cuando
always
alguien
think
no
what would
avanza
happen
na
when
transformación
someone
digital,
doesn't
¿no? A
really
veces no
take
hacemos esta
strides in
pregunta,
terms of
¿no?
digital
Y
transformation. And
toca
we
temas
don't pose the
fundamentales,
question, right? So this is a fundamental
confianza y
question.
este tema del mundo digital, ¿no?
Confidence in
No
the
siempre
digital
planteamos en
world.
Europa qué
So we
significa
always wonder
posicionar el
at the
sector
PAHO
salud en el
how
mundo
to
digital, ¿no? Entonces, muchas
position
obrigado,
this in
Ana
the
Paula,
digital
por
world. So thank you very much,
hacer
Ana
más
Paula.
preguntas. Entonces, ahora sí
Then we're
paso
going
también
to
la
make a
pregunta
question. So I
al
also have
doctor
the pleasure
Mauricio
of
Barreto. Mauricio,
having
você
Dr.
está,
Mauricio Barreto.
a ver, está con una presentación también para compartilhar.
You have one presentation to share
Sim, estou
too?
com a apresentação.
Ok,
Yes, I have the
muito obrigado.
presentation here.
Antes de começar, queria falar também que
Okay, thank you
professor
very
Maurício
much.
Barreto é
Before
muito, muito
starting,
querido
I
e
would like
respeitado
to
aqui
say that
na
Professor
UPA.
Barreto is very well
Praticamente não tem
respected here
reunião
in
que ele não
PAHO.
menciona
There's
a
no
Maurício Barreto.
meeting
Muito obrigado e
where
agradecer
Mauricio
também
Barreto
compartilhar
isn't
este
mentioned.
momento
So
com
thank
você.
you very much for
Prazer,
sharing
prazer.
this moment with
Muito
us.
obrigado.
Thank you as
Eu
well.
também vou
And
falar em português,
I
como
Ana
Ana
also
Paula,
speak in Portuguese like
infelizmente,
Ana Paula,
mas eu acredito que tá,
but
a
I
tradução
believe
está
that
funcionando,
the
os
translation
colegas
has
da
been working
tradução.
well for the
Bem, eu sou
colleagues from abroad,
epidemiologista,
right?
né?
So I
Então,
am
meu
an
foco é um pouco
epidemiologist,
diferente. Eu
so
acho
my
que a questão
focus is a little
central do
bit
debate
different,
aqui
even if the central
também
issue
eu
of
vou
the debate at
tocar
hand,
isso
and
profundamente,
I
é a
am going to touch on
disponibilização
that,
massiva
which
de
has to do
dados,
with
né?
the
Para
massive use of
produção de
data
evidências.
for
Eu vou
producing
colocar aqui minha
evidence. So I
apresentação
will share
em
here
forma
my
de
presentation.
rapidamente. Aqui. Tá ok?
Okay?
Marcelo?
Sim, aí dá, perfeito.
Tá. Produção de
Okay,
evidência
perfect.
uma coisa à
So
parte
the
de todo o
evidence
arcabouço
production
científico, né?
is
Ele
something a
apresentou
part
aqui
of
casos
all
excelentes,
the
né? Seja
scientific
na Inglaterra,
effort, and
seja
we
na
have
Dinamarca,
excellent
seja
cases
no Brasil,
either
né?
in
A
England or in Denmark
necessidade,
or
o
in
sistema de saúde
Brazil,
precisa
and
muito de
the healthcare
evidências, né?
systems,
Esse é
they need evidence,
uma
right?
das
So
áreas
this
de
is one
aplicação do
of the
mundo, né? Que há
application
uma
areas.
necessidade
There is
permanente
a
de novos
permanent
conhecimentos, enfim, novas
need of new
evidências, né?
knowledge, of
Para
new evidence
tomadas e sofisticar todo o sistema de
for
tomar decisões
refining all the
seja esse
decision
tomar
making
decisões.
systems,
Então, eu acho que nesse
whichever
ponto a
level it
gente também
happens.
se
So I
conecta, né,
believe
com
that at
as
this
falas
point we
anteriores,
connect
né,
with
de
the
alguns outros
previous
debates.
presentations
Mas eu,
that were
com
shared
pouco
here. But
tempo, eu vou
as I
focar
have
num
little
problema
time, I would
que
like to
nós
focus
estamos
on an
trabalhando e
issue
demonstrar
we've
aqui
been dealing with,
alguns
and I would
resultados
like to share some
dessa
results
abordagem,
of
né?
this struggle with
Todos
you,
sabem que os
right?
estudos de
So
coorte são
you all know
estudos
that
essenciais
cohort
na
studies
produção de
are
evidência em saúde,
crucial
né?
to produce
Quando se quer
evidence
conhecer
in health
questões em
studies
saúde
when we
da
want to
população, de uma
know
população,
population
os
health
estudos longitudinais, os
issues,
estudos de
the
coorte são muito
longitudinal
semelhantes, né?
research
Eles são
approaches
métodos
or
usados
cohort
na
studies. They are
epidemiologia, na
methods
pesquisa em
used
saúde em
in
geral, mas
epidemiology
também em
and
outras
health
áreas como
research as a whole, and
economia,
other areas as well as
sociologia, educação, né?
economics, sociology, education and studies that are applied in other fields of knowledge. But normally there is a series of advantages, and I am not going to go into detail.
Mas ele é muito usado como método, né, porque ele tem uma série de vantagens, né, em comparação com
But
outras
it is very used as a
né?
method because it
Porém, claro,
is
também tem
used in
suas,
comparison with
suas
other
limitações e
methods,
problemas,
but
né,
there are
enquanto
some
tem uma série de vantagens, né, porque ele
limitations.
seja um método
And then
muito aplicado, né? Só que normalmente, né, o processo de produção ou de construção dos estudos longitudinais
Of
de
the
coorte
construction
é
of
feito com
cohorts
dados
is done with
coletados primariamente,
data
né? Essa
collected
é uma
primarily.
característica normal
This
quando a gente
is
pensa
a normal
estudo de coorte,
characteristic when we
normalmente,
think
né,
about cohort
a coleta
studies.
de dados primários. Nós temos
The
casos
collection
exemplos,
of
né, em todas as
primary
partes do
data,
mundo,
we
inclusive no
have
Brasil, de
examples in all
coortes muito
parts
bem
of the world,
consolidadas, né?
in
No
some
caso do
very
Brasil, o nosso coorte
consolidated,
do
Elsa Brazil,
nascimento de Pelotas, né?
and the one from
Que
Pelotas
produziram e
that
continuam produzindo uma
produce,
quantidade
continue
imensa de
to produce
conhecimento,
immense
mas que
quantity
são
of
feitos com
knowledge,
dados
but
primários, né?
they are done with
Com
primary
todas as
data
vantagens e desvantagens desse
with all the
processo, né?
advantages and
E,
disadvantages
evidentemente,
of
você
this
tem uma
process.
alternativa,
And
né, que é a
evidently,
utilização
you
dos
have an
dados, né? Dos
alternative, which
dados
is
que
the
já estão
use of
coletados no
data
sistema de
that
saúde,
are already
como foi
collected.
colocado aqui,
And
principalmente
as
por
the
Ana
way it was
Paula,
put
né?
here,
Quer dizer, o
especially by
sistema de
Ana
saúde
Paula,
brasileiro tem uma tradição de produção de
there
bons
is
dados,
a
né? Isso eu
tradition of
queria
the production of good
reafirmar aqui,
data.
né? Às
And I
vezes
like to
nós
reaffirm
entramos
here
nessa categoria de
that sometimes we come in
low
this
income countries, né?
of
Quando se diz
low
Brasil
income
ou outros
countries
países como se
in how
fosse,
we
né?
classify their
Mas em relação a
countries.
dados, nós temos uma
But in
tradição
terms
muito
of
grande de
data,
produção de
we have
dados,
a
até às
big
vezes
tradition of
excessivos
data
dessa
production.
modalidade
I
de
would say even
informação.
sometimes
Devemos
excessive.
agradecer em parte à própria OPAS,
We have
Marcelo,
to
da
thank
tradição, né, que a
OPAS
OPAS incutiu, né, na
that
qualidade dos dados de
in the
saúde. Isso foi muito
quality of
importante, né, de registros, né,
data,
de
health
criação
data, and the importance of creating a registration
padronização de registros
and
e outros princípios que
standardization.
foram fundamentais para essa cultura, né, de qualidade de dados de saúde. E, evidentemente, o Brasil, com um país de mais de
And evidently,
200 milhões de
Brazil,
habitantes, a
with over
quantidade de dados
200
produzidos
million of
é muito
data,
grande.
the
Só que esses
quantity of
dados normalmente
information
estão
is very big.
em silos, né, separados,
And
né?
usually
Eu
these
acho que
are in
qualquer um que
silos.
trabalhe
And
nessa
anyone
área, um dos
who
grandes
works in this
problemas que
area
encontra é exatamente a conexão de dados,
is
né?
the connection of data.
Talvez a Ana Paula não tenha falado, mas
Maybe
ela
Ana
pode
Paula
ter dito que
hasn't
ele deve
said
ter
it,
tido
but I believe
problema de, poxa, essa variável seria ótima se
that this
tivesse dados,
variable would
mas
be
está em
very
outra
good
base de
if I had
dados
data,
e
but
tal.
it's in
Então,
another
esse é
database.
um problema, né,
So
que
this
se
is a
resolve em
problem
alguns, com
that
algumas estratégias de
we
investigação,
have
como
some
os
strategy,
estudos
investigation
ecológicos, os estudos de
strategies
dados agregados, né, que
with
podem
ecological
agregar esses
studies
dados
or
no
data
nível
aggregate studies
geográfico, né,
at the
e isso é possível,
geographical
não há nenhum
level. This is
problema,
possible.
mas
There's
a
no
nível
problem.
individual isso cria alguns
But at the
desafios e alguns
individual level,
problemas, né,
there's
que eu
the
acho que esse é um ponto
challenges
central e importante que vem
that
sendo
is a
discutido
central
em vários
issue
países do mundo, né, que
and
é
in
como
many
realmente
countries in the
ampliar e
world, and
amplificar
how
a
to
utilização
amplify
de
the
dados, né,
use of
dados do mundo
data,
real, dados
data
administrativos,
of the real
de várias
world, administrative
denominações, né,
data. There are many
ou
different
dados de rotina,
definitions,
né, e
or
que
routine
se
data,
utilize esses dados de
where
forma
we use this
organizada e
data
tal.
in
E
an
claro, com o
organized
crescimento
manner.
do volume de dados
And of
produzidos,
course, with
né,
the
nessas
volume
áreas
of
mais especialistas como
information
da saúde,
created,
isso se
but
torna a
especially in the
informação
health
muito mais
sector,
complexa, né? Os
this
desafios, quer
creates
dizer, a
omission
quantidade de
even more
informação que o sistema de saúde
complicated. The
deposita, de
quantity of
todas essas
information
formas, né?
in
Para
various
cada
shapes and
indivíduo que
forms for
passa
each
pelo
individual,
sistema de saúde, são quantidades imensas, né, de
these are
dados que
immense
crescem, né,
quantities
a
of
nível
data that
estratosférico
grows
e,
at
claro, isso
stratospheric
cria
level.
novos
And of
problemas,
course,
né?
this creates
O,
new
a
problems.
integração desses dados, eles têm
And the
vários
integration
desafios,
of this
né?
data,
Que
there are
eu
many
também
different
vou citar
challenges,
aqui rapidamente,
which I
né?
will
Desafios
mention quickly.
tecnológicos, né?
Techno
Desafios
technological
do
challenges
manejo da
of the
acessibilidade, né?
management and
E, claro, o desafio da
accessibility,
privacidade,
and of
né? Esses
course
são
the
desafios complexos, né? Que
privacy.
quem
These are
maneja esses
complex
dados,
challenges
né?
that those who manage this
Enfrenta
data
diretamente, né?
and face
Desafios que,
directly
tendo em vista a importância disso, né? Os
as
países estão
having the
criando leis de
importance
proteção
of
de
these.
dados, né?
But
Hoje
countries are
nós temos
creating data
já temos
protection
aqui
laws.
no Brasil nós
in some Brazil, we have a data protection law that's been created many years ago that somehow regulates in the legal way the use of these databases when we want to fragment and to have it at the individual level. Another necessary thing is computation. The first speaker talked about the challenges in that sense. Of course, computational system modify. I'm a researcher, and to do research with these big databases, the computational, you have to go from microcomputers to big servers and new softwares, new routines that have been developed to create this world of what we call big data. Other thing is the management of this data, governance of this data has to be done, and it is complex. There is a system of governance and management of that data. Of course, the Ministry of RDS and other systems are developing and improving these governance systems. And of course, they're more sophisticated and more delicate in this process of creation is the governance of data, and the other in how to connect and link or connect these data sets in each context where they have their own ecosystems to improve these connection systems. Brazil will at some point will have a unique number for each individual, but until now, many of our systems are not based on a single number, which or a ID. You can still use other elements to connect to with high level of efficiency. So in this context is that we have an experience where we have a SIDAX. We developed something which we call a cohort, totally set up with data of the real world. So it connects data from one system, from a single registry that register all Brazilians or any family that want to apply to one of the social programs and connected from the same to health systems. So we created a structure that has over 140 million people in that cohort. These are huge numbers. To get to these numbers with data collected primarily. And another cohort is the birth cohort that has over 30 million, and it's similar that we use the basis, not only the single registry, but the CONASS. So based on those two cohorts that are within a center that works here in Salvador, if you're not from Brazil, Salvador is in the northeast of Brazil, near the sea. I have a round circle showing where it is, and it stays in the capital, Salvador, and it manages this system, has high security classes, and to manage these quantities. And many government agencies, especially the Ministry of Health and other ministries that send these data with high level of secrecy so that they can be operated in our systems. And it has been possible to produce a great number of investigations at the many different areas. There are groups with different academic issues that are being answered with these databases. And the principle of these cohorts
a questões científicas, muitas delas de alta
to
relevância
respond to
e
scientific
importantes no
issues
sentido de produção de
that
evidência
are
para
very
vocês.
relevant
Eu
scientifically
vou
and relevant
colocar
to
aqui
the health
algumas
system.
áreas rapidamente,
I'm going to
né?
put some areas here very quickly,
Que em especial que tem
and
muita aplicação,
especially
né?
that
Por
has
exemplo,
a lot of
investigar fenômenos
application.
raros ou fenômenos
For
de baixa
example,
frequência.
investigating rare
Nós
phenomena
temos
or
de
very
muita
low
dificuldade, mesmo numa
probabilities
população
in
Brasil, com uma população de
in
200 milhões de
Brazil.
habitantes, de
With 200
entender
million inhabitants, we
determinados
have
fenômenos, né?
difficulties
Como
to
é que eles
understand
acontecem.
certain
Essa é, por
phenomena.
exemplo, aqui uma
For
incidência de
example,
tuberculose,
an
né? A
incidence
tuberculose,
of
ela é uma
tuberculosis.
doença ainda recorrente, né?
It is a
Importante no nosso
recurring
registro epidemiológico, né? E o
disease
domicílio é
here,
dos
and
focos, né, de transmissão.
and
Se
where you
pensava
live,
hoje, se
the
pensava que
household
nós
is
tínhamos
one of the
já
focus of
resolvido o problema do
transmission. We
domicílio,
thought
né?
we
E
had
com as
solved the
ações
household
que o
issues,
sistema de saúde
and with
tem,
the actions with
reduzido a importância e o peso do
the health
município,
system
né?
had,
Na
and we
transmissão
reduced
da tuberculose. Mas vocês veem
in the
aqui
weight in
que
terms of transmitting tuberculosis.
a
But
nossa
as you can
coorte
see
e a
here,
possibilidade de
our
juntar milhares
cohort
de
and
casos
the
de tuberculose
possibility of
com
joining many
aqueles que ocorreram
cases
no
of
mesmo domicílio,
tuberculosis
quer dizer, é
in the
possível
same
reproduzir
home,
análises,
it
né,
is
ou segundos de
possible to
análise,
reproduce
que
analysis
mostram que ainda,
that
né, o
show
caso que ocorre no domicílio é
a case that
precedido por um
happens
risco
at the
16
home
vezes maiores, né,
is
maior
16
de
times
ocorrência de um
greater
segundo caso de
of
tuberculose.
a second
E quando
case of
essa
tuberculosis.
criança é menos de 5 anos, essa pessoa tem
When
menos de
the
5 anos,
child is
esse
less
risco
than 5
chega a
years, this
62
incidence
vezes maior,
is
né,
62
de
times
transmissão.
higher
Um
of a
problema que a gente
chance of a
pensava
transmission. So
resolvido,
a
né, ele
problem
não está
that we
resolvido.
thought that was
Ou
solved was
trabalho
not solved.
recente que saiu,
And a
acaba de
recent
sair,
work
mostrando uma questão
showing the
similar com risco
issue,
de
a
suicídio,
similar
tá? O
issue
suicídio
of suicide
ocorre num
risk.
domicílio, né?
It
E o
happens in
nível
a domicile.
terapêutica de ação
And
que deve
what
ter
is the issue
nesse
of
domicílio. Vocês veem
therapeutics?
aqui que nos
And you can
próximos
see here
anos, né, nos
in the
próximos
next
poucos anos
years
após um primeiro caso, que tem uma
after one
chance
case,
4 vezes maior
there
de
is a
ocorrência de um
chance
segundo
4 times greater
suicídio
of
no
having
domicílio.
a
Então
second
mostra
suicide in
que o
that
sistema de
household.
saúde tem que dar uma
That
atenção muito
means
maior,
that
né,
the health
em
system has to
termos
give
de
more
quando
attention
ocorre um caso
of when a
dentro do
case
domicílio.
occurs
Ou
within the home,
estudar mortes de uma doença
or to
específica como
study
chikungunya. Chikungunya é
deaths
uma
in a
doença
specific
que hoje
death
está
like
afetando, começa a
chikungunya.
afetar a Europa também,
It is
né?
starting
É
to affect
vírus
Europe.
transmitido no
It's a
Brasil pelo
virus
Aedes
transmitted in Brazil
aegypti,
by
né?
the
E
Aedes
que esse
aegypti,
vírus
and
ele
this
causa uma doença
virus
aguda, depois tem
causes a
sintomatologias
serious
crônicas, mas você conheceu
disease,
muito
and then you
pouco
have
sobre
other
o que
symptoms
ocorre
that are
a
chronic,
posteriori
but
do sintoma
you
agudo,
didn't
né?
know
Então foi
very much
possível
what happened
demonstrar, né,
after
que
the acute
a
symptoms. And
incidência,
here
uma
it was
mortalidade, uma
possible to
sobremortalidade
show there that
extremamente
there's an
acima, né? Mesmo
overmortality that is
após
excessive,
a finalização
even
do período agudo, né? Ele
of
se
the
propaga
acute
por
phase.
muitos meses, né? Após o
It
sistema agudo, ele
propagates through many
continua com
months
a
afterwards
sobrecarga de
and
mortalidade
has
em
a overload
pacientes que
of
foram originalmente
mortality
infectados por
in
chikungunya, né?
patients that
Principalmente para
were
aqueles,
originally
claro,
infected,
que tem já
especially
alguma
those
doença associada como
have
diabetes
some kind of
ou doença
disease
isquêmica do
like
coração, outras
diabetes
coisas,
or
né?
ischemic
E
and
estudar
others,
em grandes detalhes, né?
and to
Padrões de
study in great
mortalidade da
details
Zika. A Zika foi uma infecção
mortality
que ocorreu
patterns
no
in
Brasil,
Zika.
né? Nós
It is a
tínhamos
disease that happened in
possibilidade de
Brazil.
ter nos nossos
We had
sistemas,
the
né? Todos os casos,
possibility in our
praticamente todos os
system,
casos conhecidos de Zika no
all of the
país,
known
né? E
cases
com
of
isso estudar
Zika,
os padrões de
and to
mortalidade, né?
study
E
this
ter muitos
patterns of
detalhes sobre
mortality,
os padrões de
and to have a
riscos,
lot
né?
of details
De
about
mortalidade
risk
associadas
patterns
com
of
uma doença como a
mortality
Zika, né? Isso
associated with
evidentemente é
Zika.
uma evidência importante,
Evidently,
né? No
this is
sentido
an
de
important
pensar não só
evidence,
os casos atuais de Zika, né? Que estão evoluindo, mas
the cases of
futuras
Zika,
epidemias, né?
but
Como
future
pensar na
epidemics,
questão da prevenção, do
like the
tratamento, das
issue of
abordagens
prevention,
associadas,
treatment.
né? Eu vou passando aqui porque tem aqui
I'll go a little bit quicker.
ainda nessa ideia
Still in this idea
do evento raro, né?
of a
É
rare
muito
event,
interessante porque
it is very interesting.
quando a criança nasce, ela tem uma série de riscos associados, né?
And
O
there's
bate-peso é
series
associado
of
ao aumento de
risks
risco de
and
mortalidade,
weight
pré-termo é
and
associado ao risco
mortality,
de mortalidade, né? Mas
risk
quando
of
você junta
mortality.
tudo isso,
But when
né,
you
e
join
coloca,
all of
né,
that and you
todos em
put
conjunto, né,
all that jointly,
crianças que nascem com essas três, né,
the
com baixo
children who are
peso
born
com
with low weight
pré-termo, eles têm um risco
and
de óbito
they're early,
62 vezes
they might
maior
have
do
a
que
risk of death
né,
62
uma
times
criança que
greater
nasce em
than a
situação
child that
normal,
is
né?
born
Então,
in a normal
isso só é
situation.
possível, né, com
So this is
grandes
only
números,
possible
né? Quer
with
dizer,
great amount
pequenos
of
números jamais
numbers.
poderia ver,
Small
né?
data,
No caso
small numbers
nosso, né,
wouldn't show
juntando os
this.
dados da coorte que nós temos, nós conseguimos 180 mil casos de crianças
We
que têm essas três associados, esses
180,000
três elementos,
cases
né?
of children that have these elements
E
associated
que aumentam excessivamente, né, seus riscos e suas chances de sobrevivência.
and
Bem,
affect very strongly the chances of
estudos de
survival.
desigualdade social, né,
There are
posso passar
studies of
bem rapidamente,
inequality.
né?
I will go
O
very
Brasil é um
quickly
país
through them.
com uma história
Brazil is a
complexa,
country
demográfica
with
complexa, social complexa, né?
complex
Um dos
demographic
grupos hoje,
numbers.
né, considerados mais,
One
né,
of the numbers now is that
sofreram mais nesse
the
processo
groups that
histórico do
suffered
Brasil é
most in
o
this
grupo dos
historic process
indígenas, né, os
was the
povos originários
indigenous
aqui do
populate,
território
the
brasileiro, né? Eles eram
originary peoples.
em torno de 3 milhões, se estima, né, com a chegada, na época que os portugueses começaram
We
o
had
processo de
we had
colonização desse território,
estimated
e hoje
3 million
é
in
em
this
torno de 1 milhão
territory,
apenas
and
de
there is
indígenas,
now
né,
only
que
a million
a todos esses
indigenous
processos, né,
that
complexos,
survived all of these different
alguns chamam de
processes.
genocídio histórico, né,
Some would call
dessa massa da
historical
população.
genocide,
E hoje, né, quando a gente vai
and
olhar os dados, né,
and
comparando
when
aqui
we're
em
going to
cada,
look
em
at the
cada gestão,
data
você
and to connect the
classifica,
data
né, os indivíduos
that
pela sua
classifies
etnicidade,
these
com os dados de
individuals by their
mortalidade, né, você vê aqui
ethnicity and
diferenças
mortality, we can
gritantes,
see the
né? A mortalidade, por exemplo, entre os
incredible
indígenas
differences.
de
The mortality
crianças, né, de
between
mães
indigenous
indígenas
and
em torno de
children from
2,5 a
indigenous
3 vezes
mothers,
maior
2
do
to
que
3
a
times
mortalidade
higher
de outros
than the
grupos,
mortality from
de
other
outras crianças
groups,
nascidas no
from
país.
other
E quando
children
se
born in
olha
the country.
algumas
And when
comorbidades
we look
específicas,
some
né,
specific
você vê o risco, por exemplo, de morrer de
morbidity
desnutrição,
numbers,
que
the
hoje é uma
chance
doença
of
muito
die of
elevada no
malnutrition,
país, né?
which is a
Ele é
rare event in
16
the
vezes
country,
maior
is
do que
16
na média
times
da
bigger
população. Ou seja,
than the
isso não é
average.
visível nas
So it
estatísticas,
is
né? As
not
estatísticas
visible
oficiais
in the
mostram um risco muito
statistics.
baixo de morte por
The
malnutrição, como aqui
official
mostra um risco muito
statistic
baixo
shows very
de
low
morte se for diarreia, mas você ainda tem
and
subgrupos
by
dentro da
their year,
população
but you have
com
subgroups in the
altíssima taxa,
population
né?
with
E
high
evidentemente
levels
precisam,
and
né, ter
evidently
focos do sistema de
have to
saúde,
need
né?
a focus
E
from the health
focar nesses
system
grupos
to
para que
focus
questões que
in these
aparentemente
groups
superadas possam ser
in issues which we
indevidamente ser
thought were
superadas, né?
overcome
Então
already.
esse é um exemplo, né, do
So
uso
this is an
também dos
example
dados,
of
né?
the use
A
of
mesma
data.
coisa com desnutrição, né?
The
As
same thing
crianças,
with
nós temos dados
malnutrition.
de
We
crescimento
have
nutricionais
data
dessa
of
criança
nutritional
no sistema
growth
de saúde,
in the
e
health
você vê que
system.
hoje uma criança indígena ela
And
cresce
when
3
an indigenous
centímetros
child,
a
it
menos
will
do que
grow
a
3
média do crescimento
centimeters
das crianças do
less
país.
than the average
Bem,
in the country.
uma outra área que interessa aqui ao centro e que tem sido usando essas coortes é o efeito dos sistemas de proteção social, né, na saúde. O Brasil tem
The other
imenso
thing is the
sistema de
effect of
proteção
social
social,
protection
é
systems over health,
foi
and
chamado de
it
Bolsa Família,
happens
que é
in the
programa de transferência de renda,
Bolsa
Cash Transfer
Familia.
Program, né? A Conditional Cash Transfer Program. E nós temos tido imenso interesse em
And then we
avaliar
have
como
a
a
great
política de
interest
redução da
of
pobreza ele
assessing how the
afeta a
policy
saúde.
of
Isso tem sido
poverty reduction
investigado com
will
bastante, né,
have an
riqueza.
influence. It
Talvez
has
seja um
been
dos programas em que os seus
investigated.
efeitos na
Maybe it's one
saúde
of the
foram
programs
mais
where the effects
investigados até
over
hoje
health
por
have
onde
been very investigated, because
mais de dezena,
some
né, de
we have
artigos
over one
produzidos mostrando
dozen
efeitos
papers that
diferentes
have been
desfechos,
produced
né, no campo da
showing
saúde.
effects, different
Sumarizando
outcomes
aqui,
in the health
é
sector.
o nosso programa chamado
Summarizing
Saúde, é
here,
bastante
our program
conhecido
is
por
called
todos,
Bolsa
né?
Família,
Ele é um
like
programa
a
condicional,
family
tem algumas
subsidy,
condicionalidades, né?
family
E
grant.
vocês veem
There are
aqui
some
os efeitos
conditionalities, of
dele,
course,
né,
you can hear,
no Estado
and you
Nacional de
can see the
Crianças, na
effects here.
redução de nascimentos pré-termos, no baixo peso ao nascer,
Effects on the
na
nutritional question,
hanseníase, né,
on
em HIV,
leprosy,
AIDS,
on
né, na
HIV,
mortalidade por doenças
on the
cardiovasculares,
mortality due to cardiovascular
mortalidade por
diseases,
crianças, né,
over the
mortalidade materna,
child mortality, maternal mortality, over the suicide rates, over the substance use-based hospitalizations, and also mortality among patients that had psychiatric problems, that were hospitalized due to psychiatric problems. So this is lots of actions that will show this possibility. And more recently, we were seeing here layer a so Brazil is a big country with different biomes, climatic conditions. 60% of the Amazon was in the Brazilian territory, so it shows lots of possibilities for investigation of the relationship between climate changes and healthcare. And this is an advanced challenge, a thing. These data come from several sources, ground-based stations or satellites or many other forms. And some studies start to show here results that are very interesting and very, as I have numbers, we have sufficient figures to allowing us to study the effects in different populational subgroups, things that weren't possible with different approaches or with small cohort-based studies where you can't compound your data and scale them up. So this is an area where several colleagues and groups also they are working here. They are producing a lot in this field, and the first publications start to come out. They start to be circulated, and it all is allied to a certain awareness over the data, because data is a public good to Brazilian society, and we have been creating several mechanisms to communicate to society in the sense of understanding the interest of society in that regard, the society questions, society question marks, so that we can collect the point of view and data from different walks of life. I think my time is up, but here data are very plastic, so to say. So data, they are of reasonable quality. I believe that the health care data in Brazil are of good quality. So this is something important to take into account. And basically, we can solve a scientific problem like that too. You can put in the same space, same probability, the probability of integrating the data and have different variables on your system, what improves a lot the investigative capacity in all of these contexts, and see the different possibilities here. And I would like to sum up with this. I would like to put this forward to debate to our colleagues. This process here, it has been reproduced, or this is inspired by others and by other experiences in the Nordic countries, in England, in Australia, in Canada, in developed countries that have been using data massively. But in my view, it makes us think that we have a traditional model to do research. It uses data collected primarily, but this model can be complemented by alternative models where we use data collected by the routine or by the administration or by from real life. They are integrated data that will allow us for generalizations, and they're linked related to the healthcare system, public health actions, as well as other actions. As the evidence level generalization of these results are much more efficient in terms of informing certain conditions and serve as a basis for certain decision making. So thank you very much, and I hope I've been up to the challenge. So thank you very much. Excellent as always, and I would like to congratulate the four panelists. I believe that I should be should shut down in order not to stain the interventions. So now these spaces are very important for us, and thank you very much to all of you, all the speakers, and something that I like a lot when we have epidemiologists. This is very deep. The debate is also open to the non-traditional issues like the public digital infrastructure and other things that are now crucial in the process, and not things to take into account ulteriorly. So now I would like to put forward a question to the speakers, if you could reply in 2 minutes, because then we would be ready to wrap up. And let's get started with ladies first. So, Ana Paula, I have a question for you. How you talked about the assessment of health technologies, right? So how do you think these process of health assessment, because it is something that we're also experiencing in PAHO, so aligning the assessment of health technologies along with the speed of innovation without compromising the scientific value. I don't know if you are dealing with this debate. I would like to know if you could maybe draw some brief reflection. Yes, thank you very much for the question. Dr. Marcelo, this is a topic that has been dealt with in literature, and I believe by entities like PAHO, ISPOR, and others that want to subsidize agencies in many countries, subsidize decision making. So I was able to take part in ISPOR decision position making, and ISPOR positioning. ATSs and all the traditional models, bringing all of them along. They are all used and well accepted. So it takes into account the evaluation process. So I believe that being very objective, I believe that if we can do that, more contemporary models that will allow access and allowing for the technological capacitation of the country, I think this is a way to speed up a process, not only of decision making and incorporating technology, but also to deliver this technology to the user at the end point. So I still think that we have some inefficiency decisions. We know that Conitec maybe takes more than a year to make decisions, and technology gets to big major cities and not in the countryside with the same expansion. So I think that it can put on the table decision-making spheres that will allow us to understand how we will operationalize the incorporation and how I can assess the effect over the populational health, and not only just because it's being incorporated. So this is my point of view and a bit of what should come out in this publication, this ISPOR positioning about the topic. So great. So we are looking forward to this publication, Ana Paula.
Make a question to Mark. Mark, in the context that we are almost all the countries we are living, in particular the health sector, with limited resources, how do you think that the concept of the equity criteria can be incorporated into the economic evaluation of digital health and artificial intelligence in particular?
Yes, thank you. Well, the thing about the term equity is it means different things to different people. And absolutely fundamental to start with would be a clear operational definition of equity. And there are HTA bodies around the world who have begun to do this. So NICE in the UK, for example, now has operates what they call modifiers to reflect disease severity and disease rarity which one could constitute as equity considerations formally in their assessments. And there are now methods available called distributional cost effectiveness analysis, which builds in distributional issues around health. So this is not just about the sum total of improving health, but a consideration for the groups that receive that health gain, in particular those who have economic disadvantage. And that is now being used in a somewhat informal way by NICE. But those methods are being considered, I think, internationally. And so the question is whether there are any particular equity considerations with respect to the technologies you're talking about. So AI-driven technologies, for example, in the health system. And there may be, and you may have been discussing some of those that I haven't picked up on already. But I think the key thing is that we have to be able to operationalize this. And I emphasized the issue of opportunity cost earlier. And there is a tendency to think about special characteristics of new technologies and then not mirror those special technologies in terms of opportunity costs. If, for example, the distribution of health outcome to disadvantaged members of the community is important, then that's important not just for the new technologies, but for everything else in the system, including those things that get displaced as a result of spending more on new technologies.
Thank
Hope
you.
that's helped.
No, yeah. Thank you so much. I'm sure we can make an entire debate around this. So thank you so much. I will continue in English with Christian. Christian, thinking about incentives, because there were several discussions around that. What type of incentives, can be financial, regulatory, or institutional, you think could be really critical in ensuring that the different actors in health systems truly share data?
Yeah, I'm not quite sure what you mean, but I mean, if you ask any clinicians, they are somehow able to express what data they need, or what data they would like to have access to. But sometimes it's not really understood why or how it must be organized. I mean, sometimes data are not just read by clinicians; they are also created and entered into the different systems. And that kind of work is not very popular among clinicians to enter data. And we've been working with the concept of value chain, where you can actually put values to the different work tasks that are put into the process. And therefore, there might be some work tasks in the beginning of a process where the work is not, the duties are not very popular among clinicians. But once you can tell them by these models that they will actually have a value further on in the treatment process, it changes the way they feel about incentives. So I think, and I mean that leads me back to what my group is working most on is participation, participatory processes, which is not so easy done. But I think it's very important to have the users on all levels included in the design and implementation processes.
Thank you so much. We here at PAHO are having some kind of deeper discussions on change management, cultural management, to see if we can find different angles in the concept of data sharing, not only among institutions. Sometimes in our own institution we don't share data with other unit that here. So we are looking at that. So pasando a portugués o portuñol, disculpa, portuñol.
Going back to Portuguese or Portuñol. So how do you think the epidemiology can evolve in the era of AI, do you think that it will replace the classical design of epidemiological trials, or it will come rather as a complement to prop up the work that has been carried out already? I believe that the applications are very limited, and I will put forward some reasons why. First, the lack of capacity to understand something basic in public health, which is the causality processes or the processes of how the determination system takes place. AI can't read that. They can't disambiguate what's predictive, what's separation, what's causal. So I believe that this is a central question. Epidemiology is a discipline centered around the causality determination process of the health disease processes. And they're important to inform public health systems. While the AI models, I believe they are nowadays, they have a major application in the field of populational health, in the field of predictive models. So this is a resource that can speed up processes, for example, what we see in terms of epidemics and other kinds of predictive modeling, and the causal thing isn't the main thing, but in the sense of the classic epidemiology. So this is an issue. And in addition, I would like to mention the biases here that the training systems, the current training systems for AI devices will entail. There is this impossibility of understanding the world in all its complexity with reductionist views into the world, and it will make us interpret information without taking into account equity and other things. You asked 2 minutes, of course, that this is a complex, big discussion, but 2 points that, in my view, are very important things in discussing AI in scientific disciplines like epidemiology.
Thank you very much. Yesterday, in the Journal of International Research, an article which we had the honor of publishing together with the Dr. Jarbas from the PAHO and Secretary Stella. I'll share the link afterwards. And they did a specific analysis of the biases in applying artificial intelligence. And we're practically on time. I would like to share very quickly what are the 3 pillars in terms of OPAs that we're working in this context. Besides the production of data, there's the tradition with basic health indicators. We have 240 indicators and data. I think 29 years of data sets, and this has been published. But besides that, we have collaboration projects in terms of governance and how to set up standards for interoperability. Now we're deepening the concept of digital sovereignty. 3 weeks ago, we had an alliance for primary care in Rio, organized jointly with PAHO's World Bank and IDB. We also had a panel on digital health and a debate as regards digital sovereignty. And the second line, we have a very strong emphasis in desegregation of data, not only as an instrument of equity, but in this concept that Professor Mauricio mentioned, to strengthen algorithms and that no one is invisible within the system. And the third area together with the strengthening of human resources. We put an area with cooperation with the country in terms of cyber attack protection. In public health, we have many specialists, and we are aligning with academic institutions. So I'd like to thank Felipe and other colleagues. I'd like to congratulate CONASS and the organizing committee, and a personal feeling, I'd always to congratulate Brazil when the institutions are doing history. They do not notice that until it in fact becomes something historic. In the international arena, Brazil, especially in terms of the creation of digital health information division, is not only creating history, but inspiring other countries about the idea of digital health as a fundamental pillar of public health in the countries in the Americas. So with that, I'd like to end, and greetings to everyone, and I hand it over to Felipe. Thank you very much. Okay, a lot of content. We already have 2 hours of presentation, but we have 6 minutes to midday. I'd like to hand over to our technical advisor, Luciana, to ask a question, or Nereo, if he wants to make some kind of consideration, with the due permission to using a little bit more of your time, and thank you once more. Good morning. First, I'd like to thank for the brilliant explanation, Professor Marx, Christian, Ana, Professor Barreto. Many important reflections to our day-to-day and in terms of decisions for health. And from your speech, we thought two things, and I'd like to make the most and to know your opinion. The first is thinking of variability. When we think about care based in value, but to think about variability in a country like ours that has continental dimensions with many territories and inequalities, which Professor Barreto mentioned, like when we think about the indigenous peoples, how to think about these different contexts, how much it costs to treat a stroke in the Amazon region where you have to go by plane or a boat and many days transport, and how much does it cost to treat in São Paulo with all the structure we have. So how to apply these concepts and considering these significant differences that we have in our territory. And the second thing I was thinking about when we think about real life data, all of this wealth that we have in Brazil, how to bring this to our context of evaluation and to incorporate it in the CONITEC. In CONITEC, we still have a model which varies rigorous methodology and with evidence, and still very heavy logic and with very rigorous methodology, which we think is important. But how to bring this real life data to our decision making in CONITEC, to take all of the data we produce and to weigh this from the most classical studies and all of our analysis that are still very rigid. So we feel this difficulty by the perception of the managers of the importance in utilization, all of these factors that interfere with the day-to-day, and sometimes an analysis that is very methodological of this research, like Professor Barreto mentioned, which is more traditional. So I think these are the two provocations to end this brilliant morning.
Bom,
Ele
acho
pode
que
começar a falar, eu não sei quem. Bem, eu poderia falar rapidamente.
I could
Obrigado
speak
aí
quickly.
pela questão. Eu acho que é muito
Thank you
importante.
for
Eu
the
acho que você
question.
sintetizou
I think
pouco,
it's
acho que a
important,
reflexão coletiva e questões que
the
estão
collective.
no fundo, né? Eu acho,
I
eu
think that
antevejo, né,
I
sistema de saúde.
preview
E
a,
como eu sou mais velho, né? Eu comecei
as I'm
alguns anos
older,
atrás.
I started a
Outra
few years
coisa,
ago.
anteriormente não tinha no
Many
Ministério da
things
Saúde, né? A
in the
capacidade
past
de
we
você
didn't
fazer
have in
era
the
muito
Ministry of Health.
limitada.
The
Eu antevejo o
capability or
Ministério da
capacity to
Saúde
do
e que
things was very
os
limited.
técnicos dos
I can
ministérios
see
daqui
a
10, 20 anos
ministry,
vão
a
ter feito
health
coisas fantásticas que
in
hoje
10,
nós
20
chamamos
years
de
that
pesquisas, né?
technicians
Que
can
vão
do
ser
very fantastic
cotidianas,
things,
né?
which we
E
call
tal. Eu acho que essa questão de dados
research,
é
which will be
central. Se
routine.
quer uma coisa,
So it is this
é
issue of data
necessário
is
desenvolver
central,
infraestrutura e
is to
preparar para isso.
develop an
Porque
infrastructure
você
and to
colocou a
prepare
questão
for
de
that. You put the
subpopulações,
issue
porque
of
até hoje o conhecimento científico é
subpopulations.
baseado
All the
no que se
scientific
produz
system,
em
what
Chicago,
you produce
é
in
replicado no
Chicago,
mundo inteiro, né? Você tem estudo que foi feito
what is
né,
produced in
no
Chicago is
Whitehall,
used all over the
Harvard
world. You have the White
é
House. The
usada no
Whitehall
mundo inteiro,
study
que
is
um
used for the
coorte
whole world.
importante, mas de
It's an
funcionários
important
públicos
cohort,
ingleses, né?
but of
Tal que se
English civil
generaliza com
servants.
muita facilidade. Mas
But it can
num
become
sistema
generalized
tão,
very
tão
easily.
sofisticado, você tem que
For
ter
a
decisões
sophisticated system, you have to have
estratificadas, né? E eu acho
stratified
que só um sistema de
decisions.
dados integrados
Only an
pode fazer
integrated
isso,
data
né?
system
Amanhã
can do
você
that.
poderia analisar
Tomorrow,
uma
you
questão
could
não é para o
analyze
Brasil, mas para o
a
estado do
issue, maybe
Paraná
not for
ou
Brazil,
o
but just for
estado
the
do Mato
state of
Grosso ou numa
Paraná or the state of
subpopulação
Mato Grosso or
afetada
in
ou num
an
conjunto de
affected
hospitais.
subpopulation
Isso
or in a
precisa ter
set
uma
of hospitals.
flexibilidade
So we need to
e
have a
acessibilidade aos
flexibility
dados
and
muito definidas e
accessibility to the data
estruturadas
that
para
are
que
very
isso
well defined
aconteça
and
a
structured
contento. Então, eu acho que
for it
essa
be
para mim
done
é a
in a
questão
positive
central,
way. I
certo?
think for me
E
that is the
a
central
questão
issue.
disso é
And
possível. Agora
is it
você tem questões
possible?
políticas,
Yes.
né? O
But now,
Brasil
but you
recentemente
have
está
political
investindo R$ 1 bilhão
decisions.
no
Brazilian is investing
laboratório
1
P4.
billion reais
Ele pode
to
investir
doing a
R$ 1 bilhão
P4
e
lab.
construir centros, né,
He
com
he can
capacidade de gerir,
use that
né, e
to
sofisticar
generate
a gestão
centers
dos dados, né,
to
produzidos
in a
pelos
more
estados. Então,
sophisticated manner
tudo isso são
manage the
questões
data.
políticas, né, que precisam de implementação, precisa
All of these need
de
implementation,
esforço, evidentemente,
efforts.
leva tempo de
Of course,
amadurecimento,
these
né,
take
leva
time to
aprendizados
mature,
coletivos, não só nosso, mas
not only
internacional, né,
ours,
empresas
but
como
also
essa
international.
mostram, né, para não ter o bias da unicidade, né, vai
And
ser
do
ter
not
isso
have the bias of
mais
unicity,
disseminado e
but
compartilhar
disseminated
experiências.
and to
Eu acho
share
que, como nós
experiences
temos um sistema de saúde, o nacional
as
de
we
saúde, nós
have
temos tudo,
a
as
national
quatro
health
queijos na
system.
mão para que
We have
implemente que as decisões políticas possam ser
all the
aceleradas e possam
instruments
ser
for these
resolvidas,
instruments to
né,
be
questões
accelerated and
tecnológicas e
solved
técnicas e
in the
questões
technical and
de
technological
utilização de dados. Nós
issues.
temos uma lei de proteção de dados pessoais, que é uma das leis mais
We
generosas que
have
tem,
one of the most
né?
generous personal
O
data
parlamentar
protection
brasileiro,
laws.
a
The
meu ver,
Brazilian
foi
parliamentary
extremamente generoso. Ele criou uma
was
lei
extremely
que diz
generous. He
que
created a
esses
law.
dados públicos podem ser utilizados para
This public
pesquisa,
data can
para
be used for
atividades
research,
teóricas, né?
for
Contanto que
activities,
seja para o bem comum, né?
if it
Contanto que
is for
seja,
the common
né,
goods,
utilizada para o
if it
bem
is
coletivo, o
used
bem da
for the
sociedade. Então,
collective
eu acho
good,
que
for
nós
the good of
temos todo um
society.
conjunto de elementos
We have a
extremamente
set of
importantes,
elements
né,
that
para
are
implementar.
extremely
Agora,
important to
isso leva
implement,
a esforços de
but
implementação,
this
né, e
leads
decisões
to
políticas para a
efforts
criação
and
de novos
political
modelos,
decisions for the creation of new
no
models, new
tempo, na história,
structures.
o Ministério tem criado isso.
And the
Eu
ministry
antevejo
has
alguns
created
anos,
this, and I
eu acho que o que
forecast
nós falamos hoje aqui,
what
o que
we
a Ana Paula
saw,
falou, o que eu
what
falei,
Ana
isso
Paula
pode ser
saw.
feito rotineiramente dentro do
This can be
Ministério da
done
Saúde.
routinely in the Ministry of Health. Thank you.
Eu vou fazer só breve assim, complemento.
Okay,
O
I'll
professor
just
Barreto
do a
já
quick
respondeu,
compliment.
né, muito do
I
que eu
think Professor
gostaria.
Barreto already
Mas sobre
answered.
assim, o primeiro ponto, a questão
The first point of variability, of course, there are circumstances that are part. Many times the access in the Amazon or in Acre require a time of transport that is intrinsic to the national. But there's some things that shouldn't be different, and we can work for them to be less different. Those studies, we were just seeing the surgery room, only the surgery team. That's not so different. Of course, there'll be a little bit of variability, but in summary, you have protocols about what is the procedures, what is the technology, and all of these can be homogeneous. And when we open the results of these studies, the response of the medical teams, and the medical teams accepted. We thought we would never, that they wouldn't be reacting so well. And sometimes they didn't know how the hospital across the road was working. So the transparency of this information means that we know where the best practices are. And I think it creates a virtuous cycle. So variability can't be eliminated. I think it can be reduced. I think that is our directive in, especially of those who want a more homogeneous policy. And a second point, and is central to the point we work with, it has to be rigorous of the scientific methodology. It has to be there in the evaluation of technology, not only in decisions, but also in follow-up of the technology. But currently, I think Professor Barreto was fantastic. The methods of evaluation are advancing. Good. We have an analytical capability that is incomparable to what we had in the past, and this had to be incorporated. Otherwise, we will always be falling behind. So it's not about reducing the rigor, but in terms of using these big databases, and if they talk to reality, I think those are the two final messages, and thank you for your question. So in the name of the CONASS team, to thank Professor Mark Scooper, Christian Grant Norman, Ms. Ana Paletkis, and Professor Mauricio Barreto. It was a privilege to participate. And also Mr. Marcelo D'Agostinho, it was a pleasure to participate. We had 900 people participating in a virtual manner from the CONASS network, participating live as well. Many state Secretary of State, Dr. Claudia, Professor Lucas Barreto, Representative CONASEMES, Michael Giammi, and many others. And I'd like to thank for the participation of all. I'd like to highlight a few points. The presentation, Professor Murilo, I would have to highlight, Mr. Mauricio Barretos, because I think the data presented shows the importance of the institution in similarity to what we have in SIDAX. We all had a negotiation in 2018 of the institution of what would be the proposal in terms of regulating access to the data, and very similar to what was being built at the time for the general protection data law. And we were discussing this with our technical chamber about how much we can advance in the formalization of this and how it was proposed at that time. And I think almost 8 years that we have this theme in discussion in how much we can advance in the regulation and in the institution, and how Professor Mauricio Barreto, in the injection of resources I think it's normal. I think it's fundamental for the public health system. And I like to highlight with Professor Ana Paula the issue of the cost of the non-incorporation of certain technologies. And interesting how we incorporated the vaccine in terms of respiratory problems for pregnant women and others. But happily, it was incorporated, but the discussion was very complicated. I think if we had advanced more in this issue with the Professor Ana Paula, maybe it would have been a little bit easier. Gladly, so we incorporated and we have hope of how it will impact the quality and the life of our children to reduce hospitalization, but also the reduction of costs of these hospitalizations. What would have been the cost that we would have to calculate of the non-incorporation of those technologies? So once more, thank you, professors, for participating in discussion. And now I'd like to hand over to Felipe for official closing. So thank you due to the time constraints. If you want to make any comment, we are here alive, but I would like to close for this morning. Yep. Christian, Mark, okay? Okay. So I thank you immensely, and I inform that we will come at 1:30 p.m. Brasilia time for the program that is in the CONASS site. Thank you all.
Obrigado aí. Tchau.
Bom, e aí eu informo para os membros da Câmara Técnica, principalmente,
And
mas
I
para
inform
demais
members of the
o QR Code tá lá
technical
fora.
chambers. The QR code is outside,
Esqueçam, por favor,
and we'll put it here.
para depois
Don't
da
forget,
aprovação
so you
das
can prove
Boa tarde. Vamos retomar aqui agora os trabalhos
Recording in progress.
do CONASS Debate
Good
Saúde
afternoon.
Digital.
Let's restart
Nós
the
iniciaremos
CONASS
neste
Digital
espaço
Health
para falar
debate.
de inteligência em saúde,
Now we're
onde
going
o
to
secretário
talk about
inteligência
intelligence in
e
health
Sierges
with
CONASS.
Mr. Saterabi.
E nós vamos colocar a apresentação dele em tela.
Mr. Santerabi, Technical Advisor CONASS, we will put his presentation on the screen. Afterwards, we will
Da estratégia saúde digital
talk
no
about
futuro.
the digital strategy and the future of health
Com a presença do
with the presence
Conselho Nacional de Saúde,
of the National Council of Health,
Ministério da Saúde,
with the Ministry of Health,
de secretarias municipais de saúde,
the
CONASEMs,
Council of Municipal
Conselho
Chambers,
Nacional de Secretários de Saúde, o CONAS,
and
da
now
esfera estadual.
with us CONASS, which is National Council of Health Secretary. Then we will do a round of Brazil with 5 states representing the national territory. 5 secretaries will do the speech on the digital transformation in the territories, and then we will finish the program with a general end summary. I will now hand over to Santerabi, and we have until 2 p.m.
Boa tarde a todas.
Good afternoon to all. It's a pleasure to be here talking to you about this important work that we are developing within CONASS, and initially to thank all the support for the execution of this work, CS, and to thank the presence of our secretaries, Cláudia from Mato Grosso, Nayara, and the others that are watching us in a virtual way, and our colleagues Felipe Ferrer, and thank you for coordinating the whole process. I will give a summary of this process that we're going, of the creation of a network, of the Center of Intelligence for strategic management of the Unified Health System, the SUS. We do this cooperation with the Executive Secretary, with the technical chambers of the states.
Adriano. Então, todo esse trabalho, ele nasce.
So all of this work, this speech I'm going to carry, I will give now, is very much aligned with the mission of CONASS. Many people know CONASS for this power of coordination and the construction of SUS with the ministry and CONASEMS. But the mission of CONASS goes beyond the coordination and creating policies. It's a lot about dissemination, diffusion of knowledge, process of innovation, and exchange of experiences. So the building of CS is aligned with the institutional mission of CONASS. The transformation, we talked a lot about this in the morning, about digital transformation, and it's a theme of our event. So that what is possible within this discussion is how is the construction of this intelligence of this management of health and of SUS. And in this digital transformation or transition, we're in the process of from an analogical to a digital process. So we build for the construction in forms, in paper. We work with digital spreadsheets and data, construction of panels, and analysis and georeference. So the great challenge And it goes from a totally digital process to the analogical processes. So this challenge of this digital transformation is not a future, it's a real need that, and the opportunity to overcome. And we're trying to work since of the law that created SUS. And we have the clarity that there is a real SUS and the ideal SUS, the one that is real, the ideal is that is in the Constitution, in the academic papers, in articles, and the real SUS is the one we face every day and with the state secretariats. And they know this reality of the real SUS and the difficulty of putting things into practice. The digital transformation goes beyond the application of new technologies, as was commented this morning. So it depends a change in culture, of mentality, and of practices. When we talk about technology, digital transformation, we have to see that there's the physical technology and the social technology. And this is the way, and the transformation, and this is the end we are seeking. So the practice here, and within the traditional process of data and the evaluation of around 60% of the work, 80% is in the structuring and collection of the data, and only 20% is to do the analysis and decision making. So within this logic of digital transformation, we have to invert this flow. And we have tools and technology to invert, where 20% with automatized processes, we can define problems, do the collection, and to have 80% of the time to do analysis. And so with the analysis being done or not done, the manager has to make a decision. So in the technical aspect, we have the responsibility of seeing this, to see the result in order for the manager to take a decision. Otherwise, he will take a decision without that analysis being done based on the data. The first step when we came to the discussion of CS was the qualification of the data. We have clarity that in SUS there is infinity of data, and we still have a certain difficulty. So the first step we have to discuss, and this comes much in the speech of Anna, how are we going to create a data-driven culture if we don't have organized, structured data to make use? So with integration of data, this generates knowledge and then intelligent management of that intelligence. So when we talk about intelligence, not about the manager. It is important and fundamental for what? To improve the population. That's the end we want, our proposal. It's not to create, integrate data, information, and to improve the health of our population. In the world saturated with data, what we have the most is data. Our challenge is to identify the data, is to filter what really matters, because the quantity of data we have to take a decision is infinite. So we need to have a capacity to filter what really matters. And CIEDS is a lot of that in the identification of the data, curatorship, and to deal with this data and visualizing that data. And we talk a lot about strategic. Another is a tactical visualization, and another an operational, to give an opportune vision for the managers. When we're talking about the process of visualization, we have clarity in Brazil, but all over the world, that the majority of data, we have data and enough panels. We have too many panels, and there some secretariats have over 200 panels. So the question is, how will the manager subsidize a decision-making process when he's looking at 100, 200, 300 panels? So within that logic, which we did in partnership with Washington, with colleagues, we discussed a methodology within the process and the building a process, tactical panels and strategic. What does that mean? If a secretary doesn't have a problem, but we have to have a capability of translating those 200, 300 panels where you can align data from various systems of information, various different, and you can summarize in a strategic panel. And within the discussion that we carried out in the assembly with the secretariats, we were able to translate these tactical panels of the state management. To understand like our car work, to know something is wrong, the driver doesn't have to be a mechanic. It became a small red light in the panel. And when they signal this to the manager, then, and if they want more information, they can bring the operational panel. So they start to create a flow and a model of visualization of that data. You start to filter that information and what matters and which will subsidize the manager in decision making. And the response, it comes very much in this logic of the technology. So you have the physical technology, which is the infrastructure, resources, materials, computers. And then you have the social technology, the practice, cooperation, the collective processes. So the work of CIEGS, it cannot be understood as a proposal of a construction of a physical technology where you have a lot of computers, but to understand that we have to advance in process of technology integration of the various actors in that analysis or that response that they will need. Another discussion that we talk a lot is the famous intelligence pyramid. Where does this intelligence come for management? The base of the pyramid is data, which generates information, which generates information and then knowledge, and this will then be translated into management intelligence. So the more treated, more information you will have, more information, knowledge, and more capability of intelligence for manager to take a decision in that opportune moment. That's why the importance of having policies like heads, the NRNDS network. Then you can create inputs, a new knowledge, and a new intelligence to have more efficiency for management. So in these 3 years that we started this work, 2025, we closed with 17 states with their sièges organized within that logic. All of these states in blue, from the north, the Amazonas, Acre, the north and south, southeast, São Paulo, Minas, Espírito Santo, the south of Paraná, Bahia, Sergipe, Piauí, and Maranhão. And until the end of June, we have around 6 states with data to our expectation that until the end of the year, we can get 90% of all states of Brazil within this structure, working within this logic, so we can foment more and more this process of cooperation. CIEDs cannot be understood as merely a nucleus or a center to organize and create data and panels. So we work, this work that we're doing, we have a strong discussion within these 3 dimensions. The qualification of the process, in the discussion of integration with the theme health, and within the scope of digital transformation. So these 3 dimensions will create the capability that we have for it. Within the 17 sièges, all of this work is a demand and a discussion jointly with the whole assembly, with the 27 state secretaries. We have clarity that each siège has what they have, their own personality and a different scope in their own line according to the specificity and the need of each state. And with that, and which is the strongest aspect of our work, an experience that is carried out in Rio, we had some practical experiences with the work that was carried out in geological risk. We were able to go up to various states that have the same need. So from the moment that we identify a successful case, we put this within the network, and each state, it doesn't have to start from zero, but it will get the whole base of the construction and only has to adapt in its reality of each state.
Tem vários relatos e até o final desse ano a gente vai lançar uma publicação da experiência do CIES e a gente conta com
And we're going to launch a publication by the end of the year with the experience of CIES, and we count on the support of all states for this publication, and it will work as a blueprint to help other states that want to carry this out or that already have this formalized in this process of enhancing our network. So here I've shared some of the pics of these states that have already rolled out their sièges. This is just for you to have an idea of the relevance and the dimensions of this work. This is the Intel Center in the state of Rio de Janeiro. Dr. Claudio is here participating with us, so it's also part of the Intelligence Center in Rio de Janeiro. This is the Intelligence Center in the state of Bahia. This is in the state of Piauí, state of Paraná, state of Amazonas, state of Mato Grosso do Sul, state of Maranhão, state of São Paulo. And as you can see, the facilities may differ because they will accommodate that into specific, according to the logics and the needs of each state. So the CS is to be built up. You don't have to have a dedicated room with several screens all over. No, it's enough to have a meeting table where the technicians, the intel of each area will gather in order to make a decision or to carry out a specific kind of analysis according to each demand put forward by the high management. So the physical space is being built and each one is building that within their logic. So there is no receipt for a recipe that is one size fits all. And here in our understanding, this management intelligence is the sum of the human intelligence plus the technical intelligence that is available within the health department already. And with the digital transformation and the advent of AI, we can use artificial intelligence as well. And it gives us more robustness to process data in a faster way, and it will enhance more and more the construction of these managing artificial intelligence, as we've been calling it. And I think it's clear for everyone that the generative intelligence comes to put down a specific kind of barrier. When we were talking about digital transformation, that was a barrier. We were referring to a technical chamber or an IT area, but the generative artificial intelligence is putting down all these walls with a natural language. Any person can it can have the communication with the computer facilitated. Now you don't have to know programming language to talk to the machine. Nowadays, with natural language, you can consult databases and move forward. So it really brought down a specific kind of barrier, an access barrier, and it enhanced our ability to carry out innovative processes within the management in an exponential way, actually. And our imagination and creativity will dictate the pace forward, but there's no limits whatsoever for this kind of thing. You can skyrocket. It will only depend on the maturity of the technology available in each state and the maturity of each state. So the ability to produce responses that are faster and more targeted will be enhanced exponentially given the digital tools made available. Of course, we have to overcome the digital barriers, and to that end, CONASS, in conversation with the state health departments, we want to carry out this capacity building, 3-hour capacity building program to raise awareness in the high management as to the use of artificial intelligence to help them manage and inform local managers so that they can multiply that knowledge within their own state, not only in the state health department, but also with the municipal health department, so that we can root in this discussion in the ground of healthcare. So this is the turnkey on the digital transformation. Running in parallel, we have this trilogy, 3 courses to capacity building. This is for practical use of AI in 3 different modules with different workloads. This is a 3-hour course so that we can carry out actions that will give capacity building to the high management. We are offering this. And now, according to the logics of creating multipliers, but also having collaborators. So this takes place within a collaborative process with CONASS, states, and in the near future, we're going to get to the COSEMs and CONASEMs local ones in order to effect this digital transformation for good. Last year, we launched a book, The Digital Transformation of the SUS Unified Health System, which translates a little bit this digital word we're engaged in into lay language. So this QR code gives you access. It lives in the CONASS web page. It's public access. You can have easy access to it. You can just scan the QR code and have access to this important material. This book was built, intended to those who don't really understand the lingo, the jargon of those who deal with IT. This is for managers who don't have much of digital literacy so that they can master the related vocab. So this is the CONASS web page. All of our work is there with CIEGES. It talks a bit about the work that we've been carrying out, the network that we've been establishing within the CONASS network. There is an address and the POC of all states that are taking part in this network. So this is a way to multiply knowledge, so that each state, 17 states are already taking part in the network. They are within the CONASS web page. Those who would like to have access and have direct access, you can have access to it all there. To wrap up, we understand that the digital future actually is built by people, right? But by people who use artificial intelligence in order to support decision-making, human decision-making. This is the logic according to which we work. So digital transformation won't be carried out by machines. It's rather affected by people who understand AI, who understand the digital process that we've already put into motion, right? So there you go, my contact info, and I would like to thank once again your patience and your support, Dr. Claudia, who held our third meeting of the CIEGES, Dr. Cristine, the first meeting in 2022 that initiated all this process. Dr. Nayara held the fourth meeting, the first of the northern region of Brazil. So these are managers who are focused on innovation processes, not only, but also modernity as a whole. We didn't consider that in the past. Now we are trying to qualify a SUS with over 250 million inhabitants all over Brazil. We must rely on digital technologies that will prop up this construction. So I'm at your availability here, just in case you would like to have some questions answered later on. Thank you. Yes, a round of applause. We are now within the CONASS Technical Chamber with several secretaries, and I would like to open the floor for 2-3 interventions. Our time is on the spot, but of course that we can't lose the opportunity on collecting in 1-2 minute interventions do we have anyone registered to take the floor? Don't be shy. Okay, so Secretary Nayara, then Secretary Claudia, and I think that's it, right, too. So please, go ahead. Well, first off, good afternoon, you all. I'd like to congratulate CONASS. I would like to congratulate Sandro and thank for the opportunity. Following your intervention, Sandro, this is true that when several technical teams get together, they are working with different tools that they didn't have access to previously, and CONASS, with all this effort of advancing in terms of new technologies, this is the beginning in the state of Amazonas. What we understand today is a greater alignment so that we can all be on the same page. And CIEGES was a trigger so that this all could take place. So I am here with Valdino. Where is he? I am here with Claudino. Claudino also belongs to our team in the Secretary in the State Health Department. He's responsible for CIEGES. I'm also here with Carla. Carla works in the technical advisory, and she's a liaison between all technologies and with other departments so that CIEGES can really be a collective construction space for decision-making. But before all, this is where the tool is validated so that it can be official within the Secretariat. Would you like to add something else? Good afternoon, everyone. And as the Secretary talked about, CIEGES, one of the first works that CIEGES was able to produce shows in a very straightforward manner many of the results that health has gained and acquired over the course of years, I think that the Secretary will share the material a little bit down the road, but it's a start, and it was made up of the creation of CIESs in the state of Amazonas. Cláudia Mello, the State Health Department of Rio de Janeiro. My testimonial has to do with this. CIESs came to us in 2023. We had a previous meeting when we were thinking of putting up this intelligence center. We didn't have a specific name yet back then, and it was a launch that Sandra and Felipe went to Rio de Janeiro. We had some workshops, and then we thought, well, in 3 months, we will launch it. So in 3 months, we were able to put it up, and then we can share later on where we gained ground and where not. So I would like to congratulate and thank this gathering with the technical chamber. For us, the CIESs and everyone, it's very important because we were able to draw the line where we wanted to go, what were the limits, and nowadays we have a very good results. We have here colleagues, statisticians, Leonardo, also executive. He also works with information technology. It means that we have a very dedicated team. It's a one-way road, actually, because we are here as a person seeing that, well, the world is following this path, and we have to be aligned in order to provide the population with good health care, because an opportunity to take action based on data-driven databases. I think this is very important, and it will help us in the daily practice. So I'll do just like Nayara, I'll turn it over a little bit to our technical area. So good afternoon, everyone. Just to add up, I think Sarah will show and images will illustrate what we've been carrying out. So I would like to thank CONASS support once again. I think CONASS was the main agglutinator of the ideas we have, but sharing the technology that we've been trying to apply, thinking of strategic, operational, tactical dashboards, so that it's very important to not lose sight on it. We have to think who is going to read the panels, the dashboards, the information made available, and how decision-making can be enhanced at the higher management sphere. So this will be shown. Thank you very much. Well, so I'd like to thank Sandro. Oh, yes, please go ahead. I am Cristine, the Deputy Secretary of the State of Mato Grosso do Sul. I'm also here with Márcia, who's our Superintendent of Digital Health. I would just like to talk about CIESs a little bit. This is very motivating, actually, because CIESs was very challenging, right, Sandro? We were also one of the first states to incorporate, to embrace the idea. And I believe that actually our challenge is to promote, to foster culture in organizations. And this is a challenge, even if we already have this movement, which is a movement of adhesion, artificial intelligence, or this new view. We still have things that are deeply rooted in our institutions. And this is our major challenge, so to say. And I see this with very good eyes, actually, because it's a very good moment we're in. This is the moment of literacy. So CIESs, for example, helping in this confirmation of this literacy. And then I think, well, what we can do, we can bring together small groups at CIESs and do 3 hours daily with sectors, small groups, and so on and so forth. And I believe this is a process of continuous education that we must provoke, we must work, because changing turning the key here is difficult. It's not easy. This is a step-by-step thing. I don't know if Márcia would like to speak something too. And of course, I would just like to thank CONASS for all the movement it's been championing. So thank you very much to letting us follow through. Good afternoon, Márcia Tomasi, Superintendent of Digital Health. I am responsible for CIESs in the state of Mato Grosso do Sul. As Tina said, we have been evolving a lot. We're still incorporating the team, and this is a major challenge for us. But just to complement what Dr. Christine said, actually the challenge is not only the secretariat and the technical areas, but also the need of engaging municipalities, given the fact that the data, so that it can really inform decision making in the localities, it will make a big difference, so that we should engage them. Dr. Mauricio, our secretary, is also a huge champion of this cause, and it's important to provoke the municipality so that they can come to CIS and understand not only the technical teams but also the manager, because more often than not it doesn't happen and they don't make a team available to work on this proposal. So this is something that we're going to evolve, and I believe it's going to be very nice. Good afternoon, everyone. Odsley, State of Piauí. I believe that the initiative is very important, as our colleagues have already highlighted, but there is an important detail to consider, which is the creation of the network, the possibility of state health departments to visit one another and understand what's being built, share ideas, exchange information, right? To understand what's being built, for example, the visit paid to the state of Mato Grosso do Sul, we got to know the everything that we were mapping out. We were mapping out the highway all the way up to the border with the other state in this other country, and in the state of Bahia as well, state of Goiás as well. So all the visits we paid, somehow they enrich on our end, and will allow us to build this. Not only CIS's creation, but the network as a whole, it's very important. It helps everyone a lot. Very well. I would like to thank the presence of everyone here, and let's go to the next activity. I would like to invite the to the table Deborah Malek, the National Counselor for Health, and the Technical Advisor Michael Diana, Technical Advisor to CONASS. And we have here the Secretary of the Ministry of Health, Stella Dodge, of Digital Information. I would like to thank everyone's presence. Please take your seats. And I would like to provide the context to the table. Deborah Malek will be the first to speak. We're going to put up her presentation here, but there is a table to talk about the future of digital strategy. And we also have here a technological advance beyond to what we were thinking of when we formulated this strategy. And the challenge has to do with the federated management of data, so that it can be made available where it is most needed. So I'd like to turn it over to the counselor, Deborah Malek, representing here the National Council on Health.
Thank you, Ferrer. Thank you, everyone. Can you give me a 12-minute warning? Okay, thank you. And initially, I would like to thank with each one of you that the social control has over, in terms of health conferences and deliberations done in those, indicating the need of having a policy in communication in our country and the importance of advancing, and especially in this last period, much in the line that in the opening line that I brought to you, in the sense that we aren't able to debate and in advance without democracy and without a project for development of our country. So in this process, especially in the 10th health meeting, it was deliberated to create a technical chamber, and that's how it was done. We had the participation of Ferrer, that is working around a year now, and still starting its work, but I think very soon we will have from the commissions that coordinate this propositions for social control around artificial intelligence, among other subjects. And having done that opening or introduction, there are some issues for the reflection here so that we can try to contribute to the process. So initially, that in the optic of social control, digital health has to be seen as a country project. And there isn't digital health without technology, without governance of the state, and this from some initial premises. The issue of technology. It's the project of a nation and about dispute of power in that path. In terms of digital platforms, as structuring of the care with the data, strategic planning, and in health, strategic management and public health, always thinking of innovation with a view of the ethics of care and equity that is so dear to each one of us, and in the perspective that digital health, in this view of technology, can in fact bring reduction of social inequalities in our country. And we understand that we are in a historical moment and of great decisions, because either we go into this view of strengthening tools in this democratic path, and that goes through all of this federated architecture of interoperability, with autonomy, with infrastructure, with social participation. This is very important in all of this process, looking at sovereignty and equity. Either we advance in this way, or we will be more and more increasing the challenges to our sovereignty, be it the processes of privatization or external dependence, and also in this theme of increasing asymmetries, and that has the loss for Brazilian society and for us. And in that sense, I bring some reflections in terms of international and in the perspective of social control. It seems that in this international view, we have the dispute between models, we have the big techs that are very present in the life of everyone, with the narratives and with all of this infrastructure of data. We have the concern of interoperability without sovereignty. This has shown to be a global tendency, making easier the flow of information, and in that perspective of transforming that in merchandise. So you have this asymmetry of power. And what does the social control bring in this scenario and in this aspect? The need of protagonism of the SUS system. Brazil is an example to have the most inclusive policy, which is the single health system, the unified health system, to have a critical view of incorporation of technology and international standards, but keeping our autonomy and democracy and sovereignty, with technology reinforcing social control and national sovereignty. So building a path for a sovereign digital health. And going a little bit in the issue of federated management of data. This point here, I would like to make an observation. This still hasn't been duly talked about in terms of social control of SUS, but we have some positioning in the process of debate. So we understand that the federation needs to be in a process of a shared federation without isolation of system, with integration, be it all administrative autonomy or sanitary, and having the guarantee of interoperability of those data and sustainability, seeking security, traceability. And it would seem that if this is the path, Brazil has the answer, which is the RNDS, sorry. In terms of the adjustments, these adjustments that are done in the process, but it would seem that the answer we do have, that we have to see the path to make the final adjustments, to make concrete this process among all entities. Now, I want to bring some challenges, not only bring challenges. We are here in an effort, we have the collective answers. So I will bring some aspects of social control that are very important. First is democratic governance. All of the process of decision has to be participative or being effectively, be it of criticism, constructive criticism, and this is our political collective effort where each one of us is, but in favor of the population. The institutional integration here brings I want to make my my testimony. We've had a process of approaching social control with the SEDIG and also seeking joint solutions and active transparency. So in that sense, we understand that the Committee of Digital Health, Management Committee of Digital Health, has a role to guarantee the public interest in this national strategy. The other is the protection of personal data. The great concern, if you speak to anyone, a counselor, there is always a concern about sensitive data. We know, and I've mentioned the Secretary, that the third journey of data protection for social control, it demonstrates the political commitment of the federal government in seeking the alternatives for that security, but it is something that is set of different facts. I'm a pharmacist, and something we see a lot is the issue of using data in pharmacies. This is a day-to-day event. Imagine coming to the health sector, and we understand that we have the general law, the National Council of Health. At the end of the pandemic, and with productions, it's here available to each one of you, but to see that in fact that the general law data protection can guarantee the security for users, but the protagonism that is up to those managers and the monitoring of the social control part. And in terms of sovereignty and data, in this aspect, to share with you a concern in this sense. Brazil produces important public policies. Here I want to talk about science, technology, innovation, and especially talking with the proximity with this, and that in our comprehension, it's one of the indispensable things to have. But beyond that, and this morning, we had an excellent panel in the morning. We have other policies built in Brazil with protagonism, with social control, like health surveillance, basic health. And these are policies that work in the day-to-day of people, and they have to have coordination so that we can have advances. And the public infrastructure of data. So in that sense, we understand that the single health system is our response to the movement of this process. And here, getting to the end of my speech, we understand that we have some paths to a sovereign in terms of digital health. The first, which we took some risk, is to think as a state policy. I think this is something we can think with the advance of an important construction, but an investment in qualification. And here I bring it in two perspectives, in the sense of financing that is public financing that is robust, and the qualification to reduce technological dependency, but also for social control of SUS, so that the counselors, independently of the level, are having condition to speak out. In the terms of infrastructure and respecting the autonomy, the security and confidentiality, and innovation, always promoting and with the principles of the directives of the single health system. And sorry for going over, but okay, so, but thank you. Apologies are not due. It was 13 minutes, so it was perfect. It wasn't necessary to apologize. Thank you. I will ask to put the presentation of Anistela, and then we will open for debate, as is the name of the event. So our technical team will put Anistela's presentation, and at the end of the transmission, when we do the closing, we'll give you some numbers, but we've already receiving many positive comments in the social networks. Good afternoon to all. Firstly, I would like to congratulate CONASS for carrying out this event, which is so dear for us. And when I saw the program this morning, I had separated the agenda to be all morning here. Unfortunately, I had an unexpected demand, and then I will be able to follow with the part of the morning. I had support of Patricia. I don't know if she's here. She made a summary of what happened. I'd also like to bring to you to congratulate Deborah for her presentation. I'm happy the council is here together with CONASS. We are coming back from the mission in India. Minister Palgili, with to a series of ministers together with Lula. They're still in mission. They went to Korea, now the United Arab Emirates. And this was central to the agenda, science and technology. but digital health has been strongly in our agenda. We had the opportunity to visit an important hospital in Bangalore, which was from a cardiologist that is a highlight in India. It's a series of 20 hospitals in India and then 12 in the UK. And he found a way through digital transformation to do high complexity cardiology in big scale. So this hospital we visited were 1,000 hospital beds, and it's very complete. He has specialities that complement and close a cycle for a full. And the AI impact that I think is one of the biggest global events. In the opening, they had many chiefs of state, and I like to highlight there was the UN, Mr. Gutierrez, chief head of the UN, and the president of France, Macron. And something that was an axis of the event was this seeking to work in an integrated manner, not competitively, but in cooperative manner, to seek the sovereignty of the countries, but within a perspective of collaboration and thinking about the social impact. So it was in our agenda how to reduce inequalities, reinforce public capabilities. We had a panel dedicated to Brazil, various ministers, each one speaking of their area. Minister Padilha was also part of it. This was a very interesting event and shows that we are in the right path, connected with the tendencies and the most important aspects. Another panel that was of importance highlight, and that was mentioned by Guterres and also others. Big techs were also there, only Meta wasn't. And an issue that was brought forth in an interesting way, strengthening the issue of science in this process. Some of the highlights, the importance of international governance based on science, and not only in the hype, the advance of artificial intelligence. It's moved quicker than our capability of understanding and governing the process. We have to be attentive so that we can seek a shared governance, a practical architecture of cooperation, and this issue of governance guided by science that doesn't stop innovation but gives a direction to this process. And some important dimensions. It's the first time that this global forum in artificial intelligence happens in the global South country. And Gutierrez mentioned that, and the issue of principles and collaborative and equitative access and in computational capability. The issue was discussed, and in terms of production of AI, international transference of data, this is something that Deborah mentioned, and even to highlight by the CEOs of big tech to reinforce the important role of the UN as a space for coordination and governance.
So I believe these are some aspects that weren't here in my presentation, but they are interesting for us to consider. So part of the representations, the opening of the official ceremony is on the internet. So I believe that the Antonio Guterres speech as well as Macron's are very worth it. Those who would like to take a deeper look, it's worthwhile. So I'm going to speak a bit about the federation, which is in our agenda. We've been working with you in that regard. And this was a structuring demand, the federalization, and Paula Xavier, director of DataSUS, would be here also. So I would like to thank our directors, our team. So a perspective for a future look, in order to have a SUS and a connected Brazil, so we should think of having everyone talking the same language. Interoperability is the key word. This is under construction, and I believe that it's in an advanced stage, right? Taking into account the states. So based on the federalization, we start to have the dimension of the three spheres of government, but also the main managers, the health managers, and users as well, with real-time access to data and information, in the sense of having direct access that is continuous, is structured, having autonomy in a health system that is based on analytical capacity. So the discourse of federalization during 2024, 2025, we had a pilot that was built with 8 states at first, with on-site and remote workshops, with modelings, governance models, and methodological adjustments over the process. It was a collective learning, actually. So from 2025, 2026 onwards, we start the step of expanding to the 27 states, continuing with the remote and on-site workshops with scenarios, consolidation of working plans, and so on and so forth. And also concerning the legal aspects, we were able to understand more and more, advanced, gain grounds, and have a solid basis for this data sharing in terms of commitment in this sense. I would like to say that in addition to the third journey of data protection that was done in February, March, we're going to start March 11, we're going to start in partnership with the Institutional Security Cabinet and the Secretariat of Cybernetics and Data Protection. We're going to hold a seminar on the information security and cybersecurity. It's going to be hybrid. It's going to be held online as well, and it's important for everyone to attend. So we hope in 2026 to finish the state step and get to the municipal step in this cumulative continuous expansion to municipalities in the 4 dimensions of the federalization project. So the update of tools and instruments in the responsibility term, with a formal indication of the authorized public authorities to have access to data, there should be an institutional commitment in the secure use of data, so people will have an understanding into what means having a password and a double factor authentication, multiple factor authentication, and we take into account security, because this is a something carried out by the set of actors engaged. So a rupture in one of the parts will jeopardize the whole work. So this is important to have traceability and auditing, and the individual term that is signed by each agent, the administrative, legal, and objective commitments, and all this basis consolidating the decree 10,046 from 2019, data governance, and in the law 13,709 for the general protection of data. So there's a learning in terms of federalization has an approach that has four pillars in order to build this intersectoral articulation between the different state departments. The first domain is an institutional one, so new institutional models will be here. Many health departments are creating their AT divisions in a more strategic way to come up with better public policy. So the domain of governance here, the competence and the management spheres in order to be able to support the implementation of federalization, the domain of informatics, that is data science, everything integrated in a single site, and the domain of communication strategies to achieve a wider audience and the other managers of the other policies, health professionals, and users as a whole, healthcare users and professionals. So taking into account this collaborative process, there was a initial moment of concept proof, technical visits, planning, workshop. Then there is a deepening with the four domains and workshops till the phase of consolidation with working plans and getting to the access of raw data coming from the national network of healthcare data. We had 3 on-site meetings in the pilot phase, then bilateral agenda remotely with all 5 meetings online to deepen the theme and bilateral ones with all the states. And in the national step, we have scheduled 3 workshops. We're going to have 1 workshop in Belém, Information and Informatics, the introduction of the agenda with the domain communication. Then we're going to have a workshop in Curitiba in April, and another one in Brasilia in July with the consolidation of the working plans that have been elaborated. So this is a little bit what is proposed for federalization. And in order not to take too long, I'm going to stop here. I had another presentation, but it's a results presentation, something we already did. So I think that we can stop here so that we can have Q&A at the end as well. So thank you. Thank you very much. That was very strict, and we have the online presence of Dr. Paula Xavier as well. And then if you'd like to say something or leave it to the debate, that's up to you, Dr. Paula.
Vocês estão me ouvindo?
Can you hear me? Yes, we can hear you. There's some noise, but we're going to correct
Muito
this.
obrigada, Felipe.
Okay, very
Boa
well.
tarde
Thank you
a
very
todos.
much, Felipe. Good afternoon,
Parabéns
everyone.
não pela apresentação, né, mas na verdade pela decisão de na sua
Congrats
gestão seguir com esse projeto
for
importante, né, que é
continue with this project, so
Quero
important
dizer
project,
que
federalization one. I would like to say that in the next meeting that will take place in the state of Pará, we're going to have a specific moment for the federation, so we will concretize these access and these federate management of the data. We're going to announce this. And I would like to say that I see this federalization project as an opportunity not only to not be so focused on the data access issue that was the main point, of course, and we were able to achieve it, but in the confirmation of a network of collaboration between states, municipalities, and the ministries for all the field of digital health. We've seen this, and it's been something that we raise a lot, the federalization, the effect of being together in this process. So we see how much exchange we have had in terms of federative agents, and I believe that we can potentiate this even more. So I think, for example, with this incorporation of five and the different languages, the competence in the states. So why not new informational models that can really be a national benchmark, could come from any regional entity, from a state or municipality. So the possibilities would be infinite. And because together we do things better and we go further. Just to thank for the space and congratulate all of you. So we thank you, and if you can still stay here with us, we would be honored with your presence. I am going to turn it over to Diana, representative of CONASEMS, while the team puts up the presentation. You can already take the microphone. Okay, good afternoon, everyone. I would like to thank Deborah with these social controls, so important for all this discussion, Felipe Neirão for the invitation, Jurandir, the state secretariats, colleagues from the different state health departments. I would like to thank my working group of digital health, CONSEMS, and all the municipal secretaries, because we advertise this to many, so we have reports of many of them working, Stella, Paulo, all the secretaries, and all the technicians, the team of the Ministry of Health. And I would like to talk a bit about the municipal perspective, about the perspective of digital health. This is a main challenge where the working process that takes place with the states. And we believe that we have important things because the primary attention is municipal, so we have to coordinate the care and need demands information. So we must have this topic here that Felipe gave me. This is very complex, but I am trying to be very simple and straightforward here to talk about it. So our objective here is to discuss a little bit the municipal perspective here. And to do that, I am going to follow this. We're going to talk about digital health, the logics of the organization in the country, municipal definitions in the national scenario, where we've gotten to, as Deborah says, we've advanced a lot. Where we want to get, we still have to advance in some aspects, and how we're going to do so that the municipalities can get there. Well, in Brazil, digital health, I always like to say that because we can exemplify the logics of things. We have a national policy of health IT. I think some people have seen this slide more than once.
Recording in progress.
Princípios e diretrizes norteadoras para o uso de tecnologia da informação e comunicação em todo o sistema de saúde brasileiro. Nessa lógica, para que uma política seja efetivamente operacionalizada, a gente precisa de um plano de ação. E esse plano de ação internacionalmente é chamado de estratégia de saúde digital. Já foi chamada de estratégia de e-saúde, né, e-health, e atualmente é chamada de estratégia de saúde digital. Então, ela é o quê? Essencialmente um plano de ação com as ações nacionais de saúde digital e diretrizes para os planos de ação das demais esferas. E também um plano de monitoramento e avaliação, para saber se a gente está ou não atingindo essas ações, né? Conseguindo concretizar essas ações. No governo federal, assim como nos governos estaduais e municipais, nós temos programas, né, que fazem a efetiva alocação de recursos para a implementação das ações que a gente planeja, né? No governo federal, a gente tem exemplos, né, do programa SUS Digital, Informatiza PS, que já foi até revogado, mas trouxe aí um volume de informatização muito importante para a atenção primária. Abaixo, a gente pode dizer assim, nós temos os grandes mecanismos que fazem todo o ecossistema funcionar, né? A gente tem no Brasil a Rede Nacional de Dados em Saúde, a gente tem as redes estaduais e alguns municípios, poucos, têm redes municipais, e sistemas de base, que são os que dão o corpo para que essas coisas funcionem. E abaixo de tudo isso, a gente tem efetivamente as ações, iniciativas, plataformas e mecanismos de tecnologia da informação e comunicação que dão vida, fazem a saúde digital efetivamente funcionar na prática, no cotidiano do profissional, do cidadão. É um pouco isso. E essa imagem é importante para a gente exemplificar o que a gente vai falar. Bom, no cenário nacional, a gente tem municípios. Olha que maravilha de IA, gente. Se vocês vissem essa apresentação no passado, esse slide, ele não era tão bonito assim. A gente tem um cenário, né, onde 88% dos municípios têm até 50 mil habitantes. Então, dos nossos 5.571 municípios, 88% tem menos de 50 mil habitantes. E quando a gente olha para a vulnerabilidade, a gente tem um perfil bastante dispar de vulnerabilidade social. Estou usando o IVS do IPEA. Especialmente, um destaque importante que a região norte e nordeste é a que conta com o maior número de municípios, percentualmente, né? A maior proporção de municípios em situação de alta ou muito alta vulnerabilidade. A região sul e sudeste, o contrário, né? Maior percentual em baixa ou muito baixa vulnerabilidade. Então, esse é o cenário que a gente lida quando a gente fala de municípios. E a gente tem um desafio que é conseguir estabelecer consensos. E os consensos, quando eu falo do papel que eu ocupo, ele precisa ser feito com 5.571 municípios numa lógica distribuída em 26 COSENs. E essa visão precisa ser discutida. A visão que eu recebo a partir dos COSENs, desses 5.571 municípios, eu preciso aqui dialogar com o CONASS, com o Ministério da Saúde, a gente conseguir estabelecer consensos para aquilo que a gente está pensando, planejando, idealizando, possa efetivamente ser implementado e consiga chegar na ponta, no cidadão, no profissional de saúde, que é quem efetivamente recebe as ações de saúde digital que a gente pensa. Buscar consensos, eu vou pular essa parte, mas é meio trivial. A gente tem uma lei, né, a Lei 8080, no seu artigo 14A, estabelece as comissões intergestores como espaço para negociação, sempre que isso afetem aspectos operacionais, financeiros e administrativos da gestão compartilhada. Então, todo marco normativo que a gente discute em âmbito nacional, estadual, precisa dessa discussão, precisa de conseguir estabelecer esses consensos. E estabelecer esses consensos é uma parte muito importante, muito cara, porque quando a gente tem uma estrutura muito complexa, né, de governança para chegar com as nossas decisões. Eu não vou entrar no detalhe, mas a gente tem grupos de trabalho para discutir todos os temas que a gente fala aqui da saúde digital, um grupo específico onde a gente conversa, dialoga e leva o que foi discutido para os COSENs, e todos esses grupos estão ali paralelos à Comissão Intergestores Tripartite e à sua organização. A gente tenta sempre levar uma visão daquilo que é o coletivo dos 5.570 para a gente conseguir estabelecer esses consensos. E com isso, né, com estabelecer esses consensos, chegar numa política nacional de informação e informática em saúde, chegar numa estratégia de saúde digital, chegar em programas federais que apoiam a gestão municipal, nós conseguimos avançar muito, né? A gente tem hoje uma plataforma de interoperabilidade que funciona para aquilo que a gente precisa trocar de informação entre os pontos de atenção. E a gente tem, eu vou citar só dois exemplos, que são aqueles que impactam mais diretamente nos municípios. A gente tem uma atenção primária aí com um tamanho absurdo, são 55 mil estabelecimentos, mais de 15 mil equipes, 1 milhão e 100 profissionais e 95% de informatização. Informatização com uso de prontuário eletrônico. Isso num país do tamanho do nosso, é um feito histórico. Então, dado toda essa negociação, essa discussão que fazemos até hoje, chegamos nisso, que é algo muito importante e impactante para o país. Temos ainda coisas a avançar que eu vou falar aqui, né? E precisamos avançar porque temos muito o que fazer com essa figura. Eu quero dizer que não é o SUSA PS, não é. Nós precisamos alcançar a interoperabilidade plena, né? Acho que é um grande desafio para todos nós, tripartite, uma coisa que impacta absurdamente no processo de trabalho do
This
profissional de
impacts
saúde,
very much
porque a partir do meu
upon the work of health professionals, and from those electronic health
eu
records
consiga efetivamente
that I can effectively execute all of the actions without having to change screen or to fill out a form or someone to type somewhere else, transcribing that form. An example that is very simple, but the message is we need to interoperate everything so that we can reduce the load of work of our professionals and to be able to give citizens a more adequate information, the vigilance and not just administrative data, a data that is effectively focused on the citizen. I have a journey. The secretary has seen this slide. In a way, artificial intelligence improves everything I do. We have a desire. I was talking with Luciana in combating cancer, and the desire has been expressed for 3 years before the policy. It's like a dream that interoperability allows us, that a person, a woman in this case, of a cancer in the uterus case, might have a happy end with technology and IT giving her support, where she just schedules online through the ISUs. Then she can have primary care and this help. If there's maybe a, a meeting with a doctor to do the exam, supported in teleregulation, I can do those exams or not. First, I have to send it to a specialist because I'm primary care, because maybe you're describing something that is serious enough that I can take it to primary care, beyond primary care. Then they will do the exam. Being positive, I can work with artificial intelligence to predict the severity. We have a municipality in Manaus with an incredible example using AI. It's open technology. I'm not talking about anything that is private, and we could predict the risk of cancer, and from that risk can do automatic scheduling with a specialist. Having done that, a consultation with a specialist, and they can directly do a request for a surgery. And as soon as the surgery is forecast, the system would alert the citizen. We would have the hospital registry and the follow-up for primary care and sharing of care, and also when if necessary, some teleconsultation. Why not to talk about full interoperability so we can navigate a patient, especially in the case of cancer? I don't, I don't know how strongly we can talk about oncology and these problems. Why not navigate in terms of dealing with someone with cancer, to do it quickly and to get over some bottlenecks? And the way it is now without technology. So how do we think the municipalities will get there? Like I said, these are a set of initiatives that have to be coordinated at the municipal, state, and federal level. But we have a task of the CONASS support to the municipalities, something I'd like to present to everyone. Beyond the working group, we dialogue every 2 weeks with the representatives on the themes that are being debated. We have a set of supporters in the region. We have a sample Brazil, a set of panels, and more CONASS that I will talk a little bit. We have the QR code here. It goes to our site. And in the Mostra Brasil, it gives prizes for a good experiences in all states. It also shows it in the state. They take a set of experiences and also at the national. So I'm going to talk just about the national. In the national, we get to 790 work. These are 14 categories. The 44 works were in the area of digital health. And so it's an expressive volume every year. They have incredible experiences of a sample of policies because you have evidences of the implementation. 5.6% of the samples. That's an important volume because we compete in themes like primary care that are clearly bigger, and it's an expressive volume. And we had at the last one that won prizes. Then we have the CONASS painéis. They do not compete with the panels of demos. The objective is very clear, like you saw here. And we also have how much does it cost? The panel is oriented to the municipal manager. It tells the story of the municipality in data. It is focused. It doesn't have a regional view. It about the technical team and how the municipality is behaving. You're not going to make any kind of tabulation. It's a immediate view, let's say. How is the municipality at this moment? And it has a different logic for this public. So we focus these panels, and this is a very specific public where you have to take a quick decision. You have many tabs, but all of them have a specific view for a quick consolidation, direct panorama of where the municipality is. We have a recent tool of how much does it cost that allows technicians or secretaries to be able to go in and to do a management on their health services. To give them a panorama, you need to implement a new work. How much does that effectively work? Do you have the capability or not of implementing? And that tool with our panels allows us to do so. We have the mechanisms Mais CONASS. It's where we have courses, where we offer, be it for managers or health professionals. And talking about we're training over 40,000 agents. And the Saúde com a gente 400,000 and the Ser Gestor trains many others. This is a massive course with a huge volume of professionals. We have the TV that transmits. They transmit by satellite in a specific channel, as well as by screening and programs available on demand. And in YouTube, I made a filter about digital health. There are many videos here. For Diogo here, there are many colleagues from the Secretary of State talking about the themes and many other different ones. It's a library that's quite vast. I have the book number 8 of the Ser Gestor, which is about information. And to conclude, we need a regional planning. And we bet very much in this, betting in the regional. And we have a movement that is very important. And we have an action plan that we called PASD, which is defining in the process where we recognize the territory, we think about the needs of technology in the region to deal with SUS and surveillance management, and what actions are common that we can share between these municipalities and to implement this transformation. It goes the it follows the directive PNIS and of the digital school. The idea is to strengthen the macro-regional discussion. The plan helps this to happen. And there are many actives here from COSENS having this discussion on digital transformation. And it is important that we have this organizational arrangement that is intermunicipal and with the municipalities, the state, and others, so that it's important to continue have this thinking, how we can jointly implement this and alert to the municipalities. It's important that those actions are in the plan and that they are part of the annual program to give legitimacy and social control of these policies. And I hope we were able to get this discussion. And I'll let my greetings to all of you. Thank you. Thank you very much. I think it was symptomatic to put Belo Horizonte, the Mineiros taking care. And now I'm going to speak myself. I don't know if I presented me. I am Felipe Ferrer, Technical Advisor to CONASS. And this with Manzano, we do, here on my right side, we do the coordination of the Technical Chamber of CONASS that is here present. We have representation of over 20 states, and clearly all of them are watching online as well in our social networks. So while he puts up my presentation, it would be interesting because I will be able to cut some slides. Some of this has already been covered so that we have time for a debate, the CONASS debate. And I will carry out an institutional presentation. CONASS is the National Council of Health Secretaries. So it is the composition of the 27 secretaries. The structure of SUS is tripartite and harmonic, the federal, municipal, and state governments. They are equivalent in the decision-making, and we also have a change from a model that was hierarchical, vertical, to have the primary care as the opening for SUS. And this changes everything. Why? Because when we rethink a health model, we also have to rethink the data model. But we change the structure, but in the digital transformation still hasn't followed up with the consolidation of the health network. And that's part of the problems. Thank you. So we have a structure for decision making that contemplates the municipal, state, and federal. And not all of my slides are in English because I'm also explaining SUS to the world. All those here present know what the SUS is. I just wanted to go one step backwards to show how our health system works. We also have social control at all of those three levels, and the national level with the National Health Council, which honors us with their presence here. We also have a division, 5,771 municipalities, and we have many 120 macro regions to make it easier. Municipalities don't have to do transplants, tomographies. We have to regionalize. Of course, there are many difficulties, and so this articulation, coordination is done with the state bridge and the federal government, and that we expect the whole country to do reduction of diseases, harmonization. So we have the pillars here carried out by the Secretaries in the 70s, that in the Constitution and then became our law, which is the epidemiology as a factor to feed decision making. Then we have our Secretaries. They took the decision in the 80s based on data. Okay, of course, it's from 89, the law. But when I talked about the transition, but still with a hospital focus strategy, I have symptoms. Maybe my heart is I want a cardiologist. So we have to have the family doctor, a basic health team, so that the person can be followed up fully. So the integrality starts with the primary issue, and we have to have access to specialists and to give return to that information to primary care. That's how we designed our health system. Like I said, CONASS comes before SUS. This is Dr. Ajib Jateni, which is the name of the auditorium here. We are representatives as set by law. So we're following rules. We are formal representatives within the federal sphere and CONASEMS as well. These are the secretaries. This is CONASS, but we also have an administrative structure. It might seem we are few, but that's in Brasilia. So therefore, we have 27 representatives and their deputies. So CONASS is the administrative team, technical aid, and the technical chambers. That is 27. So CONASS is everything there. And we are with the state's presence, and these are the chambers. Then we will send these slides in the slide share, and everyone can look at them with some calm. So we go through a process of digital transformation, like it was mentioned here. We go from a process, an analogical process. I have to, in order to have access, and I have to request, and I don't know what's the period, etc. And now we go to something digital, and the result comes out, and the professional can access, I can access myself, I can go to the app, and I have answers that we do not have. This is the impact of artificial intelligence, Internet of Things, to use a watch to monitor those who have some kind of cardiac rhythm problem. It might be expensive, but it'd be more cheaper because maybe they don't have to be hospitalized, or with some kind of vascular accent. So we don't know how to answer these answers yet. We are starting this instrument.
Precisa da transformação digital, acompanhar a transformação de processos. Informatizar, até como disse o Dr. Christian hoje de manhã,
So digitizing it, as Professor Christian said, is not just taking it from the paper to the screen. It has to do with automating and streamlining processes. And in the history of SUS, we had several policies, around 50 national policies. And us from IT, we have to understand and be up to the challenge in terms of national policies. And we do have ours, that is National Health Information and Informatics Policy. And we have to follow up these evolutionary process. And in the beginning, this is an illustration from 2002, but it's very modern because this is in the PAHO situation room course textbook. So here, for example, we have a structure of governance of the healthcare system. This is on the left hand. There is a structure of terms that are forms, there are data banks, and they are still in silos, as Mauricio Barreto has said, but we're trying to integrate them and link them to the taxpayer identification number. And here down below, we have a structure of producing data, decision making for producing data. They are both for production and analytical. It has to be integrated. So our dream is to have a lake of data where everyone can take a swim, go swimming in data. So here I am just mentioning dozens of data banks that historically they're not linked among themselves. These data bank also in terms of notification. You don't have, sometimes people have Hanseníasis, leprosy, but we don't know if they have had tuberculosis, but it's changing. And these repositories, we start to have some integration here. And we are going to integrate to what direction? To what direction should we integrate? So before we were working with data that we call ecological, right? The indicators, denominator, numerator, have an aggregate piece of data per municipality, per health region, per state, and it was disruptive what happened with Tabinet, the interagency network. Several initiatives that were promoting data use, as he has said, we produce a lot of data, but in spite of not being integrated, they have lots of use. And given the intuition and practical use, the society has been claiming, well, you should use this in a smart fashion. And in this national conference, we created the technical chamber, as it has already been mentioned, led by Dr. Deborah and myself here as the CONASS representative, and we have a very interesting composition. But society is already using words like interoperability. This is a difficult word to pronounce, but people are already using that, telehealth and so on and so forth. Also, there are other activisms, as we call it, several actions. So, for example, people, it should work. One of them is the judiciary branch provoking the executive branch, and the judiciary said, oh, let's do, or let's have a national platform so data can be integrated and we can take an integral look, a wholesale look over health, so that the set of the state health secretariats or departments initiatives, are they okay? So the delivery of drugs, for example, it should be on the same patient record, it should be on the same record that is accessible by everyone. So the clinical protocols and so on, it's all should be there. So in October, we had an agreement in the White Hall of the Supreme Court. We have some judges down there, and with the representation of CONASS and CONASEMS. And here we have another engagement that comes from the legislative branch. So the image you see there, the project of law 5,875. There are dozens of bills on digital health. So the legislative branch also tried. They said, well, the executive branch has to mobilize itself. So many of them here are talking about the taxpayer identification number, CPF, as we call it in Portuguese. So this is the index. So this bill was a set of forces joined because this was a way to achieve interoperability among different health players. And I'm going to talk more about that. We have health informatics as a knowledge domain because before we used to put into practice the most general things. Of course, that sanitary study data, many study data, but that's why we have a technical chamber on information and informatics. We have specialties from SUS, and everything has to do with digital health, as we say. So this is the professional healthcare, digital healthcare professional, for example. So we should take into account all that. We have the Brazilian Society and so on and so forth. And there is already a professional profile that the SUS needs, which has to do with management and being in the cabinet of the secretary. Many houses have the chief information officer, that person that works in the managerial level, giving support to the decision making. And we have the three levels: operational, tactical, strategical. So meetings, for example, they go to the operational, as Paula said, fire. Fire is just like the universal language of information systems, English, right? So when we say fire, that's because we want to get to the strategic level and understand how it's going to work. So we have to say fire. This is what we want to say. That's why we have this agreement at the strategic level, so that as Sandro said in his presentation, and Michael has already mentioned, we have two different levels of national governance and these chambers. One working group comes from the tripartite decision-making chamber, and other is the managing committee of digital health. And all countries have that as the national governance of e-health or digital health. And here we have 7 vectors, 7 axes, 7 pillars of our digital health structure. So you can all take a look and read. So it's the first search. And also it was already said, we have the legal framework that culminated in this unique way, the single way of interoperability. So it's the result of this tripartite agreement. And here we come from a tradition of a data federalization. Even if states and municipalities consider that, consolidate that, the Ministry of Health will have access to the last one, and sometimes this piece of data doesn't come back. When we talked about mortality in COVID-19, we had the national data coming from the notari's office. We didn't have the health database, because even if the states had information, we couldn't work with a different one to the national database, which wasn't integrated back then. So here I am close to wrapping up. This is the transparency and access to personal data. Why is it important? Because given one way, we have to ensure the good practices, and of course that the transparency of what is done with the personal data, that will allow data to be used when the assistential contact takes place. But we need more collective science, more open science publications, volume, to use the best piece of data for the best decision making. And Synapse has shared this very well. So how are we going to make available clinical data in a safe way so that it can be used for us to make decisions with our own data? Because we are not using this, as it has already been stated. And here, this is just a provocation. This is our evidence pyramid. It was shared in the morning too. So our evidence pyramid says that in a clinical trial, the experimental trial is above the observational study approach, but nowadays we have AI. We have computer simulations, in silico simulations. So my proposal is to do a star of evidence. So this pyramid of evidence, each country has to find its own because each country has specific digital maturity. As Michael has already shared here, I'm not going to go into details, but we are in the virtuous process of digital transformation, macro-regional plans, and here to influence the municipal plans and everything else in a vortex. And these plans will take to digital maturity that will think of processes, digital culture, digital literacy, and as well as integration interoperability. So softwares can speak to each other. And here, the index of maturity level that I'm going to leave here, several things and so on and so forth. And here we have lots of tools. I have already talked about them. This slide is a synthesis. It sums up everything that was shared. So for SUS transformation, should we change the process or should we digitize to change the process or should we change the process to digitize? So this is the question that we should pose, but having this to collect the data in a best way, this is what we need the most. So I would like to wrap up here. I would like to thank you. I will continue to moderate the table. We're going to open for comments and so on and so forth. And the idea is to come back at 4 p.m., but we still have some time and we can go ahead here. So I'd like to open for the registrations, those who would like to take the floor.
Deilton, se apresente, por favor.
Deilton, introduce yourself, please. Yes, Paul shared that with me. So good afternoon, everyone. I am the Executive Secretary of Information Technology and Health from the Federal District. So we have a question to the Secretary. So if you are taking into account the current political scenario, because given the workshops that we'll do, we have the one in the state of Pará, then we have the one in the state of Curitiba. So in the city of Curitiba, because it will coincide with the political change in the state. So we know that there will be a political change in the country. In the federal district, it will be likewise. So if CEDIG is mapping this so that we won't have any kind of problem during such steps. Anything else? You can, when we get to the end of the afternoon, people get shyer, but we'll pass it over to Stella. She will reply, then Deborah, then Mike, okay? Of course, that if somebody else, Nayara, so please. Yeah. Oh, I would just like to make a remark. Those who work with technology, you are very intelligent, right? Because sometimes our head can't wrap around it. So I think it's a debate. It's important to say that since when we started in the morning, we were able to see so much information, academic information, and now we are on a table that has to do with management. Coming from your presentation that is also academic based, we can see how other debates will also have to take place because the Ministry of Health, for example, was in India right now. So now you can imagine how much technology has envisaged. And while here we are still baby steps in a country that has lots of peculiarities. So I just wanted to seize the opportunity to say that we still have to take deep dives as our colleague from Mato Grosso do Sul said, we have to have this literacy so we can all be on the same page. So I work with several areas because those who are managers have many ends to bring together. So Claudine and Carla, they are the technicians that are on top of it. And to what extent us managers have to take a deep dive, because that's the way forward. So just to leave the table with this comment, I would like to congratulate you just to illustrate how long our road ahead still is.
Diogo, secretário de Estado da Saúde de Santa Catarina. Bem, cumprimentar todos, cumprimentar a secretaria.
I would like to thank everyone. Congrats to CONASS for the event and so on. I agree with Secretary Nayara, and but I always focus on the balance, what is disruptive, and take a look at the weakness we still have in 2026. And I would like to thank her for the maturity and the conditions since 2023, continuing with the with actions that we believe is the right one, and also to correct some situations that were necessary. And also had a talk on the artificial intelligence, because nowadays we see artificial intelligence and how we're going to treat this within our unified health system, SUS. Because nowadays we have some basic things, for example, what is the installed capacity I have available. So I have to say how I can typify that in the registry and so on and so forth. I mean, internal discussions, but the presentations will have a convergence. Of course, we don't discuss the content itself, rather the form. And when we discuss the form, we face some difficulties. And for a long time, we've been focusing on the electronic tool until the time we understood that the pattern was more important than the e-tool that will point out to specific patterns. So we have to understand these advancements. We'll have some state presentations. There are states that are really going forward, and we have to take advantage and share the most in a way, and also in assistance among managers. We lost this a little bit. So in this digital health part, and those who will continue, we should have this very clear and share, because I always tell the team that I belong to that. I am developing something in Santa Catarina. I still can't change that with other states. It's public money. And those who will come from the technical chamber, we should take a look at that, because you are crucial for this continuity, regardless of the management and the political turns. So that's it. So now, yes, I believe that I will turn it over to, so in case you have more comments.
Eu vou fazer esforço para ficar, porque eu quero ouvir, quero ver o que os estados estão fazendo, quero que a gente possa de
It's a
fato
pity because I will make an effort to be here.
apresentar, para falar a verdade. Então, enfim, eu acho que
And I think that maybe we should have solved this with the presentations, and we commented this. The secretaries with IT, I'll leave it as a suggestion for the next opportunity, and not to, and to have. And it's a pity. I had the presentation, but okay. I agree with what Secretary Nayara brings. We need, for the technical work, it's very important. It qualifies the process. But when we sit with the secretariat, with the managers, secretaries, the managers, we have to have an effort of translation, of hearing, and of processing. Not to close in the academic process, so I think, in fact, the travel to India was important, but it was important for many of what, but to reinforce to us what we are doing here is not only correct, but also not as embryonic as we think it was. Of course, we cannot compare the economic power of the big techs and of some countries, but I see an effort in the current government, intersectorial. This was very clear. So you have the Ministry of Science and Technology with the Brazilian Plan for Artificial Intelligence. You have the Ministry of Management and Innovation that has a national strategy for government and for policy, SERPRO and DataPrev, with a government cloud so that we can do our infrastructure, that to have the public data infrastructure. So our connection with authorities and now the National Agency of Data Protection. Now we have a working group talking about the statute for children and teenagers. And so we've sought to be in the forum, the cybersecurity. Do we have a national policy for cybersecurity? We have in the GSI, and we're doing a seminar to go deeper into that. But that which is of the agenda in terms of the SUS, but to bring intersectorial, to give the digital the robustness necessary, and with tranquility, and to build our processes and to move with security in this digital environment. I think we're building these processes, these bridges, and this is important in structuring. I think these actions, health, action, and this digital area needs to set consensus within organized civil society, and I like to highlight of Conselheira Débora's presence here, because everything that is done, new managers, politicians that we serve in a way or another, we are just going through. And we had to hand over every year, 1 year and another, there's an election. And so if we want to do different because of this or that, something's wrong. So while we do this and co-create with the population, with the managers, and these actors that are effectively the actors for which the policy is built, they feel they belong, and that's our part is done. That's what we have to do. When there's an election and there is a management change in management, other decisions can be taken of these actors if these actors are appropriate and adhering to what is being placed, that can have continuity. I have 20 years working with public policies. I've participated in many that survived different governments because they were done with participation and seeking the better good. And I think that is part of the process, is not an exception. Okay, I think that's it. This is what from the question set. And I will stay here for the next panel to be here, the experience of the states. that will make a lot of difference. Thank you. Okay, once more to thank you for the invitation from the National Council of Health. Like I commented, we are summing forces for changes, and that these changes can be collective, and certainly in health, we conquered social control, and I'd like to thank and the whole team and our partnership. I'd like to highlight my comprehension of the importance of Brazil with these travels abroad. Brazil retakes its protagonism in exchange of knowledge and brings to Brazil, I just see it with good eyes of improvement, and I like to, and that there are many manifestations. If the 875, this is one of the law bills that the council has manifested. So I can share it for your knowledge. And in closing, for something I left here because 18th National Council for June of 27. It's a process, and the support of the municipalities and the possibility of free conferences. And why do I bring these? It's not going to overcome the stage of municipality and state and goes to the national. It comes to add more. And these are free conferences by any entity, and the social has been part of these free conferences so that you can think, and it is free, and having this repercussion, I think this goes directly to the national stage of the conference that is upcoming. So I thank you all. I'd like to thank you, all the secretaries, to dialogue a bit with a very pertinent angst from Secretary Nayara. Technology is for human beings. It's not the opposite. And having said that, in terms of digital health strategy, how to make digital health more invisible in the positive aspect. Of course, we need to be protagonists in how solving the technology and that we be remembered how we remember about energy in the sense that we are able to advance of the system, the strategies, so that everything be automatic. We get a cell phone, we do the other. To think about digital, to be transparent and invisible. And we only remember and that the discussion is important in security. And now that it gave problems, And this is an important path.
Nessa transformação digital para a gente conseguir
And to be able to do it in the public system. And I think it's important to talk about Brazilian protagonism. We was always a great producer and many names in many areas of technology. I think we can restart this. I think this is very important to talk about this protagonism in the area of health. So very thank you, so that we have technology for humans. So in the name of CONASS, I thank you very much for the opportunity, and we feel very honored. We will have a break, and we will come back 4 p.m. We have coffee here on the side. We can transmit virtually coffee, and people will fight me. So just one instant, Michael wants to do some merchandising. Just to remember, 12-15 of July, we have our Congress with all open, but just to remember, it's open. Okay, guys, back at 4 p.m.
Boa tarde a todos, todas. Vamos recomeçar.
Recording in progress.
Eu queria convidar
Good afternoon to all. We will restart. I would like to call Secretaries Cláudia Mello from the Secretary of State of Health of Rio de Janeiro, Diogo Demarchi, Secretary of State for Santa Catarina, Nayara Maksud for the state of Amazonas, Razívio dos Reis, Secretary of State for the Health of Goiás, and Diego Dal, Superintendent of Digital Health of the state of Bahia. I hope I got that right. I usually get that wrong. Unfortunately, the participation, Dr. Ari Mateus Reis was going to participate, and he was going to do it by virtual means, but he was called for a meeting by the government of the state. All of the secretaries and I thought it was important to have experience in the Northeast. So we invited Diego to talk about the experience in Bahia. He probably has it from the top of his head. He probably has a presentation. I'm going to pass over to Felipe on how the debate is going to be, how much each can speak. Yeah. We will start with Secretary Nayara from Amazonas, 15 to 20 minutes, but we will, of course, manage it here. Me and Nereu are the moderators, but feel free. The space is yours. Now, so Ms. Nayara Maksud.
Deixa eu só entender como é que passa aqui. Esse aqui é para frente. Eu acho que eu apertei alguma coisa ali. Foi? Não. Tá. Bom, gente, mais uma vez, boa tarde
Well,
para
guys,
todos.
good afternoon once more. I made a presentation very similar in CONASS to show how Amazonas had started to work with digital health, especially in the implementation of a service of telehealth. So this is a general view of there was a division in the Amazon and something I will present here. Every time I present the state of Amazonas, I have to highlight all of the geography of the state. I think each state, each location, especially those that are hearing us and participating virtually, lives in a place that has a peculiarity. The state of the Amazon is the greatest, the federation. It has 62 municipalities, and one great peculiarity is the difference from one point to another of the state. We have distances that go over 30 days. So it is a state in which its logistics is practically rivers and air. They're extreme distances. I'm talking about a region that from Manaus to Tabatinga in one boat and 30 days. So imagine a user from the single health system. For him to be having access to a specialist, he has to go 30 days by boat so that he can have that access. There's still some lack of support in some place, and we're the third state with the less medical distributions of Brazil. So imagine the specialties that are more demanded, and by the profile, we have low demographic. Most of our municipalities are 5 to 6,000 inhabitants and isolated populations. And I like to thank Sandro and talking with the coordinator of Telesaúde, this geolocalization map, this is the map of the Amazon, and this shows, besides the presence of these empties, it shows the concentration of establishments in Manaus. So it always has been this way in the axis of the Amazon, concentration of equipments, of specialists, and of technological density in the capital, Manaus, that has 2,300,000. And in the metropolitan, I can put the red. Well, that's blue circle. That is bigger here. This is Manaus. Manaus has a geographic dimension way smaller than other municipalities, but this is where we concentrate and the greater access to health. The guy who comes from this municipality until here, this is of days, not hours, days. This is the main artery of movement that is through rivers. The management of the Secretary of Health, we have something very positive. We are the team that works together for over 20 years. And I felt this in Rio as well. When I was there, the team thinking of the planning and our team of the state of Amazonas, we said we can't do more of the same. If we don't know of these empties, if we know we have a difficulty in having a that is ideal or close to the ideal, we need alternatives to do so. So much of the history that we have in the state of the Amazon, and I worked many years ago with that, and in the rivers, and of the many different possibilities, we found an alternative of carrying out a program, a big program that brought a decentralization and rapid decentralization.
And this integrated team has also worked in an organization so that we could understand what were the major demands for specialists. And we started like that, what our population needed. We needed to work in the line. We needed to understand if our regulation line was real, if it was having a dialogue with a reality. So we implemented a service of virtual assistant. Nowadays, we have an effective communication with the user, and based on that, we reduced absenteeism and we did an indigenization for you to have an idea. Nowadays, we can understand that the 18 specialties that we implement in telehealth are the ones that really are important. It will have an impact on the waiting time in the line. The second step is when you have a hygienized line. When you have effective communication with the population, we implemented teleconsultation and telediagnosis to amplify access. Many of the tools that we have also implemented in the state of Amazonas through ProAd SUS is interconsultation. So you always need a doctor for the transcription of the prescription and to complement the service of the doctor in the interconsultation. So this work of telehealth is direct consultation with the patient with a technician or a nurse following up. If the primary care doctor can follow up, that's great, but it's not an obligation because the patient will have the medical prescription and examinations, everything from the professional straight in the cell phone. So it won't take away the responsibility and the vinculation of PS because it's in the basic healthcare units that this service is implemented. We didn't take this service to a hospital. We didn't take this service to a poly clinic. No, it's within primary care so that this linkage isn't lost and that it didn't take too long so that the clinician, primary care clinician believes that his patient needs consultation of cardiologist or endocrinologist so that he could follow up and also build with this profession this kind of vinculation. The other work that I would like to show to you, this one I haven't shown yet, and it was very important, and it dialogues with our debate digital CONASS is the AM digital AM health. So it's reduction of access, reduction of waiting time, and now we are doing interoperability of some hospital systems in order to have in the transparency portal of the Secretariat so that we could also have an easy management. It will allow us to understand how the contingency of care is taking place in our units. So first, I would like to share the results of the virtual assistant. We have this service implemented since February 2025. So we have done over 12 million interactions with users in SUS Amazonas. It is through WhatsApp. We have 438,000 registrations that were updated. Patients that died, that changed a phone number, we were able to see if the patient has any possibility of absenteeism because they have two consultations, two examinations at the same time. And this is an important tool to capture people and also to ensure that there is a reduced waiting time through the working telehealth. It was a hyperactive alternative to amplify access in the countryside. So Deborah from the National Health Council, I can't see her from here, but when she opened the table in the morning, the words that the National Health Council used in a moment where reducing inequalities is key, shortening distances, and allowing the service to be implemented in the health sector has an impact over the social. It's a service that we are looking for and then we structured for SUS Amazon. So I have something here. I have a pic at the end, and we'll see. It's a 107-year-old lady having her consultation with the geriatric. So I think she didn't even know that in the countryside of the state, this kind of doctor existed. So for us, this warms our heart because we know that we are treading the right way. Now, telehealth, I think that we're going to listen about several apps, several tools. The state of Amazonas brought this model of technology to be implemented, and this model brought results, but I believe it won't end here. From the moment on that we have the impact of the waiting line and we amplify access, we are going to look for better alternatives. If we work nowadays in such a way that the capture of users follow this regulation system. There are some specialties that we're going to change the model because we have already impacted. So we start working the countryside in a different manner. So we are building other ways and specialties that we have already brought the impact to us. Now it's here our 18 specialties. So we have just placed the endocrinologist and pediatrician here, 93,000 specialized teleconsultations made available over 9 months and a half. So that's a health on your hand. So in the palm of your hand. And also we have implemented the structure of tele rooms in each basic healthcare unit, because this is a reference for us or for any other citizen that still have lots of doubts into how to handle the tools and the apps in order to have access to the doctor. And this is our operationalization, how it takes place. I'm not going to take into details. This is a team that is the central point of all these organizations. This is the regulation team of the Amazonas state that organizes the agenda, the demand that works with the offer, and the team of the state secretariat that works with all the communication with the coordinators and that discuss with each one of them the agenda so that it is close to the reality the citizen needs according to what is being used in primary care. In addition to the tele record, so for example, you have X-ray and many other things in the municipality, and you didn't have this registration. And I remember that years ago, and they were all of them going through ships, and it was going there. So nowadays you have access to the report in all the municipalities of the Amazon. So do we have that? So it's in 24 hours X-ray. So mammography, you have 48 hours. So you have the electrocardio, you have results in 10 minutes. So from the beginning of our work up until now, 107,784 reports of exams, ECG, map, Holter, and so on and so forth. So this is also, we help to take decision in a better way. Now 95 telerooms have already been implemented in the room in 49 municipalities and 24 telerooms implemented in the capital. So digital inclusion with social justice. So it's very important to highlight these in the countryside. We need, just like the capital, so that the citizen has access to that. And here, this is our map with all the telerooms that have been implemented in the state of Amazonas in all the regions. So the impacts of telehealth, so we had an impact of 88% in the offer of cardiology, of 135% in geriatrics, 160% in orthopedics, psychology 108%. So it was a percentage of increasing offer. It was very important for primary attention and impact in the reduction here. So when we implemented the allergists and immunologists, we were judicialized because in the capital of Manaus, you have this professional. So we implemented, we were able to have an impact with an impact in the reduction of the line. And now getting out of the scope of telehealth and everything that I had shown to you. So the state of Amazonas nowadays has a portal, the transparency portal, that monitors the basic healthcare units, that works with the assistance and epidemiological indicators. And our CIEGs and this is having very good fruit. Here, Claudino that coordinates CIEGs and that coordinates the state. And this integration, we have two portals, and the first portal, which is health in real time. All the population will understand. If the population downloads the apps, they know how is in the basic health units and the heat map and everything. So the management at site, it's an internal portal for the Secretariat to make decisions. There are information that we don't have access to, but they are very important because it is being implemented. So when you open the portal, so Claudine, do you think I can already have here?
Tá, abre aí o atendimentos. Aqui, me ouve? Ouve. Tá, na hora do atendimentos, de acordo com
in the part of consultations, we have the time of the consultation of each patient. So we have 12,226 consultations in emergency units. Most of them are primary care profile. You can see over 60% of the patients. So we have different here. What are the top 10 in clinical medical clinics, pediatrics that had more demand with the patients? So waiting time for SPA Alvorada, it's a new SPA we have, so Coroados, and this is the a name that is used. So it's just like UPA. So nowadays we have had 28 births up to now. And here, this is a heat map in the basic healthcare unit. So if the user wants to go in, they want to look for an emergency service where they can have better attention so that they will have lower waiting time. And this is the attendance for the kind of service attention that is distributed to population and how much each unit has had. So I want to go into the detail here. And here we have surgeries that have been done over the 7 days. So the units that had more surgeries done over the 7 days, and what are the kinds of surgeries that are being done, but now the orthopedic surgeries. So I see here the surgeries of the digestive system. Regulation now. So we are working here a lot in a very strong time, reducing the waiting time. So our work was classifying what is the waiting time in each of the things here. We have 6 to 10 days, 11 to 15 days. And so we have nowadays, for example, I need an echo, for example, in the state health network. How long do you need so that it can take place? 1 to 5 days. And then as an example of different ways, we can see telehealth really helped us a lot in the surgical risks because we work with that, working with tele. So from 6 to 7 days, a rectal sigmoscopy. So up to 7 days, you can do that. 11 to 15 days, you can have a consultation in orthopedic surgery, hips, a consultation in buccomaxillofacial surgery. So this is a radar to help us make a decision. So when it goes from 16 to 30 days, we must understand what was the thing. So the agenda was different. What happened so that the waiting time was increased for a certain thing? This is important and we should take that into account. So let's take a look at hospital beds. So this is our panel. This is our beds dashboard, just the capital of the state, so we operationalize that regardless of the patient record that is used in that unit. So there are units that work with specific models. They don't have the same system as the direct administration agency, but we operationalized and we can see all of them. So it's a panel, a dashboard of bad occupation. It's important for the regulation system because regulation nowadays, even if it monitors, it has a real time how the bed in hostels are being occupied, and then they will organize their demands, inter-hostel transfers, and there is a partnership with SAMU because SAMU is not a state, so that they can also work in that line of action. Okay. Something that's very important for us, traffic accidents victims, for example, we've mapped out in real time the number of accidents and the places in cities. So up to now, we have had 40 victims of traffic accidents, what the reasons were for the accidents, what are the places where we have more victims, and the hostel admissions, what was the peak in traffic accidents. So what have we seen? That this is not the profile of the user that is under the influence of alcohol or coming from a party. It's rather the worker. When we see it's either very early in the morning or during lunchtime, where you see more motorbikers, for example, delivering iFood and this kind of things. Okay, so we can leave this part. These are some examples in addition to the state of Amazonas, so you can leave the panel here. In addition to Amazonas nowadays, to be able to advance in technology and access to the countryside of the state, nowadays we are working more and more interoperability of our systems. So the management to inform better decision making, and I haven't opened the one from the surveillance, but they talk to us and the main notification things. So surveillance has a delay that is a bit different from ours. It's very important in this seasonal period for the state of Amazonas, where we also monitor the acute respiratory syndrome so that we can analyze how it has taken place over the last 7 days, if there was an increase in notifications.
Okay, do we have the time? Okay, it's part of it. So there was a strategic impact of the interiorization of the access to do more and more, to qualify, to get to know the strategies from all the states that retrofeed us, and that we come out of here learning more and more. And once more, I'd like to thank CONASS that is also seeing our presentation from the Ministry of Health for those policies to be implemented. Thank you, Nayara, and to all of your team that you coordinate, marvelous. Now I'd like to hand over to our colleague, Superintendent of Digital Health of the state of Bahia, to do the presentation of the experience of the state of Bahia. Firstly, I'd like to thank the opportunity that is being given to Bahia in the name of our colleagues here, that we acted strongly all of these years. I'd like to thank Jurandir, our Presidenta Tânia, CONASS, that are part of this technical, all the secretaries that are here present, and that represent. Secretary Roberta wasn't able to be here, of India. Bringing innovation to everything. And I brought a presentation. And how digital health happened in Bahia for the level of maturity. And to do, I'm responsible for technology for many years here in the state of Bahia. Digital transformation is not about technology. Digital transformation, it happens from many factors and scenarios. I'm going to talk about some important words. The first scenario we had is this one.
Você consegue dar? Obrigado, Adriano. Dá play, por favor. Conseguiu dar play? Não. Bem, não saiu. Qual era o cenário inicial? É a síndrome
So
de
what was the
Gabriela.
initial scenario? Is the symptom of Gabriela. You probably know this expression. This is Doutora Ana Beatriz. She's a psychiatrist. I was born like this. It has always been like that, so it will always continue. And that was the symptom that we had in Bahia. Everything was extremely physical, analogical, and symptoms of Gabriela. We didn't have the perception that we had to change. So first, digital transformation, we brought 3 pillars about people, culture, and purpose. Many purposes. So we need to deconstruct the format that was being carried out through these pillars to build a new format. And what is innovation about digital health? Innovation is to experiment, to learn, and transform with a little bit of creativity to innovate. And then I brought what would be the scenarios that, differently from the other secretariats, the digital transformation in 2014, it caught fire or due to lack of structure, and we lost the whole building. So we had to have infrastructure remodeling. So what was the infrastructure? This was our technology infrastructure. We had this scenario, and this was the standards. So we weren't able, it was kind of strange for us that we're arriving. So the first question, how is it in the units? We had almost 50 units. So the units were by people on the ground. There weren't beds, it was an adequate structure due to systemic structure and a non-coordinated flow. That was the standard, and I visited all of them. And the system at the time, these were the systems we had at the time. This was the standard, just paper. So all of our units, they had health records and paper. Everything was done through these documents. So that was our reality. And the first thing was to have a classroom for technology. And through that, we had 6 people working, and we were able to improve. And we brought the structure to occupy the space. And with technology, we went from a place where you had a computer to start to build a technological building that united the building. And the greatest deficiency, and even from federal agencies, was the pulverization of technologies. And to have CDG, and in the future, allow me, but this has to be the conducting sphere of our technology, as well as in the technological areas. We had to improve. We thought about a planning of a building that had all the technology so that we could unify, so that we could have these two agencies working, so we could deliver quicker the data. And this was pre-pandemic, but nothing like this is done without technological investment. I will show you until 2024. It was R$ 1 million, the budget is not very different. R$ 1 million was a lot of fighting. You had so many computers missing. Those 8,000 computers broken of around 4,000 reais. So I understand is over 30 million, and we had way less. This is just for computers, and we're not talking only about computers. We had 80 million investment. We had the first agreement with the ministry, so we could increase interoperability and also the free electronic health record. Technology, you can only do with investments. Until December of last year, we invested 118 million, and we have 280 million for this year for technology in the state of Bahia. With that, we inaugurated the building pre-pandemic, 2 days before the COVID case, and it was complex. And we ingratiated, and we didn't have this format yet. And based on public, we went to China to get to know. We had a command and control integrated center for health, and in that, we built the monitoring of all the health, the infrastructure, the technology, and now we've improved. Now we know it's important to have a multiplicity of professionals, epidemiology from health and others. We do this routinely so we can monitor the indicators, and of course, of CS, which we called CIS. And we transformed all of our units, still without the reform. And the results with investments in 130 systems, I could talk all day long about this. 40 equipment, many systems and banks. And we have to think about and infrastructure is not cheap. Everybody thinks it's just that. It's putting a computer to make telehealth. It's 5,000. I put a link, and that's it. It's working. It's not that. The computer is one of the parts, so we can have a technological infrastructure, so we can deliver and have digital health. It's a big investment. It's many items for that to work. An example of a hospital ward, we have 341,000. It's a switch, a printer, and others. So you need a lot of investment. It's not cheap. So in our timeline, until 2026, we develop all of this quantity of systems together with the state, with the interoperability. It's nothing more than the free software without profit seeking, done in communities with the object, so we can do in a community way to prepare the electronic records. So Asia Hose has cooperation with 9 states. Many of them are already doing it. In Bahia, we have many municipalities, almost 180 municipalities. The community and the Ministry of Health came recently into the community and is making potential of these different players of Brazil. And the evolution of Bahia, we come until 2026, and it came to oral units, all of those contemplated by the state, all our polyclinics, our maternities, hospitals. So there are different modules with the health records from point to point that you can manage all of your units. So it is important. Bahia has always carried out this, because when we make available these kind of electronic records, the communities reinforce, everyone wins. If we develop a part like we did here, everybody gets a module, everyone won, as is being developed in telehealth. And with this update, and with the partnership with the Ministry of Health, has been developed this long-dreamed interoperability. We have, and within our records, we had the first unified record. We had specialized units in only one record, a single record, primary care carried out by SUS. So we can see the hedges, bringing all of the registries of those patients, their life, how long, as a specialized attention, as I can all see all of the primary care. So we were able to get, and all of those states that work with this, get it automatically. So what is HEDS? Is the state network of health data, comes from REDS, but that's a marvelous coincidence. Means that we have to create interoperability in some moment in when we were structuring the data, that they be unified. About the regulation, high complexity, we bought some indicators. In the second phase, we integrated assistance, primary care. We brought it in the third, and now we're in the prediction phase, where you can clean all your data. We have 267 clean data. We have many CPFs, 15,620,000 CPFs of patients. This shows our borders being fulfilled, and we created with this, all of this data, the CIS, the Integrated Center for Health Intelligence, and we gave impulse to that. We don't call it CIS, we call it CIS, which we built and fortified even more. And that's the last point. And the one is the expansion of telesaúde. This is a strong point. Secretary Stella was with the president, and we had to give body to that. And with that, we did a complementation in real time for the president to see and make it work. I think the video might not work, but the president, now we have specialists and a specialty and endocrinologist at any municipality. A lady went there, the president went with her, and it was really cool because we built 400 kits of telehealth in 40 municipalities. So that's the next step. Our future is more and more digital and more constant. This is the Digital Health magazine of Bahia. We do the systems, everything published. And everything that you need, everything in the magazine, everything, all of the structure that has been done so that you can replicate what is in Bahia. And in the end, that I left in the last structure, the data do not substitute the care. Greater care, and the future of SUS will not be digital, and to be part of this transformation. And now, thank you, Diego. Now we're going to go to Cláudia Mello. Firstly, I would like to thank for being here. The CONASS, I've been since the first patients were transferred, I think 2017. So this evolution continue to be a spectator of CONASS and a lot of body. Every time I come here with a lot of willingness to learn, with and the experience always in the sense that the services is not only the technology. I'm obstetrician. I've been 25 years there. And like Nayara mentioned, we are here with a team, very old team. I went to 2021 and all my life I've been following up management and superintendency. And in that phase in 2019 was very critical moment. We had a blackout of technology, but in 2019, there were 3 people that were sent away, and we didn't even have email. And March 29, we didn't have email, we didn't have a site, we didn't have anything. And there was a construction at the time and came back bit by bit. And we had a new management. I was from the surveillance since 2021. And in each phase with the group, that's why Nayara, a group that was very homogeneous, and surveillance, and about the commitment with civil servants, as must be. And then we went through many different phases. I saw the reports connected to nothing, and I saw the repetitive manual, and we had scenarios, and we went for a while during the pandemic. And we had the COVID in how to do.
Up until 2020, 2021, so we didn't have much of a connection, and then we started to work with the University Department of Statistics, and we were able to work. So we thank CONASS and universities to be able to have this assessment and report for surveillance. And within our headquarters in Rio de Janeiro, I was a subsecretary. We had the first case in Rio on the Excel sheet. So everyone participated in each step. And we had the first panel. So the first panel was to understand what we were going to do in this phase. So it happened in 2020. It was a single dashboard. We didn't have any other on any other kind of data. We had just the Excel sheet. Data from surveillance was very good, but everything on paper. And we had this challenge of how to work with assistance. And then we started to assess day by day. And then, of course, we work with precision, data, and lots of transpiration. So it was very timely because we had to work with the surveillance data. So it wasn't coming. So we were working with quarterly data. Now it was daily data during the pandemics. And in this restructuring, we had to have this literacy, a restructuring of people. And that's why in 2020, 2021, we had this radical change in terms of scenario mapping. And then I was listening to our IT team, and they were giving their insight and chiming in as well, because no one wanted to come just to insert data, to key in data. Where is my mouse? My mouse broke, for example. People didn't care much because there was a radical change in culture. It wasn't just equipment, it was implementing data, implementing a technology that we hadn't seen before. So we were able to have teams, and we structured everything. During 20 years, we were in an environment where we had very bad structure for 20 years. It was just having issues, and then we have a new environment, so everyone in Rio could get to see. We were able to go to a different space. We were able to have everyone in the same space, and we have this new space, and we start to see how we're going to protect the data we have. So we have implemented the LGPD. There's an important data there as well. Internal meetings with different groups, meetings with the internal team as well, because it was a paradigm shift actually. So it was a change in terms of each file on each table couldn't be my file, my norm. No, we have to multiply and understand that it was made to be shared. Along these lines, we were able to provide guidelines to the different processes that were mapped out. We were able to have more policies of privacy, information security, and cookies, because we understood we had many weaknesses to face many things, and we thought that everything was right. But with each movement, each updating, we saw that we had lots to do still, but LGPD came to allow us to face new challenges, to get organized internally and work with the new challenges we had in order to organize all this. So we also have the structuring of data and the technological data. So Leonardo also, it was very important because there is an area of coordination and health. We had the startup challenge, 100 startups registered to be with us, and there were 5 big axes. So rare disease there, which is the uh, autistic spectrum disorder. So in terms of regulation for screening, no one showed up. We had another one on line priorities and oncology, one on cancer. So 4, except the line priority, they are all available. And in case of any product disease there, we can have any kind of innovation. And then we also had many actions with the Federal University of Rio de Janeiro that was able to participate in the election of startups and so on, so that we can have the best results. It was all restructuring. So this restructuring was very, very important in terms of literacy, maturity, to change our mindset, not only internally, but also new people coming to our service. Now, in the digital field, I should talk about sanitary surveillance, but I have been there since 2000, right? And we had things to take note, we had the norm, we were able to implement this the digital transformation as a whole. Nowadays, we have all the tablets and all the itineraries. We had 50% of time gains in terms of response time. And then we had 1,400 establishments that were reached out by us. This allows us to give sustainability to what we produce. So getting there and putting up a paid software and leave it. Otherwise, it was in 2014 when we had a huge financial crisis in the States. So this happens. So this sanitary surveillance was a very important for everyone, and for myself, it was very important for me considering the system as a whole. So operational gains were reduced by 50% the inspection average time. So now everything is 100% digital and there is a roadmap for the norm. So for example, one person says one thing, the other says another, but with this roadmap on our hand, we have more harmony among the team and sustainability as well. We used to spend 1.7 tons of paper per year, and now we are saving this. So this is sustainability in terms of legacy and financial as well. Now, digital tool in times of dengue. So the surveillance has a huge network and the Intel Center. But back then, in 2024, we had these. It seems that we won't have an epidemic in Rio this year, but there was a need in the gateway to UPAs and the other basic health units, the model that was published. We used to have our roadmap and our summaries, but the doctors that were there on the end point, they needed something that was going to facilitate their understanding of how to classify the disease. So we had this digital tool for risk classification, and it was a success because we were speeding up processes at the entrance gate, and it was an important tool, and also the information technology tools as a whole. We have the first robotics of the state here in the hospital Pedro Ernesto. It's a university in Rio de Janeiro. We have precision in surgery. We invest in heavy technology and also light technology like virtual Googles here in hospital Ricardo Cruz. We use that for physiotherapy. So health can have different slopes, different approaches for technology to help, thus providing gains in surveillance as a whole. Now, brain in operation, it is our center of intelligence in health. So it is divided into CIEVs, which is surveillance, and the state regulation. We have a database of with the labs. So we migrate data, the results coming straight, and assistance. So we need 1 minute video. If you could share that. This is a short video, 1 minute video. Let's see if it runs. I think this is a short video. It gathers the most important info to guide the decision-making process. So it aggregates information from all over the country. It allows for the best use of resources. And now we're able to have the regulations. So each was in a specific panel and making it happen. Now, in terms of surveillance, both regulation, we have this panel, the QR code, and that's our page for surveillance. And this is a new area that's been open now. So we're able to have here innovation at each moment of an outbreak or an epidemic. We have here temporary phase, and then we aggregate this as information. So for the national surveillance system, we have each tab for the population and the worker. We then will see some of the faces we have. So here we have a movement in this monitor. It's open to the population as a whole, and the prioritization of each municipality to consider themselves into data. We know that some municipalities have a wide range of digital options, 16 million people on average in our state, with 6 million in the capital. So the capital may work alone, but the smaller municipalities need our assistance to see themselves in the daily life, classification of any epidemics, and so on and so forth. Here are some of the panels of the dashboards that we have that are fixed. So the rumors, hearsay, surveillance. So it was just an email, but now we classify all the rumors all over the world, and they are classified if they are true or not. So with a word cloud, we can capture and see a notification, or before a notification, we can capture any kind of information that would be important for us. So here we did that for meningitis. There was information coming from the ground. So we map rumors from all over the world, and each of our municipality to real-time rains. This is very important. The state of Rio de Janeiro, for example, we know how floods can be very devastating, and then this is important because will allow us to go to the field if needed. The extreme heat, for example, is important. November 2024, we identified extreme heat, and then it led to lots of deaths. So we monitor since then this movement and everything that we consider. We have here in the capital and other 14 all over the state, and given our UPAs that are strategically located, we can understand all this and organize our response at each step before the event takes place. So in the state regulation system, concentrates on that all the items in the state regulation. We have an important action in the municipalities. Some areas are regulated by the capital, but there is here all the high complexity, all the initial access is made up of the different things that are here. So there is a tele consultancy within the regulation. So the clinician, for example, or the unit, when it includes the patient can be here, all the reports as well as all the images, the patient, the history, our record, and it may help in terms of teleconsultancy would help conformity because any information that may be missing can be completed, and patients will have access to sufficient resources to each step. This is the virtual assistant Serena. It was inaugurated in April 2025. So she's got less than a year, and then we can have a virtual assistant that speaks to the external public so that population understands how regulation is made, and for the internal public too. And let's see if we can have a quick video on it.
ela começou a falar, de vez em quando ela põe uma roupa do Outubro Rosa, ela põe uma roupa do
She
Carnaval.
started to speak, and then she uses pink October or a carnival costume to call attention. So here in the next step, so this is more agile, so it informs who's going to see that, where to see its position on the line. So we had all the lines transparent concerning the time and the prosecutor's office in the state of Rio de Janeiro can also follow up on that. So there is the user dashboard so that they can understand step by step. And then we also have in the user panel a bit of how to work at each step of the artificial intelligence, how they will have access to the area and the space where they will be able to locate themselves.
Então, a gente começa também um absenteísmo com a IA. A gente fez grande trabalho de rede social.
We had a big social media work also to understand this reorganization of the data in the municipalities with the inclusion of several contacts we had here, phone numbers. So we had to do this movement with the municipalities. And then we have this to help how the user would be able to have that and put the cell phone there in each of the action that they're doing. And we had this new information with 43% less. So absenteeism is a national problem, not only Rio de Janeiro, but nowadays we have 43%. Now we have 16% of reduction in lines given the support by Serena, and people are looking for better information and they can act accordingly. So she started to send WhatsApp messages too. So we told population that the state regulation system was sending to people direct messages before. It used to be seen as fake news, but since November 2025, information has been sent to the users. So 516,000 messages. So we have an assessment of 10 days before consultation, 2 days before, to confirm the consultation with the user so that they understand where the hostel is, where the consultation is. The success rate is 92.6% of information be exchanged with users. So if there is, for example, an information on the examination colonoscopy, for example, so there on our page, we can share what the preparation for that procedure is so we can monitor the entrance of data, for example, as well as how to get to the last examination, because it's better than going there for nothing. So it's important to prepare the population for the consultation. And then we see that in the social media, we did that a lot in order to disseminate Serena, to say that, well, she is our virtual assistant, and then we can use her in the sense of captivating population and understand how the population behaves. We also have an intelligent smart chat bot. I'm not sure if we can put that video or not, but the chat bot is in the sense of, well, the user can ask and can use that patient. That patient can ask, well, can ask for time, an appointment, and the chat bot here will follow our regulation and will inform the person how to use that. So it's a turnover at the endpoint. Sometimes the user doesn't know how to do that, how to insert that data. So this is the chatbot that answers the doubts of this routine.
Gente, o som. A regulação, a redução de absenteísmo, 16% para nós foi uma vitória, porque a gente tinha.
The regulation about 16%. We have 130 due to absenteeism, even with all this movement, with time 50% smaller, procedures were smaller, optimization of and for security. So an integrated future. It's not only technology, it's more and more, but behind all of that technology, it says RJ has a slogan that's very interesting. It's made up by people, that our people are our greatest right. And thank you very much. Thank you, Dr. Cláudia.
Então passo para o Dr. Diogo Demarque,
Okay.
Secretário de Estado da Saúde de Santa Catarina.
Okay, to the Secretary of Santa Catarina, please.
Bom, então passar a palavra para o Dr.
Okay.
Davi dos Reis, Secretário de Estado da Saúde de Goiás.
The Secretary of Goiás, then. Good afternoon to all. I'd like to greet everyone, ladies and gentlemen, those that are remotely. Jurandir, to thank. I'm very honored to be here to bring the experience of Goiás, our electronic health records. We have here in the scenario in 2019 and a scenario with the efficiency and planning and difficulty of access to the full stock of the patients, and in a very fragmented manner. And to put this data in information and in taking decisions so that we could add more value to the users. Just for you to have an idea, in 2019, the budget with Ana Carolina, Tibirisato, but it was 14 million. Now in 2025, we have a budget of around 81 millions for IT, around 500% increase of our original budget, and currently we're the first as the greatest offers of digital services, the only one of implementation. So we are publishing in the language of interoperability. This is important. like Felipe mentioned, we already have the international language and of the interoperation. And so this eases the work with Caiado. We visited New Delhi and also Bangalore. I had been studying Bangalore for quite a while, and their model, it was fantastic, together with Devi Shetty and others, and we heard a lot about the work they were carrying out in their country, in our state. And the hospital and satellites, and the hospital is responsible for the satellite hospitals and their care. So it's an extremely important. Now we have references, but we don't empower to help with those patients. And the hub sometimes receives or not the patients. We leave the patient. We're in a place with less technological density. And sometimes we do it through telehealth or telemedicine. And this is international reference, innovative measures. It has become more and more with some prizes that I will show in the sequence. And in 2025, I mentioned this before, 81 million with a full electronic health record. All people from Goiás can access their health records in the Express portal. They can have all of their history and all of their points of contact they had with the system. Now through CEA, which is Center of Excellence of the University of Goiás, we are also working, and the data of the private labs being annexed, and in tools that contribute to the excellence and in taking decisions. So we invested in some strategic areas due to the issue of infrastructure, modernization of the technology, Wi-Fi in all units, implementation of new servers, improvement of access to the internet, speed, stability, connection, reinforcement of the mechanisms in the issue of the LGPD, and updating of the equipment of the system and interoperability, and also the ISUs, integrated electronic health records, and the result is the recognition of the maturity and the interoperability of the federalization. And one issue, and also working and focus on the citizen. And we trained elderly as well to use the technology, to be able to seek information, to be able to accept a specialized consultation, and then we can set these in an automatized way. In terms of the electronic and the monitoring and those contracts of our organization in quantity and quality. We have 25 hospitals, many private partners, and we can do the monitoring of these contracts. And in terms of collaboration, and we can do this follow-up. And of the integrated health records and their own systems together, and in supplying of medication, registry, together with ministers of the Supreme Court for the issue of integration through the TRF4. We are requesting through the CFM. We also have a unified basis and to give basis for that decision. And if that medication is in fact is necessary and effective, and to know if this responsibility has to be shared or not. If the medication has the effect that they are proposing, of the management, in the terms of collaboration, special data, and being able to identify the patient that hasn't been immunized. And here we're talking about more efficiency of integrated health. I also know the system that was presented here, HIR. We also have the ProSempa. And the Integrative Center for Health of Goiás for the 247 municipalities. We have the Nascer network in Goiás with the reduction of mortality, working with optimum size, since many locations in Brazil, there are many locations that are part, but they are not able, and great amount of maternal death due to bleeding, and that could be avoided. So we can reduce maternal deaths, knowing that 95% of those are avoidable. So it is a priority for us. And then you have the command center, be the own hospitals, the 25 hospitals and polyclinics, and we also have EpiMed, and the use of resources in an adequate manner, and the expected mortality. And we have a big project, Institute for Health Improvement in the Einstein, which we are calling the IHR, which is installation. And we're defining roles and profiles of these hospitals so we can overcome the issue of scale due to the lack of scale. And the only way for us to solve this is through integration in networks. So we heard a lot talking about regionalization, to work with these 120 regions, these macro regions, to bring efficiency to the system, knowing that the greatest cause of spending of the system as a whole is waste. So 30% is waste the issue, which is the issue of scale. This is the one we're calling Mais Cuidado, or more care in English, to help in improving the access and in the definition of the capability we can have. Without data, without information, we can't do this dimensioning. And where we have the panel of women, if it's a cancer that's been inherited, and or if it's sporadic in terms of reducing risk, and a reparation plastic surgery, which reduces in 80 to 85% the chance of their having ovary cancer or mammary cancer, and tuberculosis and asthma. The neonatal identification is very interesting. You have a partnership where we can do the identification of the baby, the mother, so that there is no exchange or kidnapping of kids. And the program Look to the Future with a state project with all of the schools, over 500, doing retina exams, and we will send these to do all of these exams. And with electronic health records, all of these kids, all of that information goes to the electronic record, and it integrates the hospital management system, so we can have all of these informations. Here is the issue of the command center, which I mentioned. Innovation, we're working with issues that are predictive, and we want to incorporate artificial intelligence that we are using in a prescriptive manner. Some issues in terms 4,000 hospital beds we have in the state and in the hospital, where we notice if they have chances of overcrowding, we have actions so that we can avoid this overcrowding. So we have predictive, but it says what the manager has to do for that hospital not to overcrowd, because we know this is one of the great ills that we have, not only in Brazil, it's an international. Sometimes 12 hours waiting, and he ends up being 4 to 7 days more in the hospital, and mortality can increase just because he is in an inadequate environment. So it's not about statics. Overcrowding is a big ill that has to be fought, and we've done a lot against it so that they're not waiting in the corridors, not to make natural this issue, and to accept that that is the reality.
So we have an increase in seasonality, but we have to work with the data to plan ourselves. We know that if there is dengue during summer, I must have some hospital beds to treat them. I can't do the same number of elective divide per 12, and it is equal along all months, because of course I will have seasonal issues, seasonal pressure, and we know there are studies showing that the hospitals, they are more overcrowded in the beginning of the week, and this is where doctors want to operate more. If it gets to Thursday or Friday, the hospital can be much less than it is, because we're going to use it in a different manner than the beginning of the week. So we end up having an overcharge in specific moments, and idleness in other parts. With this number of hospital beds, because we cannot just schedule the hostel beds in the hostel to cushion the seasonality we have, or even the changes in the cycles of the week. Here, the partnership with the Einstein Hostel, we are giving capacity building to over 500 professionals, continuous improvement. So we are in the expectation of having 711 virtual beds. We have 4,000 hostel beds. So if we are able, by improving processes, to create 700 virtual beds, so that we can decrease the waiting line and we can improve the use of hostel beds throughout the week, then we can schedule better discharge, priority discharge over the weekend and up until 10 a.m. So if we do that, we can have a very promising results in terms of increasing virtual hostel beds availability. So IPMED here, we were able to have 168 patients given care to in addition. So it has a saving of 3.4 million reais, Brazilian currency, showing that we must go and close the gaps of our waste, because this is very important. So the identification, neonatal identification, we must identify in the labor room, and we have this partnership with the security, the public security department, so that the baby can already come out with the identification document, or they can also have, because some municipalities want the child to be registered in their own locality. But if the child is taken to the hospital, but if many mayors are saying, but hospitals in my city don't give labor assistance, so I won't have new babies. Yeah, but you won't have new deaths, I told him. So 89% of the labor are C cut. So we have this structure to deliver the baby. So we must have the pediatrician, the nurse, and lots of people. And there is this huge spending. We could concentrate resources and do an excellent prenatal, working with the security of the patient, and do this delivery in a place where I have minimum conditions and where I have volume, because by having volume, I can also make sure I have quality, and also the data that we collect can bring this justification. We need these arguments to help us doing this. Portugal did that, concentrated activities and improved everything. So digitization of the patient records. So we have 55 million pages that are digitized. Now you can imagine where we were storing this. Even in the hostels, it can, the rooms where papers were stored can become assistance rooms. So I have 20 years of patient records. They have been converted into digital data. And here, just sharing the cycle, the SIGO, the integrated health of the state of Goiás that I have already mentioned. Our challenge is that, right? Is to have the right patient in the right place, in the right time, with the right quality, with the right cost, and reducing variations. If we see how it varies, for example, the care in our hospitals, it is very big. So there's no point in doing a prostate surgery and having very good results in terms of mortality. No, we also must have results in terms of incontinency, of impotency. So if I don't have volume, I won't have quality. In the femur surgery, for example, there is no point in doing just one and have a good outcome. So it's the set that I do. It must not have many changes because the population can't feel uncertainty in terms of the services that will be given to. So if we reduce variability in the elective surgeries, the variability sometimes is higher than the variability in the urgency services. So this is also a major source of waste that we have. So with SIGU, we've been able to have transparency in regulation. This is very, very important. So population know, even in urgency, what's their position in the line. So I had lots of people, parents, family members, mayors, uh, congressmen saying, and when are you going to admit that person in the hospital? Nowadays, we have a transparency with the public prosecutor's office and with the so that everyone can follow the number of patients I have waiting internally to help also in reducing judicialization. So, for example, we can see that 8:20 in the morning. So I had 793 patients in regulation. 406 were being sent to a hospital bed, but you can see here that it helped us deal with it in the hostels. So we won't ask you to transfer a patient to a hostel if the same resolution capacity than you. So if it is an agreement that you will solve this problem, you can solve it. If you have the condition, you can't ask for referral because even hospitals within the same cluster, for example, sometimes there are transfer from patients to places that wouldn't need this transfer. So here, the qualification of the service, we have SUSI, which is a SUS innovation. That's AI to read papers, graph interpretation, and indicators. It was the ranked first in the ABEPTIC award in Goiás 360. So it's a repository of indicators that I can create. So everyone can create theirs and we can share the indicators and see the kind of different views, the indicators that allow us to have these and extract device conclusions from the data we have available. ANNA, which is the attention to the newly born, and it democratizes information of all data from pregnancy to the baby that has been delivered. So it will be democratized in the ICU so that everyone knows what kind of care that child needs. So we have also been awarded many awards. And here, just this is a short video. Not sure if we can run it because my time is up. If you can play it very briefly.
Desenvolvemos um barramento baseado no padrão internacional HL7. A saúde digital em Goiás dá mais um passo em direção ao futuro. A partir de agora, nós estamos preparados para receber resultados.
Aí, beleza. Bom, aqui só da questão do meu PEP, né, que a gente já
Here, my PEP that we have already touched upon. The translation booth apologizes. There is lots of echo, but we can't hear very well.
A questão do canal saúde, 95% das pessoas de acessibilidade móvel, usa o celular, 97% usa o WhatsApp.
95% of people use cell phones, 97% use WhatsApp. So we have the health channel. So we presented several solutions showing
Só aqui, 129 mil contatos, 2,9 milhões de mensagens e 416 mil interações por gestante que a gente tem na rede Nascer em Goiás. Essa questão das madrinhas que atendem os telefones também, a gente tem uma URA lá com elas. É isso, muito obrigado a todos.
So that's it. Thank you very much, everyone. Thank you very much, Dr. Razivil. Now, finishing our program, we still have the closing, but on this table, the experience of the Santa Catarina State, now the Secretary of Santa Catarina. Good afternoon, everyone. I would like to greet everyone again, my colleagues here on the table. Secretary Jurandir. I would like to congratulate Nereu and Felipe for the organization, everyone who's here today. Now let us give a context over the state. Santa Catarina is a state with a small territory. It's 1% of the national territory. So we have 8,177,000 people, according to the Brazilian Institute of Statistics. So if we see 8.5 million, according to the primary care, and the Brazilian Statistics Institute says that we're going to have 12 million. So either we are decreasing our population or expanding our population. It is due to migration as well. So lots of people from other countries as well coming to our state. So data from the past. So our expansion is not birth and natality. It is migration, actually. Newborns and deaths cancel off each other. So I have a responsibility as a manager. Even if I'm not a secretary within 10 years, I must think of the network from now onwards, because we will face new challenges. Now in Santa Catarina, in specific times, the beginning of the years 2000, when we talk about digital health, according to the context we had, in my understanding, we were stagnant. So when we started out in 2023, the first thing we wanted to do was to understand why we were stagnant, and we lost some time there. So this is a summary of the summer. Of course, there are lots of things, just like our colleagues, but here, given time, and this is really a summary of the Santa Catarina scenario with the issues that we should highlight. I like this figure here, this illustration, because I insist I started in health in 2008. So I was doing this. I was doing everything as an ace. I was having the APAC and the other forms. I was keying all the information in from immunization. And while I understand that the information and database for decision making for the manager is very important, we have to focus on what is beyond what is disruptive. We have to focus on the real world, something that we have on the deep end. So when I joined 2023, the State Health Department, the first thing I did was to try to understand where we were standing, and I was scared with many things, lack of technology updates. The digital tool was under judicial lawsuit, and it's still there. I'm solving this now, and nowadays with the State Health Department that wants to run municipalities instead of just being a partner. So we coordinated the state healthcare network helping strategies. So I have 295 municipalities. What is their scenario? Well, the patient is just one patient that goes to our network, the primary care as well. Santa Catarina has a network of 200 hospitals and 295 municipalities for a lot of people. But most of them are just small hostels and philanthropic hostels. Instead of saying, well, I'm going to close the hostel, you know that it is very difficult to close a hostel. So the idea is to give a vocation and focus on the expansion of the network where it's possible in the high complexity bottlenecks. And for us, it's important the Great Florianopolis, Itajaí, and the western part of the state, the island. And when I see digital health, we take a deep look into these operational planning and assessment services, information and communication technology. We've already mentioned that to the counseling, to the council member here. And in terms of digital health, with some financial support, it was very good in that regard because it forced a regional discussion, macro-regional discussion to understand reality. And we agreed on the idea. We had this debate, this big local debate, and what we can understand from all this is that we must understand the needs, and from the regional, macro-regional perspective in the Santa Catarina state, we were able to do that regardless of the financial resources, what's up, what's not up. So when we talk about telehealth, Dr. Anna will remember, so it was in 2007, if I am, well, I'm not that aware of the different decrees and ordinances. I wasn't aware if it was 30 something, but it's 2000, from 2007, if I'm not mistaken, but Santa Catarina started telehealth in 2005. So it was still before the ordinance from the federal sphere. 35. Oh, okay. So it was 35. I wasn't aware. But we started out on this journey, and it's interesting because we call it STT. It's the telemedicine and telehealth system. And there is a major conceptual thing here, which is telemedicine. Actually, telehealth is an umbrella term, and telemedicine is under it. And today, within our structure, we have a partnership with the university. So I fund this with an agreement I have with the Federal University, and I have the federal support and many employees working with the tools. This is a discussion that we've had for a long time. It was Cristina Calvo, but she left. And there is this, oh, okay.
So we have within this module of this electronic structure, we have many modules. But what is the PACI? What does it have to do with health? I mean, I'm very tired of this ping pong. If the technology doesn't help, doesn't make sense. So it's to make it easier for the patient to do a chemio or anything. Why am I going to wait to launch this or that? I will use the technology. And I've had a problem of an oncology patient. We had to take a municipality to put into the system, but I can't see in the hospital. No, stop everything. When I got back, there was I said, no, stop everything. Is a lack of training. Let's do something. But let's stop making the patient fools. Time is everything when in oncology. So we did it in this module in terms of a virtual consultation, dermatologist. You remember there was a municipality with so many dermatologists. We finished that queue almost, and with patients. And 15 years ago, electrocardiogram, electroencephalography, stomatology, general exams, X-rays that are done in our own unit, polysonography, almost 40 equipments. The patient would, from the extreme west to hospital neurohums to do a polysonography. The issue of support, teleeducation, the part of transport out of the municipalities, and all of these in production, and some still without production or being updated or still being refactored. And then I'll talk a little bit about Conecta and this history, considering the size of the population of Santa Catarina. We had all of these results related to all of this scenario, teleconsultation. We copied sometimes. I was still in COSEMES in Santa Catarina. We copied Rio Grande do Sul because many of them did for some ambulatories. We started with one or two specialties, and it worked out. We had a lot of teleconsultation, but we have a metric of 72 hours, high cost of production, all of that connected to these. So a lot of medical images. Now the system is fully intrinsic, but most of these hospitals are philanthropic. And of direct administration, especially these, the regional hospital, open doors, that hospital that receives everyone, and these images of these hospitals, and of structure of professionals and the municipalities. They can use the system, and they can use that with the tool. And in teleconsultations, we have a evaluation of good, very good, 93%. We have almost 2,000 basic health units. I don't like the metrics about the coverage. I think we look at response time, but of distances to expand the network, and teleconsultation of response in up to 72 hours is 67%. It goes to the private initiative, and we have certain difficulties. And teleconsultation in primary care, almost 50%. The management is in the APS itself, so most would be there. This data, 42% is better than anything. And here, very quickly, Sieges. He was recently in Santa Catarina. I said I wanted to do something like Claudia. I even feel a little bit dizzy. But as we are structuring, it was a good agenda. We started a siege, And the first thing we discussed, you have to have some kind of governance. Otherwise, everybody wants this or that instrument. If I get a Power BI, I can do a panel. Might not look pretty, but I can do it. I have governance, what do we want? And I respect, because this committee is set up by the technology people. They are more enthusiastic about this kind of technology and the culture of monitoring and immersive in processing, and a lot about this culture of working with information and waiting for the problem to advance. And they had a doctorate in the area, analysis of data. We also have to look at the continuity. When we have to continuity with the team. And we did a partnership with Pahom. And it was the way, because to do any kind of procurement, we have to do magic, especially with technology, with OPUS, with everything within the legality. We were able to get more fluidity on the development, homologation, all of them with a very clear logic, not to do it just to do it. And here in CIESH, reformulating to make it more friendly. And here are some examples. We put a lot of information, the panel of planning in many different visions. And that's the basic. While other people are born in Santa Catarina, what do they die? We need to know about but 20% are vascular and systemic. I need to know what is the cause. It's something we talk and talk and talk about, and we end up losing ourselves. We had to know it has the highest suicide rate of the state. I have to have an action, not only Yellow September, but we need to understand why in the Midwest there's more suicide. And if there's some kind of national data, Santa Catarina is way up there. We know there's under notification, but we take it on. And we take of the notification of Santa Catarina to make it in a more assertive manner. The epidemiological data of installed capabilities, like in this example, we had a panel for security for patients that was very cool. And the adverse events, what does the press do? But these people died by mistake. But I want to give transparency. 90%, it's the world is ending. ICUs are to be used, you know? We put this information in a public manner. If there are viruses, other informations that we've been setting up, we have a lot to advance. We are critical. I'm a little bit from the area. I'm also very curious, but also I'm a pain in the ass. And something we're not certain of. I have this thinking and we're trying to launch it internally and looking at this part of systems itself. I was with Diego during the coffee break. In 2023, something that scared me, we had the data source of Santa Catarina. What systems? What the system does? If you start, you have to finish. They do 30 things at the same time. And we did these discussions in the tripartite when we from CONASS. And in the state, it's the same logic, the superintendent change and the secretary and the technology and they started a lot of things but never ended anything. So what is our pain? The first thing, we say that we regulate, but in Santa Catarina, we had a law that talked about transparency, and we tried to regulate. And sometimes we regulate so much. How can I get to this balance? And what did I think? Where is this patient? If the surgery is so important, nobody knew. And there was a system called agenda, or scheduling in Portuguese. The system of the ministry wasn't enough. It authorizes, but it goes into internal processes of the hospital and doesn't have comorbidity. And it has the same one, but it has comorbidity. And Diogo just continued. So within a surgery in a hospital, we mapped, we put the visualization for the hospital, and now we have this in a very strong way. If they aren't prepared, if they're waiting for exam, if their immunological part, these are things that seem simple, but can make a lot of difference in the day-to-day. And these are the ones, a convention that delivered in the same way. They authorize a hospital bed. What happens afterwards? In Santa Catarina, as for elective surgeries, they private pay more. I pay more than the value of those. Otherwise, the philanthropist won't make available. You can, if you ask to block that hospital bed, so we formatted that because the investment is very big and it's a stable version. And the part about transparency, the status, it has the same logic, serves to the society, to the public ministry. We call it the Santa Catarina Network of Data. It doesn't make sense that we have only hospital info. CISAP, that's how it's called. I think we got the basis made for the co-financing of the state, and they mapped it with the primary attention. And now the registry is which we can map connected to the MDS. And we go beyond because there are other information. It is being ratified. I have to do it in the first semester. We thank you for your availability to be of the federalization and in a stable manner. This is the part of observation. The famous Conecta, Santa Catarina. There's a lot of judicialization. We goes to the courts, not only because we fail. Yeah, we fail. We're humans, but there's a lot of access, and we have an organization, and we put it into a platform to have a tool. We have we authorized, and we deal with other states. Like we said before, when a software is developed with public money, we have to share it. It's public money. Doing the part of related to the term 1, 2, 3, 4, or 2 or 3 states. I think in terms of the role that CONASS carried out, not that we want to stop access, but there's a rationality with all of these issues, traceability and logistics in terms of oncology. If we incorporate or not, there will be new technology. It will be an interesting delivery and some internal things. Santa Catarina was at the forefront, but then we had to step back. I didn't allocate a system. I bought a system. I bought a tool. And it has a technology that comes before. What do I do with external control? How am I going to explain that I invested 300 million over many years? We cannot stay with the current technology. What was the name? We had 3 options: to buy ready-made or to update technology that we had bought. So after a lot of fighting, now we'll refracture parts to have the maintenance, the development of junior. So I can go back, and this is my tool. Also for the philanthropic hospitals, there are some that are still only in theory in the paper. And we also call this health in the palm of your hands. This is a prototype in testing phase. And we have a data link, a medication, digitalization, artificial intelligence. I repeat, I want to be together, but I think, and the government didn't put a decree in terms of information, the use of artificial intelligence to pay attention and what can happen. And when we get in ChatGPT and administrative information, those can be private information, and some go to the database. So I understand that they have to be the protagonists in the Ministry of Health, together with the CONASS, to do the best use everything we have in terms of technology, without forgetting having a basic part that we have to advance, because we're in 2026 and we need to use technology. Okay, that's it. Pretty basic summary, and I'm available if anyone wants to talk. Sorry, thank you.
Well, time is against us, but we are still on track. And now I am going to turn over to Secretary Listella that wants to direct to the table a general question. So do we have someone with a straightforward question, or so Dr. Zurandir? I didn't see Jogo. Within this collection of systems you have, I wasn't here, you went out, sorry. So is there some system that can standardize the operation in the hospitals you mentioned for costs? I have a cost system that was based on to 2008, 2009. That was an initiative, I don't remember now. There was an initiative of cost management. Santa Catarina was a pilot, so the team that was there took the idea and used within this hostel platform I have. So the tool is based on that. So I have the cost center and all that. So applied that to all my hostels, and I have a very good piece of data. So I have a publication when I was an adjunct. I compared three models: direct administration. Yes, and the data is very good. So technology is bad, but the rule is very good. So for costs and the discussion of models we have, so sharing these ideas is very good. So the ministry has a tool, I don't remember what the Apura SUS, and it is inside my tools. It's very good to share here as well. Oh, the doctor. So before anything else, I would like to congratulate all of you. The presentations were all great, brilliant, and in all we see your involvement. These your eyes are shining, and so each one of you with your experience and coming from different states with different challenges, but all experiences are really wonderful. So this was very important for me to be here, to be able to see and hear. I am really touched because this is a real dialogue. This is a collective construction. So sometimes we're thinking of stuff in the federal realm, but each one of you in your own way, well, um, we're advancing together. So everything that you show have just shared lots of advances. It's impossible to do everything at the same time. Digital health is just too big, several lines to conduct. And if you work just with systems and not something else, you may be dismantled. And this is an issue. And you can't do everything at the same time. So this is a bit irking, but we see that you all have advances. And what I would like to, the question I would like to make, so it was implicit in all of you, the interoperability with the national health database, but I would like to know the patient record, for example, those who are not using the system, depending on the state, how you're doing this interoperability. And in the hostel case, Bahia showed it is using GHUs. So sometimes it's MV, but Ziva it's the MV, but it is integrated with the OPSs. So how did you solve this issue? And how this has a dialogue with all experts in the cases, for example, that you have your own app. How do you interconnect that with SUS Digital? There are many doubts. I don't know, maybe some of these aspects that I wanted to hear you about. Well, thank you. I think that we could ask the secretaries if you can reply and make your concluding remarks as well. That would be great. Our record in the capital, we have more than one model. We have Salux and others, but we were able to do this interoperation, and now we are moving towards the countryside of the state because it's one hostel in each city. So each municipality in the state of Amazonas has a hostel. Even if you have 5,000 inhabitants, for example, in that municipality, there is a hostel unit there, and we must move forward to the countryside so that we can homogenize the model. What was the last question? Yes. The hospitals don't have the digital record. No, that's why everything that's here is capital. Yeah, it's an opportunity to implement the AGU. It's in our plan. So if we don't scale everything, it is a leap forward. Yes, it fell under our digital SUS plan. So it is there as a proposal. And the other thing that is important to share is has to do with the integrated regulation, and now we have experts. All of our telehealth is also within the flow of OCI, so it's also a dialogue with the elective surgeries, like the case that I shared here, the surgical risk and other examinations. They have these, they are also related. So everything is there as a single planning. Also the municipalities, so they contribute to municipalities that have telehealth and they are able to do OCIs to do that faster. Now concerning the state of Rio de Janeiro, there is the SUS digital and the studies that we're carrying out according to the scenario and maturity. In the capital, we have MV, we have clinics, we have a variety, so we don't have a full interoperability. But one of the goals of this planning with SUS digital is to take to the countryside to try and have this unification. This is an important opportunity because our maturity had a very good reply, so we're able to do this maturity with the municipalities. So we have this possibility of trying to implement it and harmonize with all the states. So lots of municipalities. So we have these implemented this in several places of Rio de Janeiro. According to these places, some regions took a while. So we have the state regulation. So we can do all the assessment. So the state participates, but some regions they took a while in this planning, right? So they are a bit delayed, but all of them. So we are doing this CONASS meeting every month. So all municipalities, we are getting closer to organize and give support, but some municipalities are a bit out of this organization, actually. Well, we are using ISUS APS, MV, SIGO, which is this ProSempa system now with a Fire HL7 also in hostels and private labs, so that we can also have this data there. And from there onwards, we can do all the integration and take all these data to back the patient record. So patient will get all the data also, all the interaction that he had with the healthcare system. We are taking all that into account. Yes. Tibiriçá is here. So there is this interoperability of R10. Yes. So there is data from RNS2 of the interpersonalization. Sorry, but what I wanted to know is whether the data that the patient has a consultation to are data that come from the National Health Data Bank or from different sources. It can come from the national database, but for immunization, it's not enough. So we have to bring together data from ISUS centralizer, for example, to be able to have more data there. So there we have data from MV only, for example, consultations and everything. We have data from primary care, centralizer, and we have immunization data as well. So within our data lake, we can see everything and we can have interoperability with several other systems. So I would also like to thank the Secretaries, Urandir, everyone who's here, and all the colleagues I would like to thank for the learning that we have had. So thank you very much. Well, I will do a counter provocation actually, but just because I insist, doctor, that I understand the question. But the first thing that I always see is, well, I see the tripod, which is the basics, the citizen registry. We gained lots of grounds with using the taxpayer identification number in 2015. President Dilma, we did the first integration with the federal revenue service. So we identified the citizen, right? A person is a person. I had 8 national cards, for example. The second is the registry of professionals, installed capacity, for example. That's why I insist on CONASS. It's not the CONASS technology, but CONASS showing the real world that I have. If I don't have the installed capacity with these logics that still persist in this tool, and the first and the third tripod is the pattern. And here, digital health, for example, in a plan that we have that with the creation of the secretariat, it's very important because as we have published that, we have all the other standards that have been established. I will use everything that I have there. Of course, that it is important, but it's secondary because the pattern is given. What's the difficulty I have nowadays? It has to do with municipalities that don't have technical area to be able to have legitimacy to charge a company that's providing the software, and they say, no, it's the ministry is to blame and they want to deliver, and the data of vaccination and everything won't go to the health network, the health database network. So when we published everything, and we did that in the past, there is no country in the world that we think that everything from Brazil is not good, but there's no country in the world that has this in the scale we have. What we have is so rich. It is a gold mine that we have data from 2013 of primary care. Okay, failures, of course, but it has dictated the rhythm. So other primary care systems can raise the bar because they have been doing that, and companies will try to follow through. So that's why the GAGU logics is crucial, because it will do the same thing that SUS APS did. And then the sky is the limit. So I understand that this is crucial to do things like that. And I request, because not only in terms of federalization, but our routine, it's not only wanting to call the shots, but also different possibilities and partnerships and so on and so forth. So that's how it is going to be made. It is crucial. And to wrap up, and thanking for the opportunity, this is a request, but it's a request in the sense of helping our work, the work of the Secretariat. So everything that we shared in the plans, because there was big efforts, right? So I have the ideal world from the financial point of view, for example, plans to implement patient records from philanthropic hospitals. They say that they don't have money and they will ask for money. But I have the ideal world. I don't have 10, but I have 2. So let's advance. That's the priority of that state, so that we can think of progress beyond the results that are expected in the plan. So I think in a tripodic manner, that's what we have to do the course of time. So thank you for the opportunity. So I'd like to apologize because the governor asked for us coming back from India to create the artificial intelligence policy in Bahia. So we discussed with the Secretariat of Science and Technology. So it was important just to justify my absence. Now, replying to the Secretary, in the state of Bahia, we have advances in interoperability, and the greatest difficulty we have nowadays is the geographical distribution to implement that in the municipalities. It's just like what he says, we need a bit of investment. So municipalities can, of course, have the digital record and softwares, right? So everything would be there made available, but interoperability is there. Today, it's a matter of implementation. So the major requisite that we learned from you actually we have been learning due to the health database network is the hygienization of the data because of the volumetrics of the data we have. But I can't send them in bulk given the standards that we have adopted nationally, and second, given the thing that we have a need to adapt our pattern to the standard that will be established. So for example, the regulation model. So before being discussed, we already had our own model because it was discussed still. So it's a fact that the volume of data I have is much higher or bigger than what I sent. So we have to discuss that in the next step, not to lose the data because it's not hygienized. It doesn't mean it doesn't work. It does. It aggregates, it's a complementary, but maybe it's not necessary now. But we're going to get there. There will be a moment that we will want to know about all the equipment that we buy for a hospital, all the structures that were used, what's the cost of that patient. So we're going to have that real value. So how much is that patient? So how much did that patient cost? So this is important to say, and we are working a lot for this to happen. And I would like to thank the opportunity CONASS gave us to present this and CONASS friends that are always here fighting day and night for us to have digital health greater and greater. So thank you very much. So I would like to thank, and I would like to ask the secretary here to be in the table for the close. So I would like to call Michael from CONASS and everyone else. So we're going to do a very fast closing. So just to really appear there, and then Michael, Stella. This is very informal. We don't have to do that very formally.
Não, assim, é só uma formalidade, porque a gente está aqui simbolizando a tripartite. Tá bom,
This is just symbolic. We are representing a tripartite.
E a câmera tá ali. Só aproveitar a força tripartite, aí
CONASS, I will hand over to Mike, Vice President, then Anistela, and then we can give the last announcements. So in the name of our president, to thank once more for the invitation and to say it was sensational, all these conversations, and we had very positive repercussions. Those who were seeing, sending messages in WhatsApp, and a very informative and free event without many. So thank you a lot. So I'd just like to thank in the name of President Tânia and Stella, having participated in all of this time, all of our colleagues that participated in the organization. When we put this subject, it is fundamental to shake things up because there are people who are still in the time of technology of the computer. No, we're already talking about artificial intelligence. You're focusing what is our mission to fulfill our mission, which is to deliver quality of life, and bless you all. So I would like to thank you all for the invitation, congratulate the Technical Chamber of Health Information of CONASS, Nereu, Ferreri, to extend to the working group of CT. It's always a tripartite building. I think your work has qualified the process as well as these incredible experiences. We have these and we have others, and we see a movement that the country is carrying out as a whole. And this is very cool to see. So I would like to congratulate you all for this day, Jurandir, our guru, and to really congratulate you all. It was a marvelous afternoon. I really liked your presentations. Congratulations to all, and we'll continue. So in the name of CONASS, I would like to thank you all for your presence. A very intense, full day. All of the material, all presentation will be available in the webpage of CONASS. We had 2,000 accesses during the day, but it was more than 2,000 people because we got everything of the secretary. They put it all together to watch it together. So he didn't know he was going to speak out, okay? And just in closing, there is an image that is compared to SUS, is the beetle. It has an architecture that is not made to fly, but it flies. SUS is big, robust, and can, yes, show that we are at a point where we can get a step forward because we have some information and of the use of the users. So the analysis of the situation, the difficulties, the problems, but we already have the clinical data. Yes, we will consolidate, and in the last, we have election every 2 years. I think we have a lot of deliveries of planning and everything that support and the ritualization of SUS. So here are my thanks. All of those that are in the internet, and to wish you all a good night. Thank you very much. I will close here.